Good morning, everyone. Greetings to my attendees, panelists, presenters, and sponsors. I'm Dr. Darrell Daly, Chair of the Acog West Indies. I'm so happy to be with you on this amazing and important day for Acog. Historically, Acog West Indies has hosted their individual scientific meeting successfully for the last 20 plus years. However, this year is different. It's with great pleasure that I welcome you one and all to the inaugural joint meeting between the West Indies and the Argentinian sections of the Acog District 4. Although we have always felt well received, loved, and honored to be a part of Acog, a small part of us could only not help to accept that we were the minorities, as Argentina and West Indies are the only sections of Acog District 4 outside of US jurisdiction. It was one discussion with myself, Pablo, and Gustavo, who are the chair and vice chair of Argentina, over dinner last year, October, at our ADM in Asheville, North Carolina, where we agreed to change this notion, that unity amongst us would not only help to motivate the district, but also Acog on a whole. And a joint scientific meeting could be the stepping stone for same. 8 months later, here we are today, uniting as one under one theme: new times, new minds. The dream at dinner in Asheville has now become a reality. Though virtual, we are confident that we'll be face-to-face next year, and this collaboration will rotate yearly and physically between Argentina and the West Indies. This meeting promises to be not only monumental, but also interesting, educational, and interactive. We have united the regional and international leaders in their respective fields as they tackle topics in office-based, minimal invasive and regenerative gynecology, with additional important obstetric and maternal fetal medicine topics, which will surely stimulate your academic appetite. Our speakers include Dr. Tiffany Watson of Jamaica, Dr. Natalie Medley of Jamaica, Dr. Gregory Lewis of the USA via Jamaica, Professor Samuel Ramswack of Trinidad, Dr. Red Allinsod of the USA, our very own Dr. Pablo Carpintero of Argentina, and last but not least, our Vice Chair of District 4, Dr. Scott Sullivan of the USA. Lastly, we'll have a first, similar to Stump the Professors at Acog National, but geared towards our residents, a case presentation by the West Indies and the Argentinian residents with interactive questions and answers. So sit back, relax, and enjoy our scientific symposium, which has been made possible by our numerous and gracious sponsors. But in order for us to proceed, we must receive the official opening of this meeting from our esteemed, warm leader and chair of Acog District 4, Dr. May Blanchard, who is also the chair of Council of District Chair, Acog National. Dr. Blanchard is currently the Associate Professor and Director of the Residency Program for the Department of OBGYN at the University of Maryland. She's an amazing human being with excellent leadership and communication skills. It gives me great pleasure to introduce you all to her, but first, a few words from my colleague and chair of Acog Argentina, Dr. Pablo Carpintero. Pablo? He's muted.
Hi, Pablo.
Good morning, everyone. Yes. Good morning, everyone. Thank you very much, Daryl, for your heartwarming welcome words. And it's really an honor to be invited to participate in the first joint meeting between West Indies section and Argentinian section, and to share this meeting with great speakers, international referents, and opinion leaders in their key topics. But besides from this outstanding academic syllabus, for me, it is very important the sense of inclusivity of this meeting. All the countries that conform West Indies and Argentina, which are very far away from each other, miles apart, have different languages, different history, and different cultural background, are joined together to learn about our differences, discover our similarities, but Moreover, I believe that we are going to enrich ourselves and learn from our diversities. So I really hope that this will be the first step in a collaboration path between West Indies and Argentina. Finally, I would like to thank District 4 and its leadership. Here is Dr. May Blanchard for their constant and continuous support to West Indies and Argentinian section. Thank you very much.
Yeah, so thank you so much for that, Pablo. And now we have some welcoming words from our chair of Acog, Dr. May Blanchard.
Hello and greetings. I'm Dr. May Shia Blanchard, Acog District 4 Chair, and I'm so thrilled to join you on this inaugural joint meeting of Acog Argentina and West Indies sections. Sincere thank you to Dr. Pablo Carpintero, Dr. Gustavo Laterio, Dr. Daryl Daly, and Dr. Jordan Hardy for your vision and foresight in convening such a meeting and for the kind invitation to have me give some initial remarks. For those of you who aren't familiar or less familiar with Acog, I'd like to give you a brief overview of our organization and the prominent and tireless efforts of our District 4 sections. Acog District 4 is a member of the Acog National Organization. The national organization is governed by the Acog Board of Directors. And this Board of Directors includes district chairs from 12 districts, the national officers, including the president, the past president, treasurer, secretary, assistant secretary, chair of the Council of District Chairs, and subspecialty members representing their organizations of Society for Maternal Fetal Medicine, Society for Gynecologic Oncology, Society for Reproductive Endocrinology and Infertility, Society for Family Planning, and the American Urogynecologic Society. In addition, we have council members from the Young Physician College Advisory Council and the Junior Fellow College Advisory Council, representing our younger membership. In addition, we have a public member who is appointed and serves the role of speaking for our patients from the non-physician patient perspective. Over the past several years, the Board of Directors has had several strategic planning sessions to really carve out a mission and vision statement and identifying core values that represent and exemplify what Acog as an organization is about. Acog's mission is to support our members to improve the lives of all people seeking obstetric and gynecologic care, their families, and communities. Our vision is an equitable world in which exceptional and respectful obstetric and gynecologic care is accessible to all. Our core values include excellence, integrity, accountability, respect, and equity. Acog is made of 12 districts. These are divided predominantly geographically, and the districts also include our international sections from Mexico, Central, South America, and Canada. Acog District 4 is very broad, spanning from Maryland, District of Columbia, Virginia, West Virginia, North Carolina, South Carolina, Georgia, Puerto Rico, the West Indies, and Argentina. We are Acog's largest district by membership, if not by geography. And I will say, very tireless in all of our efforts to speak for, educate, and advocate for our members and our patients. Acog headquarters is located in Washington, D.C., at the heart of it all. And if you get a chance, you can visit and swing by Acog headquarters. And this presence in the US Capitol really allows for a very constant presence and ability to advocate and represent the obstetricians and gynecologists who care for our patients. District 4 representation is continual, and here we are in our twice a year in-person meetings. This was our interim advisory council meeting and strategic planning, which was held in Washington, D.C., March 8th through 9th. We spent 2 solid days hearing from each other, collaborating, and working on ways to further the care of our patients, the education of our physicians, and to advocate for reproductive rights. Our district leadership consists of our district officers, the chair-elect, Dr. Scott Sullivan, the secretary, Dr. Nabal Bracero, our treasurer, Dr. Eduardo Laratore. We also continue to have input and support from our past district leaders, our immediate past chair, Dr. Sandra Reed, our past chair, Dr. Wade Nyman, and our past chair, Dr. Ben Cheek. As I mentioned, we have 10 vibrant and active sections, and the leadership I also want to recognize here. Argentina, Dr. Pablo Carpintero. District of Columbia, Dr. Tope Bada. Georgia, Dr. Kathy Bonk. Maryland, Dr. Betty Chow. North Carolina, Dr. Katie Borders. Puerto Rico, Dr. Miguel Vasquez. South Carolina, Dr. Dawn Bingham. Virginia, Dr. Amy Keats. West Indies, Dr. Daryl Daly. West Virginia, Dr. Sean Rowan. Our District Advisory Council is also represented by our young physicians and junior fellows. The Young Physician District Advisory Council is chaired by Dr. Andrea Desai, with Vice Chair Dr. James Casey. And our Young Physician Advisor is Dr. Scott Sullivan, who is also the District Chair-elect. Our Junior Fellow District Advisory Council consists of Chair Dr. Mary Shorey, Vice Chair Dr. Katie Wyant, Secretary Treasurer Dr. Maya Orr, and our Junior Fellow Advisor is Dr. Stephen Bush. Additionally, on our Advisory Council are committees represented by their committee chairs. Our Committee on Health Equity and Reflective Care is chaired by Dr. Victoria Green. Legislative Advocacy is chaired by Dr. Adrian Zertucci. Maternal Mortality, chaired by Dr. John Albert. Perinatal Mortality, chaired by Dr. Chris Chisholm. And Communications, chaired by our District Secretary, Dr. Nabal Bracero. In addition, we have some leadership with special focus. Specifically, our Scientific Program Committee is responsible for creating the program and selecting the speakers for our annual district meeting each fall. This committee is currently chaired by Dr. Amy Crockett. On a more longitudinal level, we have 2 members from our district who have special expertise to be representing our district and heading up the national committees on health economics and coding, Dr. John Horton, and continuing medical education, Dr. Stephen Bush. The Acog website, I encourage you to take a visit, acog.org, and you will see many of the educational and advocacy resources that are available to all of the members of the college, fellows and junior fellows. Here, you can look at our District 4 webpage, which identifies ways to connect and also find out what's going on within our district. You'll see pages that are dedicated to describing ways to promote health equity and reflective care towards our patients. Junior fellow activities, and they're very enthusiastic ways to educate and collaborate. Tireless advocacy efforts from all of our sections convening together to work collaboratively to fight for our patients and our members, and ways to collaborate across all of our sections and districts in combating racism and bias in the field of obstetrics and gynecology. I hope you'll consider joining us at our 2023 annual district meeting, New Ideas, New Connections, New Energy, which will be held October 20th through 22nd of this year in Washington, D.C. In addition to a fantastic educational program, there's the wonderful opportunity for interaction and camaraderie, much as what you will be gaining at this meeting today. So with that, I say welcome and enjoy the meeting. I know you wish you were all in person, and we look forward to the next iteration of this meeting in a year. Hopefully we will be able to all join together in person then. Thank you and have a great meeting.
Thank you so much for those kind words, Dr. Blanchard. Was greatly appreciated, and thank you for educating those who are not aware on the structure and function of Acog. So we're going to get right into it. I want to formally introduce our first moderator, Dr. Chantel Clark, who is actually our junior fellow vice chair. So she'll be taking over right now and introducing the next speaker. Dr. Clark?
Thank you. A pleasant morning, ladies and gentlemen, and all our esteemed guests. It brings me great pleasure to moderate the first session for this momentous inaugural joint meeting between the West Indies and Argentina section of the Acog District 4. We have quite an interesting lineup for you today, so please stay tuned as we embark on an inspiring journey of knowledge exchange, cutting-edge research, and collaborative discussions that will undoubtedly change and influence your practice in obstetrics and gynecology. There will be a question and answer section at the end of each presentation. It will last for about 5 minutes, so I encourage you to actively participate and share your knowledge as we maintain a healthy passion in women's health. In the presentations, with focus on the of HPV screening. The presentation will be done by the esteemed Dr. Natalie Medley. Now, Dr. Medley is a fellow of the Acog and hails from Jamaica in the West Indies section. In 2008, Dr. Medley completed her Bachelor of Medicine and Bachelor of Surgery with a distinction in obstetrics and gynecology and honors in surgery at the University of. She went on to complete her residency in obstetrics and gynecology in 2015. Dr. Medley has successfully completed her fellowship in gynecologic oncology, a joint venture between the UWI and the International Gynecological Cancer Society in 2020. Dr. Medley is a consultant attending at the University Hospital of the West Indies and an associate lecturer at the UWI. She maintains her passion for women's health care through teaching and medical research, which has resulted in a number of health publications in peer-reviewed journals. In 2022, Dr. Medley completed an editorial fellowship with the International Journal of Gynecologic Cancer and now serves on their early career editorial board. In addition to being a fellow of the International Gynecological Cancer Society, she practices as a gyne-oncologist at the UHWI. Dr. Medley is also a member of the Royal College of Obstetrics and Gynecology based in the UK. Ladies and gentlemen, please welcome the esteemed Dr. Natalie Medley.
Hello, everyone. I'm Dr. Natalie Medley, and I want to thank the organizers for inviting me to speak on this topic that I'm very passionate about, and that is the role of high-risk HPV testing. When we hear HPV testing, we think, what is this thing? Is it going to replace pap smears? Is it supposed to complement pap smears? Should we now be thinking out with the old and in with the new? Well, just to give a bit of background, in the early 1900s, George Papanicolaou, shown here, made the discovery of abnormal cells in washings of women with uterine cancers. And from this, cervical cytology then became the mainstay of cervical cancer screening. And we have seen dramatic reductions in cervical cancer incidence and mortality in countries which have a robust cervical cancer screening program. And about 60 years later, we have Harold Hussein, seen here. He actually made the link between high-risk HPV and cervical cancer. So it's very possible that some of these abnormal cells Papanicolaou identified could have been HPV-infected cells. So throughout this presentation, my aim is really to show you or highlight 10 main roles or benefits or uses of HPV testing. The first one I'd like to start with is the WHO Cervical Cancer Elimination Initiative. And this is very important, and I'll show you how HPV testing is a key part of this initiative. So in 2018, Dr. Tedros Adhanom Ghebreyesus, the Director General of the WHO, issued a call to action. He said, "We have the knowledge and the tools to stop women from suffering and dying from this preventable disease. The time is now for all member states and the development partners to rally behind this strategy to eliminate cervical cancer as a public health problem." This is the first global strategy for the elimination of cancer as a global health problem. Achieving the 90-70-90 targets by 2030 would result in over 62 million cancer deaths averted by 2120. Globally, cervical cancer continues to be one of the most common cancers among females, being the fourth most common after breast, colorectal, and lung cancer. In 2020, Globocan estimated that worldwide there are about 600,000 new cases of cervical cancer, with about half the number of deaths. Most cases and deaths, unfortunately, occur in low and middle income countries like Jamaica. So what are these 2030 targets? The first is that 90% of girls should be fully vaccinated by age 15 years with an HPV vaccine. The second, 70% of women should be screened with a high performance test by 35 years and again by age 45. And the last is that 90% of women with cervical cancer or precancer should be treated appropriately. So where are we today? In order to achieve these targets, right, to eliminate cervical cancer, all countries must work towards an incidence of below 4 per 100,000. And here we can see from this chart, we're currently at about 13.3 per 100,000, the global average. In the Caribbean, we're about 13.7 per 100,000, it's a little above the global average. But we can see that some countries are already there. So for example, in Western Asia, Australia, New Zealand, they're about 5.6 per 100,000. But unfortunately, in other countries, there's a lot more work to be done. For example, in East Africa, where the incidence is about 41.1 per 100,000. As we take a closer look at Jamaica, at our figures here in Jamaica, we don't have a robust cervical cancer screening program, But fortunately, we have seen a dramatic reduction in the incidence over the years at about 25.2 per 100,000 in 1993. And now in the last review, we were about 15.7 per 100,000 in the last published review. So we have been making strides, but we still have some way to go to achieve these targets. Let's look at how we have been managing as it relates to these targets individually, starting with vaccination. Vaccination of adolescent girls is the most effective long-term intervention for reducing the risk of developing cervical cancer, according to the WHO. HPV vaccination started in Jamaica through the Ministry of Health in 2017 as a school-based program with 2 doses of the bivalent vaccine offered to girls in the grade 7 cohort. The target was approximately 20 to 22,000 girls each year based on the school population. The uptake, however, has been unsatisfactory. And this table, a bit busy, shows us what the vaccination uptake was like. In the first year, about just under 3,000 girls received the first dose. In the second year, about 6,400 received the first dose, and again, a little over 3,000 receiving the second dose. And this increased in 2019 to roughly almost 7,000 girls receiving the first dose and a little over 6,000 receiving 2 doses. Unfortunately, the numbers fell off significantly in 2000 and later years, in 2020 and later years. And I do believe the COVID-19 pandemic had a significant role to play on the reduction in the vaccine uptake in these latter years. But either way, we fell short of the target, significantly short of the targets of 20 to 22,000 girls per year. Now looking at the target of treatment, Dr. Christopher Tufton, in a statement to Parliament in 2017, stated that it cost about $274 million Jamaican dollars to treat the 392 cases annually. And this figure does represent that of radiotherapy treatment. It does not include diagnosis and the chemotherapy. It also doesn't include surgery. It doesn't include the loss of financial earnings that women suffer. And most women, or many women with cervical cancer, are actually young women, reproductive years, women are working and earning for their families who are no longer able to do so. And also, of the 392 cases, we must remember that the mortality is roughly 50% of this number. So we can't afford to play catch up with treatment of cervical cancer. So this then brings us to the next target, which is that of screening. And the second role as well of HPV testing as a primary screening test. Because of its high level of performance, countries should ideally be transitioning to HPV testing as the primary method of screening for cervical cancer. Dr. Ghebreyesus, the Director General, states that this is what we really should be moving forward to. And by high performance testing, this is really what's being described right now. So why HPV testing? If we know that pap smears work, why do we need to transition? In the United States, since they introduced their cervical cancer screening program in the 1950s, they have seen a reduction of about 60% reduction in cervical cancer incidence and mortality. And we know that women who develop cervical cancer, 50% of them have never done a pap smear, and another 10% have not done one within the last 5 years. So overall, 60% of women who develop cervical cancer have not been appropriately screened. So if we know this, we know that pap smears work, why do we need to change? But the problem is that most developing countries face challenges in implementing a robust screening program. For screening to work, it must be widespread, it must be available to and accessible to all women who need to be screened. Some of the challenges are that doctors and nurses, so we need healthcare providers to collect the samples, we need technicians to process and interpret the sample, we need pathologists to confirm positive results, and also effective follow-up and treatment needs to be done. And we know the stories of many women who tell us they did a pap smear, they didn't get a call, so they assume the results are normal. And that can't be, right? Another issue with pap smears is the limitations of the false positive rates, the false negative rates, and the sensitivity is about 50%, 51%. The specificity, however, is about 98%. Persons may argue that we have liquid-based screening, and this should be better than traditional slide-based or traditional cytology. However, the meta-analyses show us though that liquid-based screening versus traditional cytology is the same yield, the same pickup rate for cancer and precancerous lesions. HPV testing offers superior sensitivity. The strong negative predictive value means that women who test negative only need to be retested after a minimum interval of only 5 years. In less developed regions, the use of 1 or 2 HPV tests in a woman's lifetime would be sufficient to make a major impact on mortality. And with the availability of rapid test kits, those testing positive can immediately be treated, hence avoiding the delays and waits for results to come back. Those testing negative would be at low risk of cervical cancer for at least 10 years. Here we see some HPV tests and the different testing platforms which they use. So we have genome detection, amplification, monoclonal antibody platforms. The hybrid capture 2 was actually the first FDA-approved HPV test. And here this table shows us the sensitivities and specificity of various HPV tests, ranging from 90 to 100%. This is actually a report from a HPV test of a patient done here from our lab a few years ago. So prior to last year, the report actually grouped the HPV types according to the alpha genre in which they were found. So for this patient who tested positive for HPV, we know that she had an HPV type found in genre A9 or alpha 9. So it could either be 16, 31, 33, 35, 52, 58. We wouldn't know. We just know it's positive for one of these high-risk types. And here, this really depicts the genre from a part of the phylogenetic tree, which I'll talk a bit more about later. But now, fortunately, we are able to have genotyping for 16, 18, and 45 separate from other high-risk types. And this is very useful information. This is very important information to have. This additional information of whether a patient isn't just high-risk positive, but whether it's 16 or 18, aids us in managing these women. So I'm really happy that we have this information now. The next point, or the next role of HPV testing, is that it represents a progression, a natural progression as medical knowledge advances. So since Papa Nicolaou's discovery of these abnormal cells and cytology has been implemented for screening, as we learn more about HPV, the natural history of HPV and cervical cancer, then so must our management and our practice evolve. So cytology really looks for HPV-infected cells indirectly. So here we have some superficial cells which are HPV-infected, and these are termed koilocytes. When you compare this to the normal superficial cell, you can see marked differences here, right? In this koilocyte here, we have it's multinucleated versus one in the normal superficial cell. There's a perinuclear clearing, there's nuclear hyperchromasia, and so on. So the cytologist can clearly tell us, yes, this is an HPV-infected cell, and we manage accordingly. Not all cases, though, are very straightforward, and sometimes pap smear results can be open to human interpretation and human error, especially in some groups of women. So, for example, when we think of our postmenopausal women who have atrophic genital tract, in these women, their pap smears often come back showing high-grade cells or high-grade features because of the fact that they have atrophy, and this gives an impression on this slide of a high nuclear to cytoplasmic ratio, which is interpreted as being something high-grade. So oftentimes we get women, postmenopausal women, being referred for colposcopy because of abnormal pap smears, and when we do colposcopy and biopsy, there's no evidence of any CIN in these women. With HPV testing now, we're directly testing for the presence or absence of high-risk DNA. So it's less open to human interpretation and human error. Just giving a bit of background about the HPV types. So there are over 200 HPV subtypes, and they're divided into 49 species and 5 genera. All the oncogenic HPV are found in the alpha genera. Okay, and this is depicted over here. All right. The differences in the L1 protein is really what distinguishes different subtypes from genera from species of HPV. Of the 200 subtypes, about 60 types infect the anogenital mucosa, and of these types, about 12 are classified as high risk. So of all the high risk types, so we have some super high risk, which I like to call them, which type 16 and 18 account for about 70% of cervical cancers. And of this, type 16 alone accounts for about 50% of cervical cancer cases. In addition to the L1 protein, we need to know about the E2 and E6 and E7 oncoproteins, because these are the cancer-causing HPV strains, types, or proteins. All right, so E6 inhibits tumor suppressor protein P53, E7 inhibits retinoblastoma protein. The fourth role is in co-testing. So HPV testing with pap smears, co-testing, increases the screening intervals. So I just want to show you a chart from the American Cancer Society and the ASCC, the American Society of Colposcopy and Cervical Pathology. Their latest guideline actually recommends that screening starts at age 25 versus the previous guidelines, which stated screening should start at 21 years. So starting at age 25, screening is done with a primary HPV test, that's the HPV test alone, every 5 years, and this is the preferred modality. The caveat, however, is that it has to be an FDA approved test or test that's approved for primary screening. Or co-testing can be done. So this is any other HPV test that may not have been approved for primary screening plus cytology every 5 years, or cytology alone every 3 years. So the co-testing actually allows you to do this screens less frequently, again, because of their sensitivity. The studies have found, however, that co-testing versus primary testing with an FDA-approved test doesn't add a tremendous yield or increase in the sensitivities, however. So with a very good test, FDA-approved test and primary testing alone is actually preferred. If this is not available, then cytology alone every 3 years is acceptable. So they state here, very important, is co-testing or cytology testing alone are acceptable, whereas access to primary HPV testing is limited or not available. As the United States makes the transition to primary HPV testing, the use of co-testing or cytology alone for cervical cancer screening will not be included in future guidelines, right? So this is very important to note, right? In addition to extending the screening interval to 5 yearly, having co-testing with the additional information of the pap smear also provides useful information in managing these women. So a patient may have a co-test done with a pap smear, HPV test. The HPV test might be positive, the pap smear negative, or the other way around. Having both, I find, is very useful in managing. So the pap smear itself can sometimes act as a triage tool for the positive HPV test, which I'll talk a bit more about. The fifth role is that of reflex testing for ASCOS. So ASCOS, or atypical squamous cells of undetermined significance, has been evaluated in a multicenter trial called the ASCOS LCL trial study. In this study, women were randomized to 3 management arms, either immediate colposcopy, cytology, follow-up, or HPV testing. So they looked at women not only with ASCOS, but also with LCL, or low-grade squamous intraepithelial lesions. So about 3,500 women roughly enrolled had ASCOS. And what they found was that HPV triage of the 3 management options proved to be most useful. The sensitivity was equivalent to that of immediate colposcopy, and doing HPV triage actually reduced the colposcopy referrals by 50%. HPV testing identified 96% of women with ASCOS who had a precancerous lesion. And this has really formed the framework of how we manage ASCOS today, which HPV testing is the preferred modality for triage. Of the 642 women with LCL, however, 82.9% of them tested positive for HPV, and hence it didn't make sense to triage LCL by using an HPV test because most of them would be HPV positive anyway. So they stated that HPV testing is a viable option for the management of ASCOS and not LCL. Post-treatment surveillance. So let's look at how HPV testing helps us in managing women who have been treated for CIN. So in the UK, they have what's referred to as a HPV test of cure, which relies on the high negative predictive value of high-risk HPV to exclude residual CIN. a negative combined test of cytology and high-risk HPV at 6 months after treatment of CIN can allow return to routine 3-yearly recall in place of up to 10 years or of annual cytology. So there are several studies which support this. A prospective study of test of cure was also conducted in Scotland and England, and it confirmed the safety of the HPV test of cure, which allowed 82% of women who had received treatment for CIN to return to a routine recall. So what was done previously is that women who were treated for CIN would have had to do annual pap smears for up to 10 years before going back to 3-yearly smears. But since introduction of HPV testing after treatment of CIN1, a pap smear and an HPV test is done at 6 months. If they're both negative, then a woman continues to do a routine 3-yearly follow-up. And in the United States, a similar approach to the management of CIN. So after treatment, HPV-based testing, either co-testing or HPV alone, primary screening is done, or testing is done, and this is preferred regardless of the marginal status of the excisional specimen. If the HPV tests are positive, then colposcopy and appropriate biopsies are done. The preferential use of HPV-based testing is supported by evidence that post-treatment HPV test is the most accurate predictor of treatment outcome. After the initial intensive surveillance period, continued surveillance at 3-year intervals is recommended for at least 25 years after treating CIN2. And this you must remember. Now, patients we manage who have had CIN2 or more, that they need follow-up for at least 25 years, regardless of if this takes them beyond the 65 or cutoff for screening. And this algorithm here just goes through what was discussed on the previous slide about the follow-up, and it's from the ASCCP. So this is the American recommendation, where after the diagnostic, after the treatment is done, whether it's ablation or excision, then an HPV-based test is done at 6 months. If it's negative, then a repeat HPV-based testing is done every year for 3 years. If they're all negative, then a woman continues to routine screening regimes. Now let's take a look at HPV rapid testing. So some HPV testing platforms can give results in a very short time. So for example, the CARE HPV can give results in 3 hours, and it requires basic laboratory infrastructure. A study in China compared the CARE HPV to hybrid Capture-2, the gold standard, in detecting CIN3 or more. They looked at both self-collected samples and clinician-collected samples. In looking at the clinician-collected samples, the sensitivity was 97% for both CARE HPV and hybrid Capture-2. And in the self-collected samples, it was 83.3% for CARE HPV and 90% for hybrid Capture-2. And then the expert HPV test, also a rapid test, that can give results in as little as 1 hour. And it has some advantages over CARE HPV. It can give us genotyping for 16 and 18 and 45, similar to the reports I showed you earlier, which we can now get. So this is very useful information. And the other HPV types are grouped collectively. The test platform can also be used for testing HIV and other STDs. And imagine a woman can walk into the clinic and within 1 hour is tested for HIV and chlamydia and gonorrhea and HPV and has her results within an hour and she's out. Amazing. The limitation of this, though, is a very expensive platform to use. Now, HPV urine testing. So because of the high sensitivity of HPV testing, it may allow the use of urine samples containing very low levels of HPV DNA to be used for screening. Still experimental though, but some studies showed food sensitivities of about 77%, so ranging from about 50 to 98% in individual studies, with a specificity of about 94%, ranging from 17 to 99. So we can see there's a wide range in the individual studies highlighting the heterogeneity of this test. And so because of this, HPV DNA detection in urine may be feasible. However, further optimization and standardization of the methods need to be. And point 9, future high performance HPV testing. Having the ability to detect HPV testing, HPV DNA is amazing, and we're going even beyond this now. So what we're trying to look at now is not just HPV infections, because we know most HPV infections will clear within 1 to 2 years when the immune system is functioning normally. So what we're trying to detect now is HPV infections that are actually undergoing transformation or transforming infections, those that are actually in the process of becoming precancerous or cancerous. So ideally, a screening strategy should maximize the benefits of screening by detecting precursor abnormalities that are likely to progress to cancer, as well as early stage cancers, but avoiding detecting transient infections and benign abnormalities, right? Because we want to prevent overtreatment and other harms associated with screening. Because of the low specificity of HPV testing, its introduction in primary screening without a suitable triage can increase the number of referrals to colposcopy and may cause unnecessary anxiety on women who do not have cervical disease. So the WHO actually suggests that HPV testing can be done as a primary test, or it can be done with a triage intermediary. So one of these triage tools is actually testing for E6 and E7 oncoproteins, because detecting not just HPV positivity, but E6, E7 will then let us know that this patient actually has pre-malignant changes going on with the detection of these oncogenic types we spoke about earlier. So E6 and E7, as we know, have a pivotal role in starting the cascade of events leading to carcinogenic transformation. They inactivate tumor suppressor proteins, and detecting E6 and E7 can differentiate transient HPV infected patients from those who are undergoing transformational changes. So currently we have the E6 cervical test available. It's a commercially available test, mostly still experimental, and it qualitatively detects E6 oncoproteins using monoclonal antibodies. The sensitivities to date are about 42% for CIN2, roughly 50% for CIN3, and a 99% specificity. And the good thing is that results can be available in 3 hours. Another biomarker for detecting transforming HPV infections is looking for E7 oncogene. So this is done indirectly by looking for P16INK4A. So this is a cellular tumor suppressor protein that has been identified as a biomarker for transforming HPV infections. And the sensitivity for this is about 86 to 98% for LCIL, and it has an overall higher specificity than HPV testing. And 10, I decided to leave this one for last, and that is HPV self-testing. So patients participating in self-sampling studies consistently report improved convenience, less discomfort, and positive attitudes and overall acceptance compared with clinic-based sampling. Earlier studies showed that which compared self-testing with clinician-collected samples showed a 10 to 19% decrease sensitivity for detection of high-grade cervical disease. However, more recent studies, show the detection of high-risk HPV in self-collected samples using PCR-based testing has a comparable sensitivity to clinician-collected samples. Several countries have already included HPV self-sampling as an option for screening in their national screening programs, such as Denmark, the Netherlands, and Australia. In addition to this, HPV self-sampling is supported by the WHO, and we can see their flyer here. Endorsement of self-collection by clinicians, however, is less certain. Limited studies suggest that most clinicians would support a self-collected HPV test if it were highly sensitive and cost-effective. So I decided to end by sharing this study, which was published just recently, looking at the attitudes of healthcare workers to HPV self-collection. The background to this study was that the COVID-19 pandemic created obstacles for patients and providers in conducting routine healthcare. The screening took a dramatic hit, and they found that there was a 94% decrease in cervical cancer screening, with an estimated 40,000 missed screens between just March and June of 2020. So they decided to interview 18 healthcare workers, and there were about 50% of them were physicians, 33% nurse practitioners, and 94% of them work within family medicine. They all perform cervical cancer screening according to the ASCCP guideline, which I mentioned earlier. Almost all providers stated that they would offer HPV self-collection to most of their patients once it was available. There are 5 overarching themes which emerge from the responses from these healthcare workers. We can take a brief look at these. The first was that provider concerns about test efficacy and sensitivity. One provider stated, "I would be curious how this collection method would impact women coming in for routine exams, because they do more than the cervical cancer screening in those exams typically. So I would still want to encourage patients and stress the importance of continuing to have those physical exams as well." And I'm sure a lot of us here today are thinking the very same thing, right? Another provider stated, as it relates to clinical and provider barriers, time constraints, and staff constraints, "I feel like I would resist another reason to not lay eyes on my patient. I do actually like to see my patients, and don't we all, right?" The third, as it relates to patient perspective and barriers, comfort, awareness, and access. This provider stated, "The idea of putting a swab in there might be some pushback to that. There might be some pushback to that. I think more so with the older generations than with the younger generations. They seem to be a bit more accepting of things like self-testing, and the younger patients would rather do something themselves than have to put their feet up in those awful stirrups and that sort of thing. So I think there might be some generational shift to that." As it relates to process-based themes, patient clinical system barriers, one provider said, we have not implemented HPV testing alone, mostly because the labs haven't been able to do it. And as I stated earlier, implementing HPV high-risk testing really has to be on a platform that's FDA approved for it to be done as a standalone test. Patient barriers to cervical cancer screening, such as trauma, female preference. This provider said, "I think the access to care is the general barrier. So language, resources, transportation, and then the discomfort. Specifically related to the discomfort of not wanting to take your clothes off, those are big barriers to cervical cancer screening." So I decided to just leave us with this study as food for thought, so we can think, what would be some of the barriers or questions or challenges that we might have, or attitudes towards, HPV testing overall, and also HPV self-testing, if this is something that were to be implemented in Jamaica. So to summarize, HPV testing represents a natural progression in cervical cancer screening with improved sensitivities over pap smears, and is the way forward for primary screening. Triage tools such as pap smears and HPV genotyping are useful adjuncts in preventing over-referrals to colposcopy from HPV screening. New technology allows the detection of transforming HPV infection by identifying markers of E6 and E7. HPV reflex testing for ASCOS prevents over-referrals to colposcopy, and HPV test of cure is used in the surveillance for CIN treatment. HPV self-sampling is WHO approved and has been shown to improve screening rates, especially in women remote from healthcare services. HPV testing is a pillar in achieving the cervical cancer elimination targets by 2030. We know cost, however, is a significant factor in implementing HPV testing. However, according to the Director General of the WHO, the success of the drive to eliminate cervical cancer depends on political will, country-led action, investments, global solidarity, sustainable partnerships, and adaptable partnerships. So this is something that as a country moving forward, looking to get this implemented for our women here, we need to form some sustainable and adaptable partnerships. And before I close, I want to leave you with this very useful app. I use it every day in my practice in managing women who have HPV testing and pap smear results, especially with a combination of HPV test and pap smear reports. The permutations and combination of reports can be so much. The HPV test can be positive, the pap smear negative. What do you do? Is this our first screen? And I find this app to be very user-friendly. It's extremely useful, and I encourage you all to go and download this app and start using it in your practice, especially if you're going to be doing HPV testing in your patients. And with that, I'd like to thank you for your attention.
That was indeed an enlightening review on the role of HPV testing by Dr. Natalie Medley. Thank you very much, Dr. Medley. At this time, we're going to be taking questions from our Q&A section on the use of HPV testing in gynecological cancers. Our first question was anonymous. The first question asks, how often should Pap tests be performed and up to what age? Dr. Medley? Please unmute.
Oh, hi, hello. Okay, hi again. All right, thank you for having me. Okay, so regarding that question on how often should Pap smears be performed, most guidelines now recommend if it's cytology alone, then this should be done every 3 years. We have the different age groups in which screening is recommended to be started. So as I described earlier, the US has now moved the age up from 21 to 25. In the UK, it has been 25 for some time. So using cytology alone or Pap smears alone, then it will be every 3 years up to age 65. However, they do state that in women who have had, or this is recommended in women who have had consistent normal screens, especially in the last 10 years prior to age 65, then we may stop at 65. However, in women who may still be at high risk, in women who had a CIN2 or more on screening, then they should continue for at least 25 years. So generally age 65, but we need to bear the risk for that individual patient in mind.
Okay, thank you very much. I
That's
hope that
using Pap
answers.
smears. And as I said, if it's using HPV screening, then we can actually do it every 5 years. Co-testing HPV plus Pap smears every 5 years as well.
Okay, wonderful. Thank you, Dr. Medley. That certainly does answer the question. We had another comment from Dr. Christopher Fletcher. He was making mention that in the scenario that you gave with a patient that had an abnormal Pap test, where there was an increased nuclear to cytoplasmic ratio, possibly due to atrophy, if in the event that the HPV testing is negative, then it would mean that no further intervention is needed. That's correct?
Okay, so if she has an abnormal Pap smear and her HPV test is negative, then what can be done for this patient is we can actually do a repeat screen in 12 months, especially if the smears before this were also normal, right? And it also depends as well on what the exactly what abnormality the Pap smear showed as well. So even though we know that in older women, because of changes in the genital tract due to atrophy, we can have abnormal results, we still would want to earn the side of caution, especially if it comes back saying high-grade findings, and take a look. So going ahead and doing the colposcopy just to ensure that she indeed doesn't have any high-risk disease or any CIN would still be, would be fine. But the HPV test does provide some reassurance and does give you the option of actually repeating the Pap smear in 12 months. So we really need to, individualize each patient. We have the guidelines, but at the end of the day, we still need to look at the whole picture and any additional information for each patient.
Okay, thank you so much, Dr. Medley. So always do a second look and follow up. Okay, and there was a follow-up question. Could you state what percentage of Jamaican women with cervical cancer did not have a Pap test in the last 5 years leading up to their diagnosis?
Okay, I'm sorry I don't have this information for our women here in Jamaica, but I know literature overall tells us that about 10% of women who have cervical cancer have not had a smear done within the last 5 years. And the 50% who develop cervical cancer have never been screened. So by extrapolation, I would think it might be similar in our women based on what the literature states generally.
Okay, understood. Thank you so much, Dr. Medley. And there is another question related to statistics. Could you state if the Jamaica Cancer Society has a practice guideline for HPV testing and screening for cancers?
Okay, so right now, unfortunately, we're not there yet, but we're agitating for change to have HPV testing being incorporated and readily available in the public setting for our women. So right now, it's not being done extensively, We only have one private lab which offers it, and we don't have any local guidelines right now to guide the management. So we rely, or I personally rely heavily on ASCCP recommendations and that very useful app, which I mentioned at the end of the presentation.
Right.
Until we can get our guidelines going.
Okay. Okay, thank you. And there was one last question it asked if there is any E6 or E7 test done routinely in Jamaica, and is writing E6 or E7 testing sufficient for laboratory investigation and requests?
No, as far as I'm aware, that Anchor E6 platform isn't available here in Jamaica as yet. Yeah, but that's something that we could definitely look into, getting for our women. So we won't be left behind. So whatever is available on the international scene, we should be able to have all of this available for our women as well.
Okay, thank you, Dr. Midley. All
Thank
right,
you.
so we still have a few questions coming in. I think there is an option for Dr. Medley to go ahead and type a response to those questions, so the entire audience has the benefit of also receiving the answers afterwards. At this point, we're going to be moving on. Ladies and gentlemen, as the session continues, just place your questions in the Q&A section, and we will respond to them in a timely fashion. At this time, we will have a word from one of our sponsors, Medical Products Limited.
Pleasant greetings to all. My name is April Marshall, Senior Medical Representative at Medical Products Limited, a sponsor for today's conference. Before I begin, I would like to express gratitude for allowing us to be a part of SAME. In today's presentation, I will highlight two key products, both of which can be found in local public and private sectors island-wide. I begin my presentation with Nifecard Oros, a once-daily nifedipine suitable for the management of hypertension in pregnancy. Nifecard presents as 30 milligrams and 60 milligrams. Nifecard relies on an osmotic control release mechanism, which allows for the extended release of nifedipine for a 24-hour period. This therefore guarantees that your patients will have a steady concentration of nifedipine in their bloodstream for the 24 hours. Unlike nifedipine retards, your typical 10 or 20 milligrams, which are of course the more commonly prescribed presentation, Nifecard has an improved side effect profile, such as less headaches, as well as dizziness, which we know are typical complaints amongst NIFED users. Nifecard also has better tolerability, as the possibility of patients experiencing a reflex tachycardia is also reduced. In being a once-daily nifedipine, patient compliance is improved. For persons who are taking 20 milligrams twice daily, a patient can now be prescribed Nifecard 30 once daily and will achieve the same therapeutic effect. If one has patients taking as high as 40 milligrams twice daily, Nifecard 60 milligrams once daily will cover that patient for the 24-hour period. Nifecard can also be used in patients who are suffering from preeclampsia. Now, anemia, as we know, is a common problem associated with pregnancy. Postpartum hemorrhage complications are still a leading cause for maternal mortality, especially in some developing countries. And having low iron stores can also be further depleted during delivery. Now, there are many methods in the management of iron deficiency anemia, such as oral, your intramuscular, and intravenous preparations. Of course, this is depending on the status of and the need of the patient. But the efficacy of oral therapy tends to be limited in some patients for reasons such as possible non-compliance, poor diet, poor absorption, amongst other variables such as taking longer time to therefore correct low hemoglobin and iron stores. Now, intravenous iron sucrose, we are the distributors of a brand called Flovin. Flovin presents as 20 milligrams per ml, therefore being a 5 ml ampule, thus possessing 100 milligrams per ampule of iron sucrose. It can be purchased at Medical Products Limited, being that we have a pharmacist. Therefore, persons who possess a prescription may come and have their prescriptions filled directly from us. However, Flovin is also available in the public hospitals island-wide as well as in the private hospitals island-wide. Flovin is obviously more economically priced than the brand. However, it is guaranteed to have the same bioequivalence in efficacy as compared to the brand. Nifecard Oros, as I have previously mentioned, Nifecard can be found in your private pharmacies and is NHF subsidized. Nifecard is also found in your public sector pharmacies such as the DrugServe, and is also free for patients who will be visiting in your public clinics as well as public hospitals. If there are any further questions on Nifecard Oros or Flovin, I may be contacted at 535-1378. And thank you so much for listening. Enjoy the rest of today's activities.
Okay, thank you so much, Medical Products Limited, for that introduction. We hope that the audience, will engage you in getting your products for their patients. At this time, thank you so much for remaining online with us. We're going to be moving to our next presentation. We will shift our focus to the interest of modern management of the vaginal discharge. This section will be presented by the lovely Dr. Tiffany Watson, who hails from the West Indies section of District 4 Acog. Dr. Tiffany Watson received her Bachelor of Medicine and Bachelor of Surgery from the University of the West Indies in 2015. She later received her Doctor of Medicine in Obstetrics and Gynecology while training at the University Hospital of the West Indies in 2022. As a practicing obstetrician and gynecologist, she maintains a healthy passion for women's health, particularly at pivotal life stages such as pregnancy and menopause. She takes pride in delivering patient care with warmth, compassion, and encourages every woman to be the best version of herself, inside and out. Without further ado, please receive Dr. Tiffany Watson.
Good morning. My name is Dr. Tiffany Watson. I'm a newly minted obstetrician and gynecologist. I'm very happy to be presenting to you today about a very important topic, vaginal discharge and its modern management. So let's just get right into it. Vaginal discharge is a common presentation to general practitioners, gynecologists, and any primary or secondary healthcare facility really. And it comprises about 40% of complaints that we see. Annually in the US, it accounts for 10 million primary care visits. I'm sure we all have a similar experience in our clinical settings. I know I do. And as we know, the most common causes of vaginal discharge are bacterial vaginosis, candidiasis, and trichomoniasis. However, up to 70% of our patients remained undiagnosed. A study by Hillier et al. Examined the diagnosis and treatment of vaginal discharge in the community setting. And in this study, they actually found that nearly half of the participants who had a lab-diagnosed cause of vaginitis received inappropriate prescriptions. And then a third, without any of the known infectious causes of vaginitis, were prescribed treatment inappropriately. That finding was associated with the infrequent utilizations of recommended testing, examination, and proper evaluation of the complaint. So it is very important that we, as practitioners, are educated on the appropriate evaluation of our patients, and the importance is further underscored by the significant consequences of misdiagnosis or inadequate treatment, including the rising prevalence of antibiotic resistance and antifungal resistant organisms, and an increased susceptibility of our patients to sexually transmitted infections. There is also the risk of infertility and, of course, patient frustration with recurrent disease. So let's get into the modern management of the vaginal discharge. Over the next few minutes, we will be reviewing physiological versus abnormal discharge, exploring the diagnostic advances in discharge evaluation, and discussing the evidence-based management of common etiologies. We'll also discover some emerging trends in the management. Let's begin. Physiological discharge develops during reproductive years as a result of the estrogen effect on the vaginal epithelial cells. The presence of estrogen increases glycogen stores and promotes growth of the lactobacillus bacteria, or dear friend, and the production of lactic acid. These in turn maintain the vaginal pH at 3.8 to about 4.5, which is the optimum environment for the vaginal microbiome. And this inhibits the growth of ubiquitous commensals such as Gardnerella vaginalis and Candida albicans. The appearance is usually white to clear, although it can have a yellowish tinge, especially when it's on the panty liner. And the consistency varies from sticky to egg white. Its odor should not be offensive, but it differs from patient to patient. These changes are observed throughout the menstrual cycle, so it's important to be aware of what the changes are as the cycle progresses, and the volume will increase in response to hormonal contraceptives or to sexual excitation. In hypoestrogenic states, the normal vaginal discharge is a little less acidic, so greater than 4.5 in the postmenopausal woman, and it's totally alkaline in prepubertal girls, and it's usually very scant. So the abnormal discharge. Clinically, the patient may complain of a change in the color, consistency, or odor from what their normal physiological discharge is. So that is why it's very important for the patient to know what her normal is and for us to educate the patient about what she can expect to be normal. There may be symptoms associated, so itching, burning, dysuria, dyspareunia. Vulval irritation in any way can be manifested as swelling or erythema, and this may be the way that she presents. As physician, we must recall the non-infectious causes as well as the infectious as we evaluate and manage our patients. In this session, we'll focus on the three most common infectious causes, which are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. However, if the patient's history suggests the need for further evaluation for other sexually transmitted infections, do not hesitate and do not be boxed in to the three most common causes. And also remember the non-infectious causes when you're evaluating your patient, even though we're not going through this one in this presentation, but there is a recent TikTok that was gaining a little bit of traction, and there's this 90-year-old patient who actually used a potato as a pessary. So some patients may have some unusual items in their vagina. Some patients can self-medicate with garlic and forget it. And importantly, we don't want to miss a diagnosis of malignancy, which can present as a copious, watery, malodorous discharge. So try not to be too tunnel visioned when thinking about what the etiology is in this case. You can also remember desquamative inflammatory vaginitis. This usually presents with a heavy yellowish vaginal discharge and an inflamed cervicovaginal mucosa. However, this is rather uncommon in our population. It's more in the Caucasian population and is of course a diagnosis of exclusion. So if you're thinking about that, you should have gone through all of the things which I'm about to speak to you about. Let's start with bacterial vaginosis. Bacterial vaginosis occurs when there is a disruption in the vaginal microbiome. It's the most common cause of abnormal vaginal discharge and is the causative organism in 22 to 50% of cases. It's usually white or gray, thin, has that classic fishy odor, and there's not much associated inflammation. And although sexual intercourse, including receptive oral sex, is a risk factor, it is not actually considered to be a sexually transmitted infection. There is a higher risk with Black and Hispanic races and ethnicities. However, it may be more a reflection of behavioral practices or socioeconomic standings, as well as douching, cigarette smoking, and obesity can be other risk factors. The recurrence rates are actually up to 30% within 3 months, and 58% of our patients will experience recurrence within a year. And this is defined by 3 separate acute episodes in 1 year. So vulvovaginal candidiasis, this is the second most common cause of abnormal discharge. Patients often complain of itching, burning, dysuria, and dyspareunia. It's characterized by a thick, white, heterogeneous discharge, that cottage cheese appearance that is usually described, and it's adherent to the vaginal walls. There may also be a thin, watery discharge, or in severe cases, you can have associated erythema, excoriation, and fissuring of the external genitalia. An increased risk is associated with immunocompromised states. So patients with HIV infections, diabetics, patients who are on corticosteroid therapy, or after, very commonly, patients who have used broad spectrum antibiotics. So we typically have patients who come in after they've been on Augmentin for a little bit and they notice that they're having a change in their vaginal discharge. This is one of the risk factors for vulvovaginal candidiasis. High estrogen states like pregnancy or postmenopausal hormone replacement therapy will also increase the risk of vulvovaginal candidiasis. But we should remember that there is an unclear association with the combined oral contraceptive pill, as studies have revealed mixed results so far. Infections in immunocompromised patients, non-albicans species or recurrent infections are considered complicated, and recurrence is defined as 4 or more separate cases in 12 months. 5% of patients will progress to recurrent disease, with the highest being in the 25 to 34-year-old age group. Trichomoniasis vaginalis occurs in 4 to 35% of cases and is characterized by a purulent, yellow to green, frothy, malodorous discharge. However, this classic presentation is actually limited to only 10 to 30% of our patients. Most patients may only complain of a discharge that ranges from thin and scanty to profuse and thick. Erythema of the vaginal mucosa and cervix may be associated, and it gives that punctate hemorrhages, which is usually described as a strawberry cervix appearance. Patients may complain of associated symptoms like burning or itching, dysuria, dyspareunia. However, 10 to 50% of patients are actually completely asymptomatic, which stresses the importance of proper vaginal examination when we have a well woman visit, or in patients who complain of what they think is just a yeast infection. It is sexually transmitted and so it should be treated, as well as partner treatment should be promoted. And because of its high risk sexual behaviors are associated with it, in patients who have those, we should be more suspicious, even if they don't have the classic symptoms. So let's have a look at some of the diagnostic advances in vaginal discharge evaluation. We are familiar with the acidity of normal vaginal discharge. We just mentioned it as well. So testing of the pH of the discharge can help in making our diagnosis. The litmus paper should be dipped in the discharge that is against the vaginal side wall or on the upper blade of the speculum, so that we avoid any pooled cervical secretions in the posterior fornix. This can affect the pH that we get. The test does have some low specificity. It's also affected by the presence of blood, semen, or urine. So it does hamper the use. However, it's very convenient. They are easily obtained and it's an easy test to do. So it's a good adjunct to have on your trolley. Wet mount is obtained by collecting a sample of the vaginal discharge. We add a drop of saline to it, place it on a microscope slide, and examine it under the microscope at both high and low power within 10 minutes of collection. The presence of clue cells, these are vaginal epithelial cells that have a stippled appearance, and this is due to the presence of bacteria. it indicates bacterial vaginosis. If we see motile flagellated trichomonads, those are little the organism that causes trichomoniasis, then we can make a diagnosis of Trichomonas vaginalis. Hydroxide tests can be done from your wet mount sample. We just take another sample of discharge, mix it with potassium hydroxide to perform the whiff test. In the presence of bacterial vaginosis, it releases a fishy odor that is consistent with that diagnosis. The potassium hydroxide will also destroy any epithelial cells and bacteria. So this aids the visualization of pseudohyphae and spores and allows us to see and make a diagnosis of candidiasis. Unfortunately, Candida glabrata is less likely to be diagnosed on wet mounts because it doesn't form pseudohyphae usually, so it's more difficult to identify in this way. The wet mount can assist us in performing or to complete the AMSEL criteria, and this is a useful tool that we use to diagnose BV. It requires fulfillment of 3 out of 4 criteria. Its sensitivity is a wide range between 50 to 92%, but it's very highly specific at 98 to 100%, particularly when there are clue cells present in more than 20% of the vaginal discharge sample. It's inexpensive, easily performed, and can be done at the point of care, and it is, of course, recommended by Acog and the CDC. While there are limitations in its use in that we don't always have a microscope available, if you fulfill the other 3 criteria, the thin, white, homogeneous discharge, the vaginal pH, and the positive whiff test, that is acceptable and it fulfills the criteria, so you can make the diagnosis. And in fact, newer studies suggest that just 2 out of the 4 criteria can confer equal sensitivity and specificity of completing all 3. Samples of vaginal discharge can be sent for vaginal culture and gram stain. The fungal cultures assist in the diagnosis of vulvovaginal candidiasis, especially in patients with persistent symptoms and who still have negative microscopy, or when there is resistance or recurrence or complicated cases. The species of Candida can help in selecting an effective treatment. Recurrent vulvovaginal candidiasis should have fungal cultures that confirm the species that is involved. The gram stain with Nugent scoring is actually the gold standard for diagnosis of bacterial vaginosis, and it looks at the proportion of bacterial morphotypes present per hyperod field and then places them in a different score or category. So it gives a score of either normal, mediate, intermediate, or a bacterial vaginosis infection. The Hay-Eisen criteria is similar in that it puts it into categories and helps with the diagnosis. However, it's limited by the need for a lab and the lab expertise. And then there's also a delay in you getting back your results. So in clinical settings where we don't have easy access to our patients, or they're lost to follow-up, it may not be the most useful test. However, it is the gold standard, and so it should be implemented whenever possible. There are options for point of care testing like the OSUM BV Blue or the OSUM Trichomonas rapid test, as well as the BD Affirm. So the OSUM BV Blue is a chromogenic point of care assay, and it detects sialidase in vaginal fluid, which is produced by most of the organisms that cause bacterial vaginosis. The tests are approved by the FDA and have good sensitivity and specificity when compared to the gold standards. However, they're more expensive, of course, than the wet mount, and they may not be as readily available. The OSUM Trichomonas rapid test detects the presence of the Trichomonas antigen, and the BD Affirm test detects all 3, both with Trichomoniasis, Candida, and Gardnerella, However, it's done in batches. It takes about 45 minutes and is more expensive. So unless you have a high volume practice where you'll be doing multiple tests, it may not be the most economic option. Nucleic acid amplification tests. These use molecular techniques to identify DNA or RNA that's specific to the microbe being investigated. The BD Max looks for all three as well, the trichomoniasis, vulvovaginal candidiasis, and BV. And it also reports the presence of Candida glabratus. So in patients that have recurrent vulvovaginal candidiasis or recurrent complaints, this test is very helpful. It can also be a patient-collected sample. So in cases of monitoring patients with recurrent disease or monitoring treatments, you don't have to have the patient come in. And in cases where you're using telemedicine, this can be helpful. They're highly sensitive and specific, and they're viable options for diagnosis. Let's go through some of the evidence-based management of our common etiologies. So for bacterial vaginosis, Acog recommends metronidazole as an oral option as well as a topical option. For topical, we have the clindamycin as another option, but you should let your patients be aware that the clindamycin ovules can weaken latex and rubber, and they should be on a backup method of contraception. For patients who have recurrence after treatment with initial suppressive therapy, you can use metronidazole 2 times a week for 16 weeks to aid in the cure of recurrent bacterial vaginosis. Alternative options are tinidazole either orally or clindamycin orally or vaginally. For vulvovaginal candidiasis, there are many options for treatment. Those that are highlighted in bold are recommended by Acog, and this is in the Practice Bulletin 215. For uncomplicated vulvovaginal candidiasis, fluconazole 150 milligram stat is an effective, safe, and convenient option, and it actually has a 90% cure rate. I think that that's one of the favorites for patients. In severe cases, fluconazole may be repeated after 3 days for a total of 2 to 3 doses to get rid of everything. The topical agents, so like clotrimazole 1 or 2% creams or butaconazole or miconazole, can actually be repeated or extended for 10 to 14 days if the patients have a more severe case. For patients who are allergic to fluconazole or who have uncomplicated fluconazole resistant infections, we have the option of itraconazole 200 milligrams orally, although this isn't necessarily recommended by Acog as yet, and triterpenoids like ibrexafungerp 300 milligrams twice daily for a day is another oral option. They have similar cure rates and better response at 25-day follow-ups in comparison to fluconazole. It should be noted that non-albicans species are less likely to respond to topical imidazole or oral fluconazole. However, nicely, they have been shown to respond to quite rapidly to a 14-day course of boric acid. And this is given 600 milligrams in the vagina or flucytosine 5 grams per vaginum nightly. So those are other options that can be given to the patients. For vulvovaginal candidiasis that is recurrent, these are managed by reducing the fungal load with a suppressive therapy. And this is given after the treatment of the acute infection, which is very important. So the medications are discontinued typically after 6 months, and the patient is monitored for remission. So the oral regimens that we have, you can induce with fluconazole 150 milligrams on days 1, 4, and 7, and then maintain the patient, or we can give other methods for induction. If they prefer a topical method, topical clotrimazole 500 milligrams once weekly can be given, or we can use boric acid. So Kalan et al. evaluated the use of vaginal boric acid 600 milligrams, which was given monthly for 5 nights, beginning on day 5 of the cycle. This was given after an acute treatment and then continued for 6 months of maintenance. It was found to have a 95% success rate at 1-year follow-up. However, this was also combined with very rigorous lifestyle changes. So patients were asked to avoid douching, oral sex, sex toys, tampons, and even vaginal wipes. And they also had strict sexual hygiene practices. So they had to wash their genitalia prior to coitus. So, and these kind of strict changes have to be taken into consideration when we're recommending this treatment to patients. But the other topical azos have similar rates of recurrence in comparison to the oral regimen. So you do have a lot of options to tell your patients about. Trichomoniasis treatment is with what is recommended is metronidazole 500 orally twice daily for 7 days. And alternately, you can use tinidazole. However, because of the high recurrence rates with trichomoniasis, retesting is recommended after 3 months. Partner treatment is also advised, and it is important to advise the patients to abstain from sexual intercourse during the duration of therapy. We'll now look at some of the emerging trends in vaginal discharge management. So probiotics are a crowd favorite and a social media favorite. These are living microorganisms that have benefits to human health when consumed in adequate amounts. The lactobacillus species, these produce lactic acid, acetic acid, hydrogen peroxide, and biosurfactants, as well as other compounds that can help to prevent dysbiosis. They're clinically relevant because the current treatment options that we have, they often result in suboptimal cure, as we've discussed, or recurrence. And probiotics are in high demand, so we should be aware of what the evidence shows. Lactobacilli containing vaginal probiotics, they show promise in cure and prevention of bacterial vaginosis, but there's a paucity of evidence supporting their use in the treatment and prevention of vulvovaginal candidiasis. There's also some inconsistencies in the purity and potency of most lactobacillus probiotics, and this is due to variations in manufacturing controls. Lactin V, however, is being developed as a drug for human use, so it is more standardized. It contains Lactobacillus crispatus and was evaluated in a randomized controlled trial in 2020 and found to have some modest effectiveness in the prevention of recurrence of bacterial vaginosis at 24 weeks. It should be noted that many marketed probiotics do not actually have supporting evidence for the benefits claimed and are not currently recommended by Acog. Prebiotics are nutraceutical compounds. These will promote bacterial growth or support probiotics and endogenous beneficial organisms to the microbiome. So we have lactulose and lactoferrin. These have been investigated for use in the prevention of bacterial vaginosis. And these prebiotics either stimulate the growth of lactobacilli, as in the case of lactulose, or in the case of lactoferrin, will inhibit the growth of pathogenic bacterial organisms. In a small case series, lactoferrin was found to improve refractory bacterial vaginosis. The pre and probiotics can actually be combined as well to achieve a synergistic effect. However, further clinical trials are needed to really validate these therapeutic options. Phage therapy is not novel. This has been around for centuries, actually even before the discovery of penicillin. However, its popularity is increasing because of the increasing increasing prevalence of bacterial resistance or organisms that are resistant to antibiotics. So now we are revisiting this as a therapeutic option. Bacteriophages are essentially obligate intercellular viruses that parasitize bacteria. They are extremely host specific, so they can be used to therapeutically spare lactobacilli and promote vaginal eubiosis. Available phages are either naturally occurring or synthetic, and they carry a low toxicity to humans, and so their usefulness is there. Investigators are developing phages which can specifically target Gardnerella vaginalis. However, because we know that there are many other causes of bacterial vaginosis, it may be limiting its usefulness in clinical practice, but that is an area that's in development. Biofilm disruptors are another developing option for therapeutics. So as mentioned before, boric acid has shown success in the prevention and treatment of vulvovaginal candidiasis. And whilst the exact mechanism of action of boric acid has not yet been established, it's postulated that the boric acid actually inhibits the metabolic pathways of pathogenic organisms. So it prevents glycolysis or mitochondrial activity, and it thereby decreases the fungal load. It can also prevent recurrence of bacterial vaginosis if it is used after an acute treatment with metronidazole. So often I would have patients come in complaining that their boric acid is not really treating the bacterial vaginosis that they have. It is important to advise or to educate the patient that usually you have to treat the initial or the acute episode, and then the boric acid can be used to prevent further episodes of bacterial vaginosis, as it's more effective in these circumstances. Use of boric acid to treat bacterial vaginosis has to be paired with stringent lifestyle changes, so its success is based on that. Ethylene diamine tetraacetic acid has actually been combined with boric acid derivatives to create TOL-463, and this has antibiofilm properties, which in a phase 2 trial has been found to be safe for human use in the treatment of bacterial vaginosis, and its cure rates are actually 50 to 59%. So this may be more successful than boric acid alone as a future therapeutic option, especially in patients who prefer boric acid-based therapies for their bacterial vaginosis. Vaginal microbiome transplantation is an exciting and interesting, possibly scary option. It's based, or it was inspired by the use of fecal microbiota transfer in the treatment of Clostridium difficile. So essentially what is done, we have transplantation of the vaginal microbiome from a healthy donor to a patient who is infected. And in a small pilot study, it was successful in treating refractory bacterial vaginosis with this method. They actually achieved a 5 to 21 month duration of cure. However, there are significant risks associated with it, and we don't really know what the long-term consequences are. So you can have transfer of pathogens that we don't check for as yet, or even transfer of sperm and unintended pregnancy. So whilst it's an interesting method that's in development, it still needs some research and is not yet approved by or governing bodies for use. Telemedicine is one of my favorite things. Of course, this presentation is using, well, not telemedicine, but it's using telecommunications. So I'm definitely in support of it. However, we do want to avoid supporting patients doing self-diagnosis. I think I have exhausted that point. However, it's a very important concept to have. Patients should be examined. It's recommended by our governing bodies that we examine our patients who come in with a vaginal discharge and don't just assume based on the clinical history what the diagnosis is, because 70% of patients are being misdiagnosed. There are important consequences of not diagnosing our patients appropriately and treating our patients appropriately. So this should be stressed. Telemedicine is very useful in patients who are being treated for recurrent vaginal discharge. So we can use it for follow-up. Or if you have it available, you can use the BD Max vaginal panel. These are patient-collected samples, so you will have evidence of what organism is present, and that can make your diagnosis more accurate if you're using a telemedicine platform. So, in conclusion, vaginal discharge is a common presentation in clinical practice. It's often misdiagnosed, undertreated, or overtreated, especially when they're inadequately evaluated or self-diagnosed. Clinicians should be familiar with physiological discharge and be able to educate their patients about the variations of physiological discharge. It is recommended that patients with vaginitis symptoms be examined and properly evaluated to ensure appropriate treatment. The AMSOS criteria, microscopy, gram stain, nucleic acid amplification testing, cultures, all of these should be used where appropriate to aid in our diagnosis. Commercial point of care assays, especially, or patient collected samples, should be used. They are available, and many oral and topical treatment options exist that are fairly effective, but we should be mindful of the high rates of recurrence and how this can impact our patients. Lifestyle changes contribute to cure and prevention, and they should be employed. Although promising, or probiotics, phage therapy, and vaginal microbiome transplantation require more well-designed studies to evaluate their efficacy and are not yet recommended by Acog. I do hope that this presentation inspires someone to assist in the research of these options. These are my references. Thank you so much for listening. And do you have any questions?
Thank you, Dr. Watson, for such a comprehensive presentation. As the art of medicine is refined progressively, we certainly acknowledge and promote the modern approach to the management of the vaginal discharge. At this time, we will highlight some of the burning questions and comments submitted by the audience. So, Dr. Watson, this question was anonymously submitted. What is the ideal monthly treatment choice for recurrent vaginal candidiasis, and would you recommend the use of vaginal inserts for that purpose?
Thank you so much for that question. So as we know, we have many options, either topical or oral. So you can involve your patient in making that decision, and that also helps with adherence. So if the patient prefers an oral option, then you have the fluconazole induction and then the maintenance. And if your patient prefers an intravaginal option, then we have topical clotrimazole and the monthly boric acid. So between the clotrimazole and the fluconazole, we have more research that supports their use. With the boric acid, it's more up and coming, and you have a lot of contingencies, so you have to ensure that the lifestyle changes are done. So I would recommend we go with the recommendations of Acog, and we use either one, the fluconazole and the clotrimazole topical.
Thank you, Dr. Watson. So there is another question. Is there a role for the use of Sporosec in the management of bacterial vaginosis or vulvovaginal candidiasis?
Well, yes. So if I remember correctly, I really hope that the Sporosec is the itraconazole. That's the brand name, I think. Yes. Okay. So there is the great thing about the itraconazole is that it's actually very effective against Candida glabrata. So that's the one that's difficult to treat because it doesn't tend to come up on the wet mount, and also in patients who tend to have recurrent vaginal candidiasis, then it would be useful there. However, for bacterial vaginosis, where it's caused by a bacteria, it's an antifungal, so therefore it's not really treating bacterial vaginosis. Perhaps if the patient had a mixed vaginosis, it would be useful. And in those cases, if a patient comes with a bacterial vaginosis, then you would, if the patient comes with a bacterial vaginosis and you're not so sure what's happening, then investigating the patient with a test, seeing what is actually growing might be more effective, especially if you do a culture.
So there is another question. I've addressed it before. It was anonymously submitted. The ask, could you repeat the recommended treatment options for recurrent bacterial vaginosis?
Oh, sure. So you have fluconazole. You start with an induction. That's the 150 milligrams first on days 1, 4, and 7. So they're 3 days apart. And then you would repeat that dose for a 6-monthly course, and you do it once weekly for 6 months. That's if they want an oral option. If they would like to have the topical option, you have clotrimazole, 500 milligrams, that's given once weekly, and maintenance, which would be for 6 months. And then if you want the 200 milligram dose, you can do that twice weekly instead of the once weekly. And the vaginal boric acid is 600 milligrams, that's given vaginally for 5 nights, and then continued for 6 months maintenance with repeating that therapy. And all of these are available in the Acog practice bulletin as well on vaginosis.
Hi, Dr. Watson. Very good presentation. A lot of us in Jamaica do routine STI swabs or urine PCR, and a lot of us are getting a lot of asymptomatic bacterial vaginosis and ureaplasma. My question to you is, should we treat these, and do you have any input on this whole ureaplasma bacteria that is plaguing us? A lot of physicians have different approaches. I just want to know what your approach is.
Okay, so ureaplasma is one that's been popping up a lot, and there are benefits to treatment even in patients that are asymptomatic. The reason being, the presence of ureaplasma urolithicum is that it can cause increased risk of STIs, and it also can impact future fertility. So there is that role in treatment. However, if the patient seems to be colonized, perhaps we need to look at that. Is it just a colonization of the genital tract? In which case, then we may end up over treating patients, especially if they keep coming back and it's just present. So that's something probably we need to look at.
And what about the treatment of the asymptomatic bacterial vaginosis? Should we treat that as well?
Right. So in terms of treatment of asymptomatic bacterial vaginosis, it depends. For patients who have not symptoms of the bacterial vaginosis, but she has other conditions that might be, a patient who's coming for dyspareunia, or if she's coming for infertility, there may be a role in treatment of that. However, if it's incidentally found, some patients may actually clear it on their own, and on your review, you can see if they're still present.
Thank you so much, Dr. Watson. And I have a final question. This one is from me. So boric acid is now quite popular, especially in the social media sphere, and many persons are very profitable creating small businesses primarily focused on the sale of boric acid supplements and vaginal inserts, right? For women with vaginal discharge. What can we do locally and internationally to regulate and monitor these preparations, which our patients may want to experiment with from time to time?
Okay, so the first step is forums like this, where we educate each other and we encourage each other to speak to our patients and educate the populace. A lot of us are on social media and we do offer a lot of education, and we just need to promote that self-diagnosis is not the best idea. By promoting self-diagnosis, we're then leading to patients making the wrong diagnosis, self-treatment that is not good, because they then may ignore something that's more sinister, like malignancy or an STI, and then they may end up being undertreated. What we can also do is just speak to medical reps, other persons, to just get education out there without infringing on persons' right to do, what they want with their body, but we can just try to educate them. And I think that would help.
So much,
and
Dr.
Also,
Watson.
sorry,
Yeah,
and also
not
to knock what persons are trying to do, because sometimes I find that patients feel we're just trying to shove medicine down their throat. There is research that's showing that boric acid is helpful under certain circumstances. So if we take a perspective where we are open to learning from our patients and from each other, then they may be more receptive to what we have to offer, because sometimes when we throw away their choices, it may seem like we're trying to push something down their throats.
Right. Thank you so much, Dr. Watson. I appreciate your responses for those questions so far. Ladies and gentlemen, thank you for your questions. Dr. Watson will gladly respond to any further questions submitted in the chat box. At this time, we're going to have a word from our sponsors, Bayer Consumer Health, Ferring, and also Apex Radiology. We will also convene for a coffee break during this time. So ladies and gentlemen, these are our sponsors. Thank you.
Hi there, good morning. My name is Kelly Lopez. I'm Bayer Medical Advisor. Please let me tell you a little bit of information about Natel. Natel is a multivitamin and mineral supplement indicated for planning, pregnancy, and lactation. Natel is the multivitamin with 600 milligrams of folic acid and 30 milligrams of iron for each stage of pregnancy and lactation. Insufficient intake of micronutrients can increase complication and pregnancy outcome. Remember, this requirement during pregnancy increase at least 160%. Okay, in this slide we can see that many pregnant and breastfeeding women do not get enough micronutrients from their diet. This is the main reason supplementation with multivitamins that contain at least 13 micronutrients, including folic acid and iron, is so necessary and important. Micronutrients inadequacies are common due to low quality diets such as low amount of micronutrients and high amount of sugar or salt. Okay, adequate micronutrients intake during pregnancy and breastfeeding is the optimal foundation of the child's short and long-term development, including immune system, healthy development of cognitive and visual function, formation of strong and healthy bones and teeth, and metabolic health. To resume nutrition status prior to conception and during pregnancy and in infancy seems to have an influence on the disease risk in adulthood. It is also called early nutrition programming. With this slide, we remember that iron is an essential mineral for formation for red blood cells. Iron helps to reduce anemia. Lack of iron slows the intrauterine growth of the baby and leads to low birth weight. Also, vitamin D maintains healthy and strong bones. And finally, getting enough folate during pregnancy is so particularly important. This is because folic acid is crucial for early fetal development, particularly with regard to the spinal cord. With this, I can assure you Natel is the multivitamin and mineral supplement indicated for planning, pregnancy, and lactation. So now turn the page and let's talk about a little bit what is vaginal health. Like many things in life, there is all about balance, In healthy vagina, there is a balance among many kinds of bacteria. Some kinds of bacteria are considered the good ones and others are considered the bad ones. Good bacteria can keep the vagina a little bit acid. This keeps bad bacteria from growing too fast, but sometimes the bad bacteria and yeast can take over and cause some problems. So the vagina is a dynamic ecosystem that contains approximately more than 100 bacterial colony form units. An overgrowth of candida can cause a vaginal yeast infection. And the main reason of this infection are the following. Menstrual period can change the pH, hormonal change, excessive hygiene, using vaginal deodorants, washer, and perfume products, and also having sex without preservative. So, which are the causes that produce vaginal infection? In first place, we have bacteria. In second place, we have yeast or fungi. In third place, we have parasites. And let's talk about vaginal yeast infection. Basically, it's a fungi infection of the vagina and vulva, and is one of the most common gynecological conditions affecting women. With this slide, I want to emphasize the clinical difference between yeast and bacterial infection. Yeast infection symptoms are burning sensation while urinating, burning sensation during intercourse, pain, discomfort, itching, redness, swelling around the vagina or around the vulva. The discharge, this is particular, is thick, white, and clumpy discharge. So, difference number one, the typical yeast infection discharge color is white, thin and thick, clumpy texture like cottage cheese, like yogurt. Okay. Difference number two, there is no typical or specific odor associated with yeast infection. But in the other side, vaginal bacterial infection symptoms are a fishy odor which gets stronger during menstruation and after sex, burning sensation while urinating, discomfort, itching. The discharge in this type is yellow, gray, or even green. So difference number one, the bacterial vaginosis discharge color can be gray, yellow, or even green. Difference number two, there is no typical redness or inflammation around the vulva as with a yeast infection. Number three, tends to be uncomfortable rather than painful. Pain or burning during sex may be an indicator that is a yeast infection. Vaginal candidiasis may be associated with irritation on the vulva area. Therefore, concomitant local treatment with canesten can be used. You can use canesten B. 2% vaginal cream is recommended daily dose in the following way. 1 full applicator, 5 grams approximately intravaginal for 3 consecutive days, preferably at bedtime. But if you choose canesten B 1% vaginal cream, the recommended daily dose is 1 full applicator intravaginal for 6 consecutive days, preferably at bedtime. But you can also use canesten B vaginal ovule. Ovules 100 mg vaginal ovule once per day, preferably applied at night for 6 consecutive days. Maximum treatment time is 6 days. Do not exceed recommended doses. But if you choose to use or to buy canesten B ovules, 200 mg vaginal ovule, you have to use 1 a day, preferably applied at night for 3 consecutive days. So the difference and the main reason to use 3 or 6 days is depending on how many milligrams per ovule is your treatment or your cream. So finally, goals of the treatment with canesten B is kill yeast, recovery vaginal flora, relieve the symptoms, and regain quality of life. Now, do this with me. Inhale, exhale, and fill the air with clarity. So clarity, but why loratadine? Loratadine is an effective second-generation antihistamine with use in a variety of conditions, such as relief of pruritus. Remember, it can go into the central nervous system, so it does not cause drowsiness, dizziness, or alteration in psychomotor functionality. Let's remember the difference between Claritin and Claritin Core. Claritin is indicated for the relief of symptoms associated with perennial and seasonal allergic rhinitis such as sneezing, itching, and scratching of the nose or throat, also rhinorrhea and tearing. It is also indicated for the relief of symptoms and signs of chronic urticaria and other allergic dermatological conditions. On the other side, Claritin Core solution is indicated for adjunctive treatment with a systemic corticosteroid agent for the relief of severe symptoms of atopic dermatitis, angioedema, urticaria, allergic rhinitis, food and allergic drug reaction, allergic contact dermatitis, ocular allergic manifestations such as conjunctivitis reactions. Corticosteroids are well known for their anti-inflammatory and anti-allergic effects. The association of low doses of systemic corticosteroid and loratadine have proven to quickly relieve the symptoms and well-being in patients with a severe exacerbation of allergic rhinitis. And with this slide, I want you to remember the long-lasting system of clarity. So thank you for your attention and have a nice day. See ya.
Good afternoon, colleagues. I am Dr. Carleen McDonough, Chairman of Image Plus Consultants Limited, operators of Apex Radiology in Kingston and Ocho Rios. It is my pleasure to participate in this conference today to share with you our services and growth plans, which will support you to meet your daily goals in providing exceptional patient care. Founded in 1996, Apex Radiology has always had as its number one priority the well-being of our patients, the quality reporting you have become used to, and the relationship with our medical professionals across the board. Over the years, we have grown from a singular location with few modalities to 4 locations, 3 in Kingston and 1 in Ocho Rios. Our modalities include X-rays, fluoroscopy, ultrasound, CT scans, interventional studies, and more. We are excited to announce that in the coming weeks, we will be offering mammography from 2 locations, Malines Road in Kingston and our Ocho Rios branch. In the near future, we will also be adding MRI services at our Ocho Rios branch. We continuously look for opportunities to support the growth and capabilities of the medical offerings in Jamaica. In December 2022, our company took steps to raise capital by joining the junior market of the Jamaica Stock Exchange. Many of our medical professionals joined with us by investing in this venture, and we were very successful in raising the capital that will support our expansion plans, resulting in many benefits as we upgrade and expand our capabilities, enabling us to better serve you and the needs of our population. Image Plus Consultants Ltd, as we remain committed to emerging technologies, has a mandate for continuous learning and expansion of our team of doctors and radiographers annually. We support the training and practical experience of new radiographers, enhancing the quality and pool of persons available to support the industry. We remain committed to the island of Jamaica, our neighbors in surrounding islands, and our medical practitioners across the industry to grow and enhance the services offered to our community. Thank you, ladies and gentlemen, for this opportunity, and we hope the knowledge garnered today will go a long way in support of our industry.
Ladies and gentlemen, thank you so much for remaining online with us. And thank you to our sponsors, Bayer Consumer Health, Ferring Pharmaceuticals, and Apex Radiology. At this time, we will continue our presentations for the first segment of this inaugural joint meeting of the West Indies and Argentina section of Acog District 4. Ladies and gentlemen, please welcome Dr. Gregory Lewis, who will speak to us on the matter of minimally invasive surgical management of uterine fibroids. As an introductory, Dr. Gregory Lewis entered the medical field from the West Indies section, where he completed his Bachelor of Medicine and Bachelor of Surgery with honors in anatomy and biochemistry back in 2004 at the University of the West Indies, Mona. He later went on to complete residency and received the Doctor of Medicine in Obstetrics and Gynecology while training at the University Hospital of the West Indies in 2010. During his tenure, he won the award for the Best Oral Poster Presentation on his postgraduate thesis, a randomized control trial of vitamin E supplementation in the treatment of primary dysmenorrhea. This was done at the November 2012 Faculty of Medical Science Annual Research Day. Dr. Lewis also pursued residency in obstetrics and gynecology at the Rochester Regional Health in New York, USA, between 2016 and 2020. During his time, he received the 2017 Golden Speculum Award and the 2019 Resident Research Award. He graciously served as the Administrative Chief Resident in 2019 to 2020 at Rochester Regional Health. In 2020, he received his American Board of Obstetric and Gynecology certification. He also went on to successfully complete a fellowship in minimally invasive gynecological surgery at the prestigious Mayo Clinic in Jacksonville, Florida. And during that time, he received the 2022 Golden Stethoscope Award for his commitment to medical student education. At present, Dr. Gregory Lewis serves as an assistant professor in obstetrics and gynecology and a minimally invasive gynecological surgeon at the University of Florida College of Medicine. He has an impressive list of peer-reviewed publications and continues to stay current and adds to the school of knowledge in the obstetric and gynecology discipline. Dr. Lewis is a fellow of the Acog and a distinguished member of the American Medical Association, the Duval County Medical Society, the AAGL, the International Pelvic Pain Society, and the Society of Laparoscopic and Robotic Surgeons. Ladies and gentlemen, please warmly receive the esteemed Dr. Gregory Lewis at this time.
Good morning. Let me thank the organizers for inviting me to present at this Acog District 4 meeting. My name is Gregory Lewis, and I'm one of the minimally invasive gynecologic surgeons here at the University of Florida in Jacksonville. So my topic today is the minimally invasive surgical management of uterine fibroids. And the uterine fibroids are common benign monoclonal tumors that develop from the uterine myometrium. It affects up to 80% of women by the age of 50 worldwide. And we're aware that Black women do have a higher rate of fibroids than white women or other racial groups. Nearly half of these women are symptomatic, and they experience a significant impact on their quality of life, in that they'll get heavy menstrual bleeding, dysmenorrhea, chronic pelvic pain, obstruction of adjacent organs, particularly the ureters, and can develop hydronephrosis. And they can get a lot of pressure and bulk symptoms in the pelvis, as well as infertility have been related to development of fibroids. Traditionally, the mainstay of treatment of fibroids have been myomectomy or hysterectomy. However, the desire for uterine preserving treatment options has led to the development of alternative procedural treatments, such as uterine artery embolization, magnetic resonance guided focused ultrasound, and radiofrequency ablation. This is just a schema really showing the different procedural interventions for uterine fibroids, hysterectomy. We just mentioned the magnetic radio focused ultrasound, MRI focused ultrasound, laparoscopic myomectomy, hysteroscopic myomectomy, and uterine artery embolization as well. In about 2011, Monroe et al. Through the FIGO group classified fibroids according to the different location in the uterus. We have type 0 to type 8, and this has been very useful clinically, particularly for when we're talking about hysteroscopic myomectomy, the type 0, the type 1s, and the type 2, which I will get into later on as well. But this has been quite a game changer for those of us who do fibroid surgery, in terms of how we view these fibroids and in terms of how challenging sometimes it can be to meet our treatments to patients with the different types of or the different FIGO classification of their fibroids. Here's a schema of how we can manage uterine fibroids that are symptomatic for patients. I highlighted the ones that I'll pretty much discuss in this presentation: myomectomy, hysterectomy, uterine artery embolization, high frequency ultrasound ablation, laparoscopic radiofrequency ablation, and transcervical radiofrequency ablation as well. This slide pretty much talks about these different interventions and what are the ideal leiomyoma that typically can be used for these. For the laparoscopic radiofrequency ablation, for example, they're good for FIGO type 2 to 6, and fibroids that are around 7 to 10 centimeters. It's almost similar for the transcervical radiofrequency ablation as well. And for myomectomy, any fibroid, particularly 0 to 7, any size, the embolization, we look at FIGO types 3 to 6, and fibroids less than 10 centimeters. And then for the magnetic, the focused ultrasound procedure, FIGO type 3 to 6, and fibroid less than 7 centimeters. This table also looks at the reintervention rates after these procedures are done. And we see where the magnetic focused ultrasound has the highest reintervention rate at 36 months as compared to the transcervical radiofrequency ablation, which has about 8.2% at 36 months reintervention rate there. So when we're really putting together, talking to patients about their fibroids, we of course take a history and we do a physical examination. The next step usually is to get imaging to really delineate what exactly is going on with these fibroids. And ultrasound is really our first step, whether transabdominal, transvaginal, or sonohistogram, or what we call saline infusion sonogram, to look at the there are any intracavitary lesion, or shows up an intracavitary lesion much more. Transvaginal ultrasound really is what we do perform there. It's easily available, easy to use, and cost effective. But MRI is more accurate, more sensitive and specific in assessing the adnexa and the uterus, because it gives us more information regarding size, location, number, and the presence of any other uterine pathology, such as adenomyosis, if that's present. And of course, this is an ultrasound depicting a large anterior fundal fibroid. Here on ultrasound, we also see a large left lateral fibroid there. And if we're doing the ultrasound ourselves, we see where we can make a sweep and see exactly where the fibroids, get a good idea of where the fibroids are located here from this sinus clip here. As I mentioned, MRI is a very useful modality. Here we have two sagittal images showing the uterine fibroids, and we look at the axial image here. We see this pretty large, particularly fundal fibroid there that is delineated by the MRI, which really goes, gives us a little more detail than ultrasound would give us in terms of mapping these fibroids especially for pre-surgical planning. This is a patient of mine who had a posterior fibroid there, and this sometimes can be hard to reach even laparoscopically or robotically. But as I said, these sort of images from MRI give us a good view of where the fibroids are located and how robust we're going to need to be at surgery to tackle these fibroids. And there's another large fibroid uterus here from another patient of mine, and here fibroid was up to our umbilicus, but we decided to tackle this minimally invasively, and I'll show some videos subsequent to that. I'll talk just very briefly about the magnetic resonance high frequency ultrasound. As a minimally invasive method, it enables uterine preservation and eliminates the need for general anesthesia. And really what happens during this procedure, high intensity ultrasound is concentrated within the fibroid, and then this leads to development of necrosis. And this is what the necrosis that develops is really immediate, and that is what distinguishes it from uterine artery embolization. It was approved by the FDA in 2004, but I've not seen, in my practice, a lot of this being used. But just to know it's out there, and there are practitioners who would use this procedure to help patients with fibroids. Contraindications to this procedure would include patients, of course, who cannot have MRI, they have a pacemaker, if they are severely obese, if they have excessive scars on the abdominal wall, there's a high risk of thermal damage to the skin. When we're preparing patients for surgery as well, there are a number of adjuncts that we can use in order to help them to improve their pre and post-operative hemoglobin, decrease the fibroid volume, and even allow for a minimally invasive approach, even in patients who we thought that we were going to do an open procedure. And GnRH agonists have been really good in that area. Given 3 to 4 months before surgery, they can help to decrease fibroid volume. And we do, however, have to be aware of the effects of GnRH analogs. Try not to use it for more than 6 months because of the vasomotor symptoms, especially that patients complain of. Ulipristal acetate has been shown to reduce bleeding symptoms and fibroid size as well prior to moving ahead with surgery. Preoperative uterine artery embolization, I'll speak to uterine artery embolization as an entity on its own, but we recognize that there are practitioners who use, and I've actually used preoperative uterine artery embolization a day before, the morning of, or even weeks before as a planned surgery for a large uterine fibroid with a myomectomy, or for hysterectomy, where the blood loss at the time of surgery can be decreased. Perioperatively, to decrease blood loss, we can use misoprostol placed just in the pre-op area. Some people use up to between 600 and 800 micrograms placed rectally or vaginally. Tranexamic acid, 1 gram given intravenously before surgery, has been shown to decrease blood loss. Vasopressin, whether a minimally invasive approach or open approach, we give vasopressin to really decrease blood loss at the time of or myomectomy. And I typically would use 20 units now, 100 mils of normal saline, and by volume I try not to use for more than 30 mils, or what would lead to between 6 and 8 units at a time at one myomectomy. Pericervical tourniquet has been used as well to decrease blood loss at myomectomy, and the uterine artery occlusion, whether it's a hysterectomy or a myomectomy for large fibroids, we definitely can occlude the uterine artery and get some amount of help with bleeding there. Radiofrequency technology uses a slow methodical deposition of energy through a variety of electrode configurations to effectively ablate target tissue rather than a rapid and high temperature rise. And this results in a coagulative necrosis of the tissue in the treatment zone. And radiofrequency ablation also maximizes the target tissue ablation while minimizing the surrounding tissue damage. And currently there are 2 FDA-approved radiofrequency ablation devices on the market. The laparoscopic radiofrequency ablation device, or what we call the Accessor, that's made by Hologic. And then the transcervical radiofrequency ablation, the Sonata system, has been developed by Gynosonics. The radiofrequency ablation is an effective and durable treatment option for fibroids that affords sustained improvements in fibroid volume, bleeding, and the patient-reported outcomes with low reintervention rates. And I think I mentioned that before in one of the slides. And this is a setup for the Accessor procedure. It's a laparoscopic radiofrequency ablation procedure. And here we are demonstrating the optical access from the umbilicus with port for the laparoscopic and the ultrasound ports placed near the level of the uterine fundus. And the radiofrequency ablation trocar is placed percutaneously and directed into the target tissue under both laparoscopic and ultrasound guidance. The Accessor procedure, it utilizes a 5mm port for the laparoscope, a 10mm port for the laparoscopic ultrasound transducer, and an additional 2mm skin incision for the percutaneous insertion of the radiofrequency handpiece directly into the fibroid. And the entire procedure is controlled with a single tabletop field generator. Compared to the Sonata now, which is a transcervical radiofrequency ablation technology, it uses intrauterine ultrasound guidance to introduce a trocar within, with a deployable array of 7 needles, electrodes, into the target leiomyoma tissue. And unlike the laparoscopic radiofrequency ablation, the Sonata system incorporates both the ultrasonographic and radiofrequency component into a single handpiece that is inserted through the cervix. And the device accesses the leiomyoma from within the uterus without the need for incisions, unlike the Accessor, which you do have to make incisions on the patient's abdomen. I'm going to play a video here. This is a video that I presented at our last Acog meeting, and showing cervical radiofrequency ablation, the Sonata procedure. The authors have no financial disclosures. Radiofrequency energy thermally ablates fibroid tissue, resulting in coagulative necrosis, fibroid volume reduction, and the subsequent symptom relief. I'll fast forward this a little bit. I'll pause a little bit just to let you know that for this particular patient, we utilized both transcervical radiofrequency ablation and hysteroscopic myomectomy for this patient's submucosal fibroid. So she was a 41-year-old patient with abnormal bleeding and uterine fibroids, and she had previous myomectomy, that's 2-stage hysteroscopic myomectomy, robotic myomectomy, and she really wanted to keep her uterus. And she did not particularly was interested in future fertility, but did not want to lose her uterus. So we were able to go ahead. So this is after we had passed the ultrasound probe into the endometrial cavity, identify the fibroid that we're going to ablate. And then the device, we activated the device, sweep of the ultrasound to make sure we're in a good zone. And once we're in a good zone, this is what we call the overlay that we use to target the fibroid there, and to give us a good idea of where we're going to burn. Because of course, right after the uterus, you have bowel floating around. We don't want to burn the bowel. And here we are. We're about to deploy the electrodes into the fibroid to ensure that we get a good zone of ablation. And here's where the ablation is in progress. And we're keeping the device steady. And there are a number of safety features that this device allows to prevent us from causing any damage to any other structures. And what we're able to do, this was a pretty this part of the fibroid is 3 by 2 centimeters, as you can see on the screen. But we're able to do different zones of the fibroids in terms of ablation. And once we are done, we move to the hysteroscopic portion. So we ablated the fibroid, and then we moved again to the hysteroscopic portion where we resect most of the fibroid now that was intracavitary. And this was a type 2 fibroid. And I may just show you here.
Includes the use of pharmacology agents and cervical.
Okay, there it is. We're making use of 2 different tools in the toolkit to attack this fibroid for this patient. The radiofrequency ablation followed by the hysteroscopic myomectomy. So after radiofrequency ablation, mean fibroid volume decreased by about 47, 55, 66, and 71% at 3, 6, 12, and greater than 12 months respectively. And the change in the fibroid volume was consistent across the range of fibroid volume. And comparative studies of volume reduction found that fibroid-specific volume reduction was noticeably more significant. And we sort of mentioned this before for the radiofrequency ablation, followed by the uterine artery embolization, then the magnetic resonance focused ultrasound. So it's pretty a good tool that we have really to help patients who want to retain their uterus. And this is a slide again comparing the laparoscopic radiofrequency ablation versus the transcervical radiofrequency ablation. Outcomes are not really that much different. It's a matter of what you're used to, and I'm pretty much used to the transcervical radiofrequency ablation of fibroid. Now moving on to uterine artery embolization. The growing interest in uterus preservation in women with symptomatic uterine fibroids have placed uterine artery embolization in the forefront of new and invasive methods of fibroid treatments. It is performed by radiologists, and there is a decreased fibroid volume and thus pressure symptoms for patients, as well as a decrease in their bleeding profile. And here, usually the femoral artery is accessed and the embolizing material usually is polyvinyl particles to the uterine artery or to the vessels that are supplied the fibroids directly. Of course, appropriate patient selection is important. The need for pre-procedural pap smear and endometrial biopsy is important. You really just want that, they will send back the patient to us as gynecologists if this is not done for the patients. The patient desires future fertility. We have a discussion with the patient that this may not be ideal because their there are no long-standing robust data speaking to pregnancy after uterine artery embolization. Yes, patients have become pregnant afterwards, but there's also the risk of placenta previa spectrum with these patients who have had uterine artery embolization. So we really do counsel and caution our patients if they want to get pregnant, this might not be the ideal procedure for you. This is a patient of mine who had uterine artery embolization, and we got these pictures from my radiologist, and this sort of shows you the occlusion occurring there in the right uterine artery and in the left uterine artery. And the lack of vascularization of uterine fibroids leads to ischemic necrosis of the embolized tissue, which leads to hyaline degeneration and then eventually coagulated necrosis. And this process develops within months. And so, of course, you let the patient know that the results are not going to be immediate. This again is just an ultrasound picture showing reduction in the fibroid volume over months. Fibroid volume decreased by about 24%. Within 3 months when they did imaging. We have to also ensure that we discuss with the patient that there is a risk of post-embolization syndrome, where they can develop nausea, vomiting, abdominal pain, and fever. Post-embolization pain is real, and there is risk of infection, expulsion of submucous fibroids with uterine artery embolization. Uterine artery embolization versus myomectomy to treat fibroids. They have been studied. The biggest study is a FEM trial, and where it looked at these 2 interventions, uterine artery embolization and myomectomy, over 6 months, 1 and 2 and 4 years. And the primary outcome was uterine fibroid symptom, quality of life, questionnaires, and how these scores change over time. And the main outcome was at 2 years, they recognized that there was no real big difference in uterine artery embolization versus myomectomy at the 2-year mark in terms of quality of life and cost benefits. The choice on type of hysterectomy, we are talking about large fibroids. For a patient decides that they have completed their childbearing, we have to think about what route are we going to use, abdominal, laparoscopic, or vaginal route. And of course, it's based on the patient, the surgeon's training and experience and comfort in clinical practice guidelines of dealing with any of these, or doing a hysterectomy through any of these modes. The least invasive approach feasible should be used. We know that Acog still has that the vaginal hysterectomy is the most minimally invasive route, and there are persons who are pushing the envelope in terms of how large a fibroid they'll remove vaginally. We can sit and morcellate, and I'll show some videos out regarding morcellation shortly. Morcellate even large fibroid uterus vaginally, so that a large fibroid uterus doesn't exclude us doing a vaginal hysterectomy. But when we're tackling the large fibroid, we have to remember that not all large uteri are the same shape and size. There can be projection of the fibroids into the broad ligament. We might have to enter the retroperitoneal space to occlude those uterine arteries, or to get hemostasis. When the fibroids are large, surgeons might say, well, I cannot see around to get to the pedicles. Well, you can use an angle scope, and that's what I do employ in my practice. I use a 30-degree scope to really essentially see around corners when the large fibroids are obstructing my pedicles, to be able to control bleeding and complete the hysterectomy in a minimally invasive manner. There can be manipulation failure, and I'll show a video where we were not able to pass a manipulator for a different reason, but there can be manipulation failure because the fibroid is so large and you really cannot get to manipulate or move the uterus much. So these are the things we have to think about when we're going to tackle the large fibroids at hysterectomy. When we talk about robotic assisted laparoscopic or abdominal myomectomy, we know that minimally invasive surgery like laparoscopy is associated with reduced blood loss, lower rate of post-operative complications and pain, shorter hospital stay and recovery. So it really is the ideal way to go. And as well, better pregnancy and live birth rates have been associated with laparoscopic myomectomy than the abdominal route. So we definitely try to offer our patients a minimally invasive route as much as possible. I'm going to show some videos looking at the robotic myomectomy that we've tackled, done for large fibroid. And this was a large single substrosal fibroid. go ahead, we inject vasopressin and ensure that we get good control of bleeding. So after we inject our vasopressin, then we'll go ahead, I'll speed this up a little bit. I'll just go back a little bit to show you. We make that transverse incision. Ensure that we're away from the tubes, it's into the fibroid. We ensure that we're able to get down to the capsule, and now we are enucleating the fibroid. And here we keep working gingerly, keep on going until we got down to the base of the fibroid there. And now that we have removed the fibroid, I typically use a barbed suture, and here I'm using a barbed suture to suture the defect, closing on the dead space there. And this is a V-lock suture that I'm using to close the defect in layers. And speeding up that a little bit. Then on the slow side, do a baseball type stitch. And in this patient, we had a uterine manipulator. Here is another large fibroid. After injecting vasopressin, we make our incision, ensure we get down to the capsule. There. Okay, we're back in business here. And we continue to work gingerly, enucleating the fibroid, making sure we're in the correct plane. Once we're in the correct plane, blood loss is not much of an issue. Sometimes we are not in the correct plane, we encounter more bleeding. And here we are moving along, taking out this large fibroid here. Here we keep working. And so for my practice, I typically will do my myomectomy via the robotic route, unless it's a single fibroid that I can really take out laparoscopically. I can suture laparoscopically, so that's not a big issue. It's just that with the robot, it's offer better ergonomics for me in terms of moving the fibroid and in terms of suturing. But less toll on the body as we look more and more into surgical ergonomics. And here we are suturing the large defect in layers, same principle as the first fibroid there. And here we are. And then I'll just show some other videos of how we took that large fibroid outside the uterus. And I'll move on to the next video because I'll just show that same fibroid there. So here's another robotic surgery, same principle, but this is multiple, as you can see, subserosal fibroids. And this fibroid, as you can see here, is really right on the fallopian tube there, so we had to be very careful with removing that fibroid. But certainly we can, there we are coagulating its base there, making sure we're still away from the tube, and then we eventually were able to get that fibroid away. Moving that fibroid there. And then here you see what I do when I have multiple fibroids to remove. We string the fibroids along. So this is not suturing the defect. This is just attaching the fibroids so that they don't get lost in the patient's abdomen. And it has happened before where you keep working, you're taking out fibroids and one or two other fibroids go missing. But when you put them, as it were, a string, pearls on a string, you cannot lose the fibroids. So it's easy to retrieve at the end of the case. And we just tack the string to the anterior abdominal wall to take out and morcellate afterwards. And here we have taken out all the fibroids, sutured all the defects, and here we have our fibroid on a string that we're putting in a bag now, and then we're going to morcellate through the abdomen. And here we are with our knife, and we brought up our fibroids to the abdomen, and we're morcellated the fibroid there. Okay. And as I said, I don't do a lot of laparoscopic myomectomy, that means straight stick myomectomy, but here's me performing one. Here, we don't have a uterine manipulator. The patient was virginal, and so we, in order not to necessarily pass the manipulator and cause any anti-trauma. Here we are using proline to elevate the uterus and to give us a good view of the fibroid that we're going to remove there. But this is the same principle as robotic myomectomy. You inject your vasopressin, you make your incision, and then you ensure you get to your plane, and then you go ahead and remove your fibroid there. And here we're working to remove the fibroid with our assistant, and we keep working there, keep working. And here we're suturing the defect again with a barbed suture. No need to tie knots with a V-lock suture. And keep suturing there. And for those of us, as you know, as we practice, larger fibroids, sometimes we have to do abdominal myomectomy. And you can compare and see that the blood loss is in fact less with the minimally invasive approaches as the robotic or strategic laparoscopic myomectomy. And there's your finished product there for the laparoscopic myomectomy. One of the newer features is the fact that we can actually use intraoperative ultrasound. I guess much like the accessor procedure or the laparoscopic radiofrequency ablation, we have the BK probe that we can pass laparoscopically to identify where fibroids are. Because at laparoscopy, we don't have that, we've lost that tactile sensation, especially as it pertains to robotic myomectomy. And so the ultrasound probe will allow us to really identify those fibroids that we cannot easily see. And in one study by Ho and others, they reported an additional 140 myomas detected using the laparoscopic ultrasound BK probe among 78 women undergoing laparoscopic myomectomy. So this is a useful adjunct to, when you're performing laparoscopic myomectomy or robotic myomectomy for that matter. I'll quickly just go through, look at morcellation. After we've taken all the large fibroids, we have to extend our incision now in order to get a large bag or a bag big enough to hold all the fibroids, or if it's one large solitary fibroid. So here we are placing an Alexis retractor there to be able to get our bag in. And we're just using a gel port here to ensure that we secure gas. Here you're seeing we're placing the large bag into the abdomen to place a fibroid in the bag, and then we bring the bag out through the incision. And here we are bringing the bag up through the incision, bringing the bag up through the incision. We roll the bag down, and now we're going to manually morcellate. And we morcellate using what we call the extracorporeal C incision technique, or excise technique, pioneered by Arnold Advincula at Columbia University. And I'll just pause here to say that when we talk about morcellation, back in the day, there used to be, I've never seen the power morcellation because it's been off the market. That one patient who developed uterine disseminated leiomyosarcoma after the pore morcellation threw all those chips in her belly, and then the FDA took the pore morcellation off the market. So a lot of us are not really in that zone where we're doing pore morcellation, but a lot of persons, there are some persons, I shouldn't say a lot, but there are some persons who are still doing pore morcellation. And there's this new onboarding of pore morcellation in a bag where you don't have myoma chips flying in the abdomen. And some persons have adopted that into their practice. Here again, this is from my colleague Sarah Cohen at the Mayo Clinic. Here, similar procedure where we place the bag in after we remove the fibroids, and this is us showing the technique of getting the fibroid into the bag, up to the incision, and then morcellating. This is a similar video to the first one, and here we are rolling the bag down again and going to do the morcellation. Similar thing again, we're here, we're morcellating. This is contained morcellation. Notice with the fibroid in the bag, that's the sort of technique where you just pretty much peel the fibroid around, and I just wanted to show you there. You can remove the fibroid safely without disseminating it in the pelvis, and the incision is still small. You can close the incision there, and the patient have a minimally invasive laparoscopy. I just want to highlight here that sometimes we do place interseed over our incision to decrease the chance of any adhesions formation. And I had mentioned vaginal morcellation, but this is just a video showing that you can actually do colpotomy, where a trocar is actually placed transvaginally after your myomectomy to place the fibroid in a bag. Now we'll just play it from here. And here are all the fibroids that were removed. Trocar was placed in the posterior, colpotomy was made. The bag was introduced through that trocar, and then the fibroids are placed in the bag. So there was no need to extend the abdominal incision. Now after the fibroids are removed, then you go ahead and suture vaginally or laparoscopically. And here, even if the fibroid is large, you can vaginally morcellate to get the fibroid out. And here we are suturing laparoscopically. And once you, here we are, once you've taken, morcellated your fibroid, sometimes we morcellate it in one string and we call it a necklace. And this is me and my colleague, Dr. Karuba. We morcellated for a while there to get this fibroid out. I'll just move on to hysteroscopic myomectomy, and I'll pretty much show videos for that. And I really wanted to just highlight here that there are different ways of doing hysteroscopic myomectomy. We can use a loop electrosurgical resection, and there are also mechanical tissue removal systems. I typically use what we call the MyoSure. I know that there's a TrueClear available on the market. And then there's mechanical tissue extraction with scissors, but this is not really used much for myomectomy, more so for polypectomy. I just wanted to show that particular from this video. And here we are now with the tissue extraction device. This is the MyoSure, or I use what we call the MyoSure XL for large submucosal fibroids. And we place the device against the myoma, activate the device, and pretty much choose a fibroid. And that's what's happening here. And we continue to chew out the fibroid, here. You might ask, what are those blue things that are floating around? This was a patient of mine who actually had a uterine artery embolization prior, and then continued to have heavy bleeding some years later, and the submucosal fibroid was noted. And so this is actually the embolization particles that you're seeing here from the fibroid. But we kept on working with the tissue extraction device, rotating it, and until we got the fibroid almost removed. And the video after this one still is the same patient, same tissue extraction device working to remove that fibroid. And here we are. The end product, the endometrial cavity is now free of fibroid. Now the hysteroscopic myomectomy, but this time we're going to be, we do a full survey once you get in. Still using a tissue extraction technique. Here you are, sometimes you have to go again because of visualization, but you want to ensure that you only activate the blade when you're seeing well in the uterine cavity. Now the hysteroscopic myomectomy video there. And this is what I wanted to show, that now we're using the electrosurgical electrode. For hysteroscopic myomectomy, you have to use a fluid management system. You think about what your distension media is going to be, depending on if it's a bipolar or monopolar device that you're using. This is a bipolar, so our distension media here is saline. We have to think about fluid deficit when you're doing hysteroscopic myomectomy. Be careful about uterine perforation. If there's bleeding, we can use tranexamic acid or vasopressin as well, intracervical vasopressin. And here we are going ahead, resecting the fibroid. And with the electrosurgical loop, we have to think of, one of the things is the bubbles and the fibroid chips. So you do have to take out the hysteroscope and you do have to remove some of those chips. And there can be a lot of bubbles in your field, which can obscure your view. But still, it's very doable. And really, once you get these fibroids out, patient's cavity is clean, and they can go ahead if it's a pregnancy they want to afford, and their bleeding profile will be better. So let me briefly talk about V-nodes. So on the horizon is a vaginal natural orifice transillumination surgery, and this is me and my colleague Dr. Chen. We're operating laparoscopically but vaginally through the V-nodes procedure. Here we were doing a hysterectomy, not for abnormal uterine bleeding. She had fibroids weren't particularly large, but one of my other colleagues just did a 24-week size uterus via V-nodes vaginally. Of course, it took her a while to morcellate that size uterus, but the patient went home the same day after the surgery, had no incisions on her abdomen. So, I'm going to be pushing the envelope and taking on some of these large fibroids. Hysterectomy first via the V-nodes, but there have been studies out there talking about the use of V-nodes for myomectomy, where you actually can do the surgery vaginally, remove those large fibroids. And Dr. Bakeland actually has done, she published her case series of 114 patients, or a retrospective study rather, on doing a V-node hysterectomy for large fibroids. So the fact that the patient has a large fibroid doesn't mean that they cannot have a minimally invasive approach to their surgery. It's just how much we're going to push the envelope to get the patients there. So in summary, uterine fibroids can be managed by a number of minimally invasive interventions. It depends on the desire of the patient, the size, location, number of fibroids, and the surgeon's experience. The approach, however, should be individualized. The outcome metric that we look at is improvement in menstrual blood loss, fibroid volume, the patient's general quality of life, and their fertility outcomes and desires. The different surgical procedures that we aim to adopt would be ones that decrease operative time, ones that decrease intraoperative blood loss, and those that offer faster recovery to our patients and return to work. So there are a number of different options that we can for our patients, and really in a minimally invasive manner have these patients to regain functional control of their life, and as I mentioned, go back to work in a shorter period of time. Again, I would like to thank the organizers for having me present at this conference, and I'll take any questions after this presentation. These are my references. Thank you.
Thank you, Dr. Lewis. We are delighted to have listened to such an enlightening review on the minimally invasive surgical management of uterine fibroids by the established Dr. Gregory Lewis. A clear understanding on the management of uterine fibroids is basically the bedrock to the practice of every gynecologist. So at this point, we're going to take all the burning questions from our audience. Beautiful. So, okay, so one of the first questions, how does insurance reimburse for surgeries using the dual technologies such as operative hysteroscopy and sonata procedure in a single surgical setting?
Right. Thank you for that question. It's a very good question, and one of the things with new procedures coming in vogue is usually the talk of insurance reimbursement, especially here in the States. So for most of our patients, we try to get a pre-authorization before these radiofrequency ablation procedures. Some insurance will not cover it, and we have to do an appeal. And so what we have now with the reps from like Hologic or Gynosonics, what we do is we get a letter from the reps and we actually put all the studies out there together and send it to the insurance company when we are appealing for them to reimburse. So it's always been a challenge, and we do try to get pre-authorization, but depending on the insurance that the patient carries, you know, they will get reimbursement for it. And for those patients who really want this procedure and the insurance doesn't cover it, it's expensive, but some patients will pay out of pocket. But it continues to be a uphill battle. And once there are more studies out there, you know, we can furnish the insurance company with these studies that it's not experimental. This will improve the patient's quality of life and decrease their morbidity, and they generally will reimburse us for those procedures.
Okay, thank you. So essentially, we just have to approach the insurers and the undertakers for that. Okay, Dr. Lewis, there is another concern from one of our audiences with relation to morcellation at the time of laparoscopic surgery. We're asking for a little more clarification in terms of the safety of this at the time of laparoscopic surgery.
Another very good question. So the power morcellation is pretty much out, or there've been a lot written about the power morcellation. That's when you just morcellate the fibroid or the uterus, you know, open in the abdomen at laparoscopy. So all the videos I've shown you, it's morcellation in a bag. So we place the fibroid or the large uterus in a bag, and we actually, so I use the term morcellation loosely, we're actually just peeling out the fibroid essentially, but it's all in a bag. So the chance of any of those myomas, that your myoma falling into the abdomen, is almost none. I mean, occasionally you might lose the integrity of the bag, but we try to be very careful to morcellate within the bag. So if we're talking about what has been off the market, is just morcellation in the open abdomen where those fibroid chips can fall and the patient had underlying sarcoma, or the patient can develop parasitic myomas in the abdomen subsequently. And there's a new power morcellation where it's the pneumatic power morcellation, we actually morcellate with a power morcellator in a bag. That's coming on vogue, and some practitioners have adapted that. I have not adapted that into my practice yet. I still continue to manually morcellate, where I hold on to the fibroid or the large uterus and use a knife and do the excite technique, as I mentioned in the video. So that's where we're at presently in terms of manually morcellating. So we're in the States to manually morcellate, but the power morcellation is what we actually do.
Thank you so much, Dr. Lewis. That certainly does provide more clarification. We have one more question in our chat. So the question was, what is the rate of recurrence of uterine fibroids following the use of radiofrequency ablation, irrespective of the method?
Right, so of course, the two main methods are the laparoscopic radiofrequency ablation and the transcervical radiofrequency ablation. So there's not a lot of data, or we probably won't know exactly what the recurrence rate is, because some patients might recur and they're not that symptomatic. So we actually look at is the reintervention rate, and as I showed on one side, about 8%. The last review by Sarah Cohen from Mayo Clinic in Rochester and her team, it's about 8 to 11% is a reintervention rate after radiofrequency ablation. And it's really the radiofrequency ablation has one of the lowest reintervention rate compared to like uterine artery embolization or magnetic radio focus ultrasound. So what we look at really now is a reintervention rate, which is about 8 to 11% at about more than 12 months or up to 36 months.
That would be in the postmenopausal age range? Or for women, actually for women who have completed their families? Okay, all right.
Still in reproductive age group, rather, where they would have come back and have symptoms again after the radiofrequency ablation has been completed, and then we would need to re-intervene to do something about their fibroid, whether it's now a myomectomy or a hysterectomy subsequently.
Excellent presentation, Dr. Lewis. Great to see you again. I know you do a lot of work with the Sonata, or the ultrasound transcervical radiofrequency. Could you just briefly give us the criteria that you use in offering this modality to patients?
Right. So for the patients, so fibroid, if the fibroid is greater than, well, 7 centimeters, it's more likely to fail. I know, as I said before, we have been pushing the envelope to include patients who are fibroids maybe up to 10 centimeters, but I typically would not do a patient whose fibroid is more than 7 centimeters. If the patient desires to become pregnant, I will counsel them against it because there's not a lot of robust data regarding the use of the radiofrequency ablation in patients who wants to retain their fertility, but particularly for those patients who just want to, don't want to have a major surgical procedure, or patients who just want to retain their uterus. If they have a number of submucosal fibroids, I tend not to offer these patients. Even I just show you the video where we did a hysteroscopic myomectomy and radiofrequency ablation. It'll be too much in one sitting. Even at some points, I do a staged procedure where you bring them back, remove fibroids again. But for me, generally, it's the size of the fibroid, the location. If I have fibroid extending into the broad ligament, I'm not very confident of the overlay of how much you get thermal damage into adnexal structures or into the retroperitoneal structures. So I tend not to do it for those type of fibroids. With fibroids less than 7 centimeters, patient with bulk symptoms, patient or abnormal bleeding, those are the patients I tend to do it for. And I tend not to do it for more younger patients. If you're less than 30 years old, I try not to, because the intervention or success rate is going to be less because you have a longer span within your reproductive age group for recurrence or for symptoms to recur. So that's typically where I draw the line in terms of patient profile for the radiofrequency ablation procedure.
Right. Thank you so much, Dr. Lewis. Dr. John Harriot, he has a question. He would like to know, what are your views in terms of the whole morcellation being banned in several European countries, as the Karl stores has actually withdrawn their in-bag technique? What are your views on that?
Well, I believe, it is somewhat when one case of adverse outcome, is used to make a blanket statement across the board. Sometimes I think it is unfortunate. It's unfortunate that case would have occurred where the patient developed leiomyosarcoma subsequently. But to place a broad brush ban on morcellation, I think it does somewhat of a disservice to patients, because what happens is that, well, for the large uterus or large fibroids, those practitioners are forced to make mini laparotomies for these patients. So you do your surgery in a minimally invasive approach, and then because you cannot morcellate, you do a mini lap to remove the fibroids, which is fine. I do not knock my colleagues who do that. Sometimes the patients are allowed to go home the same day, but when you look at the pain profile, the patients will have more pain. The recovery does take a bit longer. So for me, morcellating in a bag, I believe it is safe, where I do it vaginally or abdominally after a large fibroid or a large uterus with fibroid there. And I believe it's safe. I try not to lose integrity of the bag, and I try to be as careful. If I'm struggling, I will extend incision a centimeter more to give me more working space. So generally, I still believe that there's a role for morcellation, and we just have to continue looking at the numbers and see if we're really heading in a direction where this is unsafe for patients generally. And in my experience, I don't think so. So I think there's still a place and a role for contained tissue morcellation and extraction of large specimen in a bag.
Thank you so much for sharing your views, Dr. Lewis. We appreciate that. At this time, I'm just going to encourage our audience to add your remaining questions to the Q&A section rather than the chat box or the chat on the Zoom platform, so we're able to identify and directly answer your responses. Answer your questions. Okay, so thank you so much for your questions. We certainly do hope that the principles explained by Dr. Lewis will positively influence our future best practices as we treat our women who present with symptomatic uterine fibroids. At this time, ladies and gentlemen, we're going to have a quick word from one of our sponsors, Indus Life Sciences.
Good afternoon, everyone.
Good afternoon, Mr. Dyer. Thanks for joining us.
Yes, Mr. Sam, thank you. I'm just sharing my slide.
Yes, thank you very much.
Yes, sir. Do you see it?
We can see it now, yes.
Thank you.
We're not seeing you, though.
Oh, really?
Okay, I see you now. No problem.
Thank you very much. Afternoon to the panelists, presenters, attendees, and moderators from Indus Life Sciences. Thank you very much for the opportunity to come on board for this ACOG 2023. I just like quickly to remind one of our brand, which is recommended for pregnancy, even for pregnant mothers, I mean. So Indus Life Sciences, for those who are not aware of it, we are based in Jamaica, 3 Carrick Avenue, Kingston 11. And we operate in most of the English-speaking Caribbean countries, right from Jamaica, Guyana, Barbados, Windward Leeward Islands, Cayman, Bahamas also. So one brand that we like to just present it today is for a digestive system, especially for those who complain of heartburn, hyperacidity, gastritis, flatulence, or acid reflux. There's no need always to start with an H2 receptor or proton pump inhibitor. Sometimes a simple antacid can give best solution for that. So, but when we talk about antacid, the question is that which is the right antacid? As you go to the pharmacy, you could see different label of antacids with different brand names, starts from D, M, or whatever brand it is. So I'm not bashing any of the brand. To identify right antacid, the antacids are classified as generations. Some of you may be very new to know that, but that's how the antacids are being classified. The first generation antacids are the oldest one, and these antacids are meant to only neutralize acidity, as because they offer the ingredients like magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate. And they have no other action other than neutralizing acidity. So there is a gap in the sense they can't have any action on those suffering from acid reflux or maybe heartburn or pain or gas problem. That's where the second generation antacids came in. Honestly speaking, today in most of the Caribbean countries, the second generation antacids are available, which apart from neutralizing acidity, can also help to relieve gas, because they offer the medications, as you could see in the slide, dimethicone or simethicone. Role of this medication is to relieve excess gas that disturbs the patients who suffer from acidity. But unfortunately, there is a gap again with the second generation. The gap is they have no answer for GERD, which is basically gastroesophageal reflux disease, which is a throwing up of stomach acid content from stomach into the esophagus. So honestly speaking, today, all brands of antacids that's available across Caribbean are classified as second generation antacid till Indus Life Science introduced the new generation, which is called as the third generation antacid, which is currently available across Caribbean countries, especially the English-speaking Caribbean, which is new gel. I request you to read it as first time in Caribbean, rather reading it as first time in Jamaica. We have the third generation antacid that is available. And as you could see in the slide, it has a new ingredient on it, which is called as alginic acid. For those who are not familiar with alginic acid, it is basically an algae. And how this algae helps the patient is that this algae, alginic acid, helps to relieve GERD or stops GERD. Those who suffer from acid reflux, heartburn because of GERD, it stops it. How does it stops? It is like this. When they take this antacid, the alginic acid in this antacid, which you're going to see in the next slide, the brand name, this alginic acid mixed with the stomach acid contents and forms a foam. And this foam floats over the stomach acid content and acts like a cap, like a barrier. And this does not allow the stomach acid content move up into the esophagus. As we all know, the mucous membrane of the esophagus is much softer than the mucous membrane of the stomach. When acid enters into the esophagus, it causes a heartburn, which is basically we refer as GERD. So this foam formed by the alginic acid prevents the acid content of the stomach moving up from the stomach into the esophagus. To understand it better, I have a small clip. If you could see the clip, you will understand it better how this alginic acid works. This is how it is. They take the antacid that Indus has introduced. When antacid touches the stomach acid content, the alginic acid in this antacid mix and forms a foam. And this foam floats over the stomach acid content. Whenever the acid tries to move up into the esophagus, it blocks. Any number of times, repeated times it tries, every time it is blocked. Thereby, there is no GERD, no heartburn. This foam alginate raft is formed in just 4 minutes and stays literally more than 5 hours. After that, it gets completely excreted along with the stomach content. No residue is left. So that's the benefit of the alginic acid. And we are the first brand that has come with the alginic acid, that is New Gel. This is the brand name of the antacid that we introduced, New Gel. New Gel basically refers to new generation antacid gel, that is New Gel. And interesting for gynecologists is this is safe in pregnancy. I mean, in all the 3 trimesters, first, second, and third trimester of second pregnancy, it can be considered. And it's also safe in diabetes as because it is sugar-free antacid. As we say, it is safe in pregnancy. Obviously, it's safe in children, even those who are less than 10 years of age. If there is a need, they can be recommended this New Gel. In Caribbean, across all the countries, it is registered as over the counter. So the patients or person who needs this antacid can go to the pharmacy and buy without prescription. It comes in 3 pack sizes. I can share it. The one which you see is a 200 ml standard pack size, and the dose is normally 10 ml 2-3 times a day. It can be given. It has a mint flavor, which has a benefit of digestion too. And also, I'd just like to highlight one more point here. As you could see in the slide, the acid neutralizing medications like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, they are in balanced formula of 250 milligram each. Why I mention this is that if one of them is in higher concentration, it may cause either diarrhea or constipation. So this New Gel will not cause that diarrhea or constipation. So, and we're not stopping here. Actually, we have one more presentation of the same, which we, as a nickname, we'll address it as mother of all antacid, because this antacid has additional benefit of relieving the gastritis pain, because it has a medication called as oxytocin, which is similar to lidocaine, but oxytocin can be taken orally. How this helps? Oxytocin gives a coating to the stomach wall and relieves pain associated with gastritis. So any of a patient has pain like, ulcer pain, during ulcer pain, when you recommend New Gel O, it relieves pain, it stops GERD, it neutralizes acidity, and the simethicone relieves gas. So this is again available as over-the-counter across Caribbean. The difference between New Gel O and New Gel is New Gel is safe in pregnancy, but New Gel O is not recommended during pregnancy. So it's not recommended for pregnant mothers. For rest of the population, non-pregnant women and those who are about 10 years of age, New Gel O can be recommended. In case it is a pregnant mother or children of less than 10 years, it is better to recommend New Gel. So this is our New Gel and New Gel O and the indications. And New Gel and New Gel O can be prescribed along with the regular proton pump inhibitors, or even for H2 receptor blockers can be given. The benefit of this is that the relief will be faster. The action kicks in, which is less than 5 to 10 minutes. That's the benefit of the antacids. And this is the pack sizes we have currently in Caribbean. We have standard 200 ml pack size. We do have 100 ml pack size. And also we have single dose sachet, which is 10 ml liquid. So especially those who are traveling a lot, or those who visit restaurants or working in the office, if you don't find it comfortable carrying a bottle with you, you can just carry the dose, which is 10 ml liquid pouch sachet, where you can just tear it up and drink it. So that is also available in both the formulation. It is there. That is New Gel and New Gel O. And just like to refresh one of our vaginal insert that we carry, that is our Dresvi. Especially in Caribbean is very popular, especially in Jamaica also is #1 brand, which is a combination of metronidazole with miconazole. And this is a gel formulation So the benefit of the gel, quick onset of action, and this brand comes with 5 applicators. So each applicator can take up to 6 grams of the gel. So it is recommended for 5 nights. So it's just for 5 nights. I'm each night 1 applicator of 6 grams of the gel for 5 nights. That makes 30 grams of the tube. So dress V is, maybe we can just say dress V coined it just to communicate dressing the vagina. So that is there. And also we have plain clotrimazole, which is clotrinavir is available. It is pessaries of 6 pessaries are there with 6 applicators. And also the last is not the least is a amino pep, which is ideal for pregnant mothers also, as it has folic acid plus zinc is also there, plus all vitamins and proteins is there. This is actually the composition of amino pep. So this is an indication of amino pep, and this is a pack that you will see. And this is again over the counter. It can be purchased without prescription. So the last 5 good things to have a healthy life: please exercise every day, just 30 minutes or so, and have nutrition food and drink adequate water, have nice sleep, good night's sleep, and please don't forget to take amino pep. Thank you very much. Thanks, Mr. Sam.
Thank you so much, Indus Life Sciences. Ladies and gentlemen, we are at the final section, final presentation of the first section of this inaugural meeting of the West Indies and Argentina sections of Acog District 4. Thank you for remaining with us online so far. We are quite behind time at this moment, so we will be changing the schedule a little bit. We will incorporate this final presentation into the lunch break. And at this time, I want you all to shift your focus to the topic of navigating the infertile couple journey efficiently, where best practices mean best results. And this will be presented by the distinguished Professor Samuel Ramsewak. Professor Ramsewak graduated from the UE Mona with the Bachelor of Medicine and Bachelor of Surgery, and he also received honors in pathology and microbiology. And he also received the prize for outstanding achievement in community medicine. Professor Ramsewak subsequently did residency training at Manchester and Sheffield in the United Kingdom. He has produced distinguished work, including his postgraduate research thesis, which examined the effects of chlamydia trachomatis on reproductive function, specifically the detection of chlamydia trachomatis by PCR in fresh fallopian tube tissue removed from ectopic pregnancies. This work was substantially funded by the prestigious Wellcome Trust, and through this, he received extensive recognition and is MD in ONG. Professor Ramsewak remains a pioneer in the field of reproductive medicine within the Caribbean. He founded the first IVF clinic, and he was instrumental with his team's achievement of the first successful IVF pregnancy, as well as many other firsts in assisted reproductive medicine within the West Indies region. Professor Ramsewak has published his own book entitled Basic Practical Gynecology, which most of us have used. And he has also written several chapters from internationally renowned books in gynecology. Professor Ramsewak has also authored over 70 scientific peer-reviewed publications in obstetrics, gynecology, and infertility. He has earned multiple awards for his exceptional work in the gynecological arena, including the Chaconia Silver Medal, the Commonwealth Research Fellowship in 1989, the 1994 Rhodes Trust Scholarship, and in 2001, he received the Award for Distinguished Service by the American College of Obstetrics and Gynecology. He also received the Annual Research Award for Trinidad and Tobago through Medical Association in 2005, and he was awarded the Scroll of Honor in 2014. More recently, he received the Nyhurst Icon in Science Award and the Caribbean Curriculum Science Award He is currently a fellow in the Royal College of Obstetrics and Gynecology, the American College of Obstetrics and Gynecologists, as well as the Royal College of Physicians and Surgeons in Glasgow. He remains a fellow of the American Society of Reproductive Medicine and also the European Society for Reproductive Medicine. He also served as the Dean of the Faculty of Medical Sciences in the University of the West Indies in St. Augustine for approximately 8 years. And in 2018, he was conferred the title of Professor Emeritus. Professor Ramsuak is certainly among the best in the field and is quite qualified and distinguished to speak to us on the topic of navigating the infertile couple journey efficiently. Please receive Professor Ramsuak at this time.
Good morning, everybody. So this is Trinidad on the line, and I'm very, very delighted to be part of this important meeting by the Acog Section 4. And having done this before, I really feel at home with all of you. So thank you for the organizers for inviting me, and also thank you for all the attendees for listening in. So today's topic is about infertility. And if we look at the WHO newsletter of April 2023, a very interesting comment and observation, which says around 17.5% of the adult population, which is roughly 1 in 6 worldwide, experience infertility. That's a very sobering statistic. And WHO also suggested that there's an urgent need to increase access to affordable, high-quality fertility care for those in need. So I don't think anybody needs to be reminded that there's a tremendous unmet need as far as fertility worldwide. So what I'm going to be doing today is to let us look at how do we navigate a couple's fertility journey when they come to you. Because at the end of the day, efficiency is critical for our patients. They want to know that we are doing the best for them so they can get the best results. And I think one of the ways I would like to approach today's presentation would be looking at 2 case scenarios and picking out of that the things that are very useful for getting on track, getting them on track, and getting the best results. So let's look at our couple number 1, which is who are John and Janice. Case scenario, have we left it too late? So Janice is a 40-year-old nulliparous woman. Her partner, John, is age 47, and they've been hoping to become pregnant for at least 2 years. Her menses come every 5 to 6 weeks. They saw the GP, who prescribed clomiphene, which she used for 6 cycles, but without success. The couple have come to see you on the recommendation of a friend, a patient of yours. They've heard that you're so good at this, that you will navigate this journey and success will follow. Is that really true? Well, according to Chaucer, time and tide wait for no man. And you remember their ages. So the questions I think that would be pertinent to answer if we are trying to assist this couple, number 1, at age 40, is she ovulating? What is her egg reserve? And of course, other important considerations, such as, is there pelvic disease? Are there fibroids, for example? Is there endometriosis? Is there a tubal factor? And of course, is there a male factor? But I want to concentrate on her cycles, which are 5 to 6 weeks, and she is age 40. So we have to wonder, is this because of anuovular cycles? And does she have a low egg reserve? Well, some of the questions that are pertinent would be, What's the cycle regularity? We just talked about that, delayed periods, missed periods. Does she have long sessions of amenorrhea? So we're going to think about premature ovarian failure. We're going to think about PCOS, hyperprolactinemia. Additionally, we ask about hot flashes. We ask about galactorrhea, symptoms of hyper and hypothyroidism. We ask about previous pelvic or ovarian surgery, for example, ovarian diathermy, ovarian cystectomy, because we know full well that when we operate on the ovaries, we are in fact removing part of the ovulation capacity of these ovaries. We need to do some investigations. What are the ovarian reserve tests that can help us to define egg reserve? Well, I think it is pretty clear that nowadays we go to AMH, anti-Mullerian hormone. But there are other important tests, for example, basal FSH, that means between day 1 to day 3, basal estrogen, estriol. What we are looking for is a level of FSH which is elevating and the level of E2 that is diminishing. Inhibin B is one of the ovulation of ovarian reserve tests, but it does not have the accuracy or the reliability of AMH. And then there are some ancillary tests. We spoke about thyroid function. So what about checking the thyroid function tests? What about LH? Because we know FSH, LH ratio is important in diagnosing of polycystic ovaries. Prolactin for hyperprolactinemia. And of course, we can do an ultrasound and assess the antral follicle count. We know that if you have an antral follicle count in the early follicular phase of 8 or more, then that is likely to be a good sign of ovarian reserve. So what is AMH? It's a glycoprotein. It is expressed by the granulosa cells of growing follicles up to the small antral stage. The number of growing follicles recruited from the primordial follicular pool reflects the number of primordial follicles. So if we know that we get a certain value of AMH, which is related to the recruitment from the pool, we have an idea of what the pool is like. We also know that AMH is not produced by the corpus luteum or by an atretic follicle. And I think it is a truism that ovarian declines with age. I don't think there's any questioning about that. So if we look at this graphic here of AMH expression, you will see that moving from primordial follicles to the pre-ovulatory follicles, we go from primordial to secondary to small antral. And that pink circle in the small antral follicle is representing the volume of granulosa cells. And the granulosa cells are what are producing AMH. When you look at this, the lower segment of that graphic, which is segment B, we are seeing in the early stage of life, large numbers of small antral follicles. But as time goes on, the numbers fall and fall and fall. And this is because of two things. One is a natural atretic process called apoptosis. And the other is, of course, utilization of follicles in the reproductive years. But we know for a fact that eggs continue to be lost by a natural process of dying like any other cell in the body. And the final part of the graphic shows high levels of AMH in the younger age group, but very low levels in the older age groups. And there are two aspects of this graph here. On the left, you're seeing number of follicles, and then you're seeing the age. So we're looking at, again, the whole idea of numbers of eggs, numbers of follicles diminishing with age because of apoptosis in the first instance. So at birth, we know that there are close to 10 to the power 6 number of follicles, but that these gradually get fewer and fewer even before menstruation has started. And then in what is considered the optimal fertility years, again, the numbers are dropping and they continue to decline until the end of fertility, irregular cycles, and the menopause somewhere around the age of 50, 51. On the other hand, the other part of the graph, which shows the dotted line, is speaking to the quality of the eggs. So this is a qualitative assessment suggesting that poor quality eggs increase with age, but numbers of eggs fall with age. So this is very important when we have to deal with a couple like John and Janice. How do we interpret the AMH level? Well, we know that AMH shows no intercycle variability, so it's a convenience measurement, meaning you can take the test at any point in the cycle, not like FSH, which you need to do in between days 1 to 3. The units it will be reported in would be either nanogram per mil or picomole per liter. And it's important that you check to see which one your lab is reporting. The conversion factor from nanograms to picomole is approximately 7. And we know that when you get a result, you will see that they are speaking to the age group per result, reported result. Some people are happy with nanogram per mil. Some people are happy with picomole. I am more comfortable with picomoles because the numbers are larger and you can more easily explain the condition that you are seeing to the couple. So what are the AMH levels with age? I just spoke about that. So in the 20 to 25-year-old highly fertile group, we're looking at a study which looked at large numbers of women, and the median level was approximately 4 nanogram per mil, which corresponds to about 30 picomole per liter. In the age group 31 to 35, in the same study, we are seeing a median level of about 2.4 nanograms, which translates to about 17 picomole per liter. Then, in the older age groups, 40 to 44, look at the drastic difference, 0.5 nanograms, which corresponds to only 3.7 picomole per liter. So if we are looking at the optimal age for fertility, which is between 20 and 34, for example, or 18 to 34, we're looking at a range of between 2 to 4 nanogram per mil, or approximately, I always use for simplicity, I say 20 to 30 picomoles. So people can understand what kind of number they should be aiming, they should be hoping for. Not that they can do anything about it, but you can know what you're dealing with. By and large, levels which are under 1, so between 0.2 to 1.2 nanograms, or 1.5 and less than 10 picomoles, would be used to identify people with low ovarian reserve and therefore poor responders to ovulation stimulation. So what's the value of assessing AMH apart from getting those numbers? Well, I think number one, it will inform the choice of the type of ovarian stimulation medication we should use. For example, if the levels are good, we can use oral medications. For example, we can use clomiphene, we can use letrozole. If the levels are not so good, maybe we need something stronger. Maybe we need gonadotropin, HMG. Maybe we need a recombinant FSH. It informs the dosage, because if you have very low levels, it makes no sense going in the lowest dose of the medication that you are intending to use. You would use a higher dose. If the levels are very high, and you see high levels in polycystic ovary syndrome, and the reason is obvious, that they are going to respond more with even a touch of medication. And assessment of the AMH allows you appropriate counseling to the couple regarding their egg reserve and a realistic chance of success. So if we're looking for success, we have to be realistic. We have to explain whether we hope using the methods that we are using now that we have a good chance, or we don't have a good chance, or should we move up to a higher level of assisted reproduction. And these These are the kinds of value added that AMH gives you in the management of the patients. Let's look at another scenario. And this is our couple, Juanita and Carlos. So their case scenario speaks to an unexpected result. Juanita, 29 years old, has had 2 children, ages 5 and 3, from a previous marriage. She's been married to Carlos for the last 2 years, but they have no children, despite never having used contraception. She has a regular menstrual cycle, has had no illnesses. She had a routine gynae checkup. She was assured she had no pathology, no fibroids, no ovarian cysts, no PCOS. Pap smear was negative. And the gentleman is 32 years of age. He's a chef. He's not fathered any children, despite being in 2 previous long-term relationships. He's not overweight. He has no past medical or surgical history, and he is a moderate smoker. He's never had his sperm tested or his semen tested, but he has used hormonal and nutritional supplements in the past. And this is from the health shop. He loves cycling, very active. So in the history, we're going to ask him about a heated environment. For example, as a chef, very often you're in a very hot environment. Taxi drivers, if they don't have air conditioning in their vehicles, they are also in a heated environment. The type of clothing preferences, the types of underwear, the types of jeans, and so on, these also create an unusually heated environment for the testes and therefore can affect their sperm production. We ask about trauma, injuries, sports injuries, and so on, infection, mumps, STIs, for example, gonorrhea, chlamydia, these can cause vas occlusion. We ask about surgeries, for example, herniorrhaphy, chemical exposure in the workplace, smoking, alcohol intake, occupation. We must find out, are they together all the time, or does he have to be away for 6 weeks at a time because he has a job abroad and other things like that. We ask about sex, frequency, we ask about erection, we ask about ejaculation. And then we would want to do an examination. Apart from a general physical, we should consider varicocele, we should consider testicular atrophy, and things like undescended testes, which is unlikely at this age. What investigations do we do? Well, I think it goes without saying that a detailed semen analysis is obvious. We should consider doing an ultrasound of the testes and the epididymis. They will measure testicular volume, they will look for varicocele, and then we do some blood investigations. We can do the FSH, the LH, the prolactin, and testosterone. And if there's azoospermia, we probably ask for a urine test looking for retrograde ejaculation. If your lab doesn't use this, I recommend that you ask them to get it. It's available online, it's free. It's a WHO laboratory manual for the examination and processing of human semen, the 6th edition, which is the latest one, I think it's 2021. And this gives details of how the semen analysis techniques have been standardized worldwide. And they also have, very importantly, what are the acceptable reference ranges. So if your lab doesn't use it, kindly ask them to get a copy. In semen analyses, we will compare the results with the recommended values, as I mentioned to you in the WHO manual. Now, his sperm concentration, which is what we call the count, the concentration is the amount per mil. So his count was low, to 3 million per mil. The reference range on WHO is more than 14 million per mil. Evidence of progressive motility was also diminished at 25%, which is lower than the reference, which is more than 30%. The percentage of ideally shaped sperm was also lower than expected, the reference range being more than 4%. Very importantly, TPMC stands for Total Progressive Motile Count. The total progressive motile count was 12 million. Now, that's a very important index of ability to assist this couple, especially if you're looking at procedures such as IUI. The total progressive motile count will be calculated by the lab. It's a very simple calculation of the number, the volume of semen, the motile count multiplied by the percentage motility. So how do we assess Carlos, bearing in mind he has these results? He has oligospermia, he has oligoteratospermia, and he has low levels of motility. So do we refer this person to the urologist? I must tell you, this is what has happened over years, but more and more we want to say, think twice. Don't pass the buck. If this is your patient, you need to try to understand how best you can help the patient. Doesn't mean that the urologist has no role, but work it out as far as best as you can. And there's a good reason for me telling you that. By the way, so the Collins Dictionary defines passing the buck, failure to take responsibility for a problem and to expect someone else to deal with it. But we don't want that. One of the reasons we are very hesitant to immediately refer to the urologist is because of this. Often the first assessment is a testicular biopsy. And the question is this really a required test in somebody who has oligospermia? Well, I would venture to suggest that testicular biopsy has very little role in diagnosis and management of most cases of male infertility. For example, non-obstructive oligo or azoospermia. If it's biopsy is not going to help you. It may have a role in obstructive azoospermia. So, for example, the testes are functioning absolutely fine, but the sperms cannot be delivered through the valves. So, if you want to confirm that there is normal sperm development and good numbers, then you may consider a testicular biopsy. But testicular biopsy has significant disadvantages. Well, the obvious things: infection, bleeding, hematoma, but more importantly, testicular scarring. Because when testicular scarring occurs, then you will have issues with disseminatorous tubules and the ability to function and to allow the sperm to maneuver through the tubules. So what would be my plan for this couple? Well, I would consider ovulation stimulation with follicular tracking and IUI. And why I'm going for IUI is because the total progressive motile count is more than 10. If it's under 10, well, it's borderline. Say if it's between 7 to 10, it's borderline. But if it's 2 or 3, then you really have to consider whether you would be able to get sufficient motile sperm for IUI. If it's 10 or above, that's a very good progressive motile count. So ovulation stimulation, OS, follicular tracking, IUI. For ovarian stimulation or ovulation stimulation, we want to ensure follicular development and therefore less cancelled cycles. So this is where you're going to use your AMH to guide what medication you will administer. For follicular tracking, well, that's obvious. You do an ultrasound, you look at the uterus for the endometrial thickening, you look at the ovaries, and you look for follicular development. Now, my recommendation is that you should do, if possible, an early ultrasound, which is between days 2 and 3 or 4, which is basically when there's no follicle already obvious on ultrasound. However, if there are things like ovarian cysts, for example, then you will pick it up before you do another ultrasound and assume that a cyst is actually a developing follicle. So days 2 to 3 and day 10 to 13 would be the times that would be appropriate to do your follicular tracking. But you should also do serum estrogen, which will be to define increasing levels to compare with the follicular development. My preferences would be clomiphene, of course, letrozole, and especially if there's polycystic ovaries. Why? Because letrozole is very much better than clomiphene in recruiting single follicles as opposed to multiple follicles. And you don't want multiple follicles being recruited in patients with polycystic ovaries. Gonadotropins would be the other option, of course, and recombinant gonadotropins in older patients and those with low AMH. So this is basically what we would do. We would start with a day 2 ultrasound, and we start the ovarian stimulation around the same time. So you're going to administer or prescribe clomiphene or letrozole or gonadotropin, starting usually on day 2. So you do a pelvic ultrasound and you do a serum estrogen. Serum estrogen should be low at this phase because there should not be a high level of estrogen because there isn't a follicle. And if there's a high serum estrogen, it means that the FSH is likely to be high, which is not a good starting point. If you're using HMG, like an injection, then you will do a pelvic ultrasound on days 8 and 10 and do a serum E2 level. And you compare that with the day 2 level. If you're using oral medications, you do your pelvic ultrasound. Of course, the first one on day 2, but the second one could be delayed till approximately day 10 to 13. And of course, you do serum estrogen again. If the follicle diameter in your assessment is more than 18 or more millimeters, and the endometrial stripe thickness is more than 8 millimeters, and there's good E2, then you can give the HCG trigger, which is HCG 5,000 units subcutaneous or IM. And then, having given the HCG trigger, we know that we expect ovulation to occur somewhere between 36 to 40 hours later. So that would be a good window to identify the best times for sexual intercourse or for your IUI procedure. So just to recap, we're starting on day 2, we're doing a pelvic ultrasound, we're doing the E2, and we're doing the E2 every time we see the patient, plus the pelvic ultrasound. And it's very important to try and get your lab to give you the E2 levels the same day or the next day, so you know how your follicle development is going. So E2 levels and follicular development. In the early follicular phase, day 2 or day 3, it should be approximately 20 to maybe 30, 50 picograms per mil. The conversion factor from picograms to picomole, as you know, that's my favorite unit, is 3.6. So somewhere between 60 to 100 picomole per liter is what you're looking for. You don't want it to be more than that, because if it's more than that, it means there's a source of estrogen somewhere in the body. It's probably a cyst, it's probably a follicle, but you need to understand what could be causing that, and you try not to start the procedure with a high estrogen level. In the pre-ovulatory time, we're looking for somewhere around 200 picogram per mil. So that's the one, if you test it on day 13 or day 14, whenever you tested that, when that last ultrasound was, this is the number you're looking at to suggest that you have good follicular development. And this is per follicle. So if you have more than one follicle, this will be increased. In picomoles, that's approximately 700. So 700 to 800 picomoles per follicle, 200 picogram per mil would be the other alternative unit. And we all know that how we do the ultrasound is generally done transvaginally. And we're looking here for what we want is what is called a dominant follicle. A dominant follicle, so that there might be other follicles, but they are smaller. They are not likely to be reaching the stage of maturation and of release. A mature follicle, we're looking for a diameter of 18 millimeters plus. Could be 18, could be 20, could be 22. If it's larger than that, then chances are it's not a follicle, could be a cyst. And then we look at the endometrial thickening, and this is a typical type of endometrial thickening, which is pre-ovulatory. And what you're seeing there is a level of 11 millimeters or 1.1 centimeter, and there's a typical 3-line image, what's called a trilaminar image. And this trilaminar image is typical of pre-ovulation. And then if you're arranging for an IUI, then you need your lab to do a density gradient IUI prep. The density gradient goes like this. It's really quite simple. It takes the processing, so it takes about 30 minutes, 25, 30 minutes. And essentially what is done is that the semen, which is the pale yellow area, is layered on top density gradients of different density. So you have a 40% gradient, for example, and an 80% gradient. And these come prepared by manufacturers, so the lab can get it from wherever they prepare them. And it's a layer there, left for about 10 minutes, and then it's centrifuged. And what happens is that in that process, the sperms are swimming, and they swim through 40%, swim through 80%, so that the ones that come at the bottom here are going to be the most resilient and motile sperm. The non-motile sperm and the dead sperm are going to be staying here. So once this tube has been centrifuged, we now get a pellet of motile sperm. And that pellet is removed and is resuspended for the IUI. And we would normally ask them to put it in approximately 0.3 to 0.5 mils of suspension, loaded into a syringe, and with the IUI catheter, we do a gentle insertion. And we are very fortunate. Nowadays, we have such wonderful types of IUI catheter. They come straight, they come curved, they come slightly curved. So being able to do an atraumatic insertion is usually very, very possible. The idea of trying to unless there's cervical stenosis from some other reason, we would normally have a very atraumatic insertion. And remember, we don't want blood in the endometrial cavity, because that will obviously affect the pH and it will affect the swimming of the sperm. And then having done that, especially if you've used HMG, you've used a type of ovarian stimulation, the chances are a corpus luteum may not produce enough progesterone, and therefore we need to support the cycle. We could use micronized progesterone. I think most of you know about this, 200 micrograms twice a day, or progesterone gel, 8%. You can use IM progesterone, and there are some, these are the popular things. Occasionally, oral digosterone has been used. So having done our IUI, what are the chances of success? Let's be realistic. What you're seeing here is a cumulative pregnancy rate versus the number of insemination cycles. And if you look at this, I think you will agree with me that once, so these are by age groups. So the blue is under 25, the red is 25 to 29, the green is 30 to 34, and so on and so on. And I think what you can see, and you will agree with me, that after 3 or 4 dissemination cycles, there is no further benefit of IUI. Right? So after 3 or 4, we've leveled off. Our cumulative pregnancy rate is going to be pretty much static after that. So that has a very important role to play in our discussion about what's next, because what you don't want to do is to continue doing the same thing over and over when the statistics are showing that it's not going to be much help. This is a study which was done with over 4,000 cycles of IUI, showing that after 3 cycles, maybe you need to rethink. Now, if in the 3 cycles there was no ovulation, if in the 3 cycles there was some issue with the sperm production, if in the 3 cycles there was some reason why there's maybe the ovulation was taking place on a tube on the side with a blocked tube, for example, then you won't count that one. So you may go another cycle, but we shouldn't be having people having 8 and 10 cycles of IUI, because it flies in the face of science and evidence. And then with that information, you can meet with your patients and discuss the realistic options for moving forward and for success. For example, at this stage, you need to start thinking, is this IVF? Is this ICSI? Is it epidermal sperm aspiration? Is it testicular sperm aspiration? Is it testicular sperm extraction? All of these things will be done usually, of course, at a specialized center, an IVF center by and large, but these are the next steps. What I've tried to highlight here is the steps that you might take in your office, which are very, very doable once you follow the guidelines. The numbers are there, and I think there comes a time when you have to say, look, I was hoping that we would get success. We haven't. Is it sensible to continue doing the same thing? Maybe not. And these are your other options. Thank you very much.
Professor Ramsuak, thank you so much for that insightful, simple, and comprehensive presentation. I know that there are some questions in the Q&A section. However, Professor Ramsuak had to sign off. We will be getting these questions to him in email, and he will respond to the attendees at the most appropriate and feasible time. Ladies and gentlemen, at this moment, we will be hearing a word from another exceptional sponsor, East Health Technology. Ladies and gentlemen, thank you for joining and remaining with us thus far. We certainly hope that the content shared by our exceptional presenters on HPV screening, vaginal discharge, surgical management of uterine fibroids, and management of the infertile couple has been fulfilling and sparked interest and will positively inform and influence your future practice. I extend my heartfelt gratitude to all the attendees, speakers, sponsors, and event organizers for making this event possible. Your dedication and commitment to advancing medical science and improving healthcare outcomes are truly commendable. Ladies and gentlemen, thank you for allowing me to moderate this session for you. It was indeed my pleasure.
Thank you so much, Dr. Clark. Doesn't she have an amazing voice? So we're on to the second and final segment. It's been great thus far. Thank you again, everyone, for hanging on with us on this Sunday. And we are almost at the end. So I would like to take the time to introduce our next moderator, the beautiful and effervescent, and in our Barbie colors today, Dr. Kirian Bridgewater Lyon, who will be moderating the last session. So without further ado, I hand over to Dr. Bridgewater.
Thank you so much, Dr. Daly, for that lovely introduction. And thank you so much to the American College of Obstetricians and Gynecologists, West Indies chapter, for asking me to assist in moderating and contributing to this lovely event today. I also want to thank Dr. Clark, who did an amazing job with moderating the first session. My voice isn't as nice as hers because I'm battling a bit of a flu, but with no further ado, I would like us to proceed. I hope everyone is refreshed and prepared to learn even more in the second session. Our next presenter, I am truly honored and grateful to be able to have the privilege of introducing Dr. So before I get the opportunity to introduce Dr. Red Allinson, we have one more thing to do. We cannot have an event of this magnitude without the support of our sponsors. And so with no further ado, I would love for you to pay attention to the presentation provided by Medimpex, one of our sponsors for the Acog presentation today.
Greetings. Thank you for having Medimpex Jamaica Limited participate in your conference. Today, we'll be showcasing to you just a few of our first-class products for healthy living. We will be focusing on our gynecological line of products. Firstly, we'll speak about our contraceptives, and we have two types, the emergency contraceptive as well as our oral contraceptives. The emergency contraceptives that we have are Postinor single dose and Postinor 2. Now, Postinor acts to prevent ovulation or fertilization and implantation. Please note that Postinor is not an abortifacient. Neither does Postinor affect an implanted embryo nor an already established pregnancy. How do you take Postinor? Postinor is taken one tablet within 72 hours post-coital activity. The second tablet of the P2 is taken by the female 12 hours after the first tablet. Now, Postinor 2 is 95% effective if taken within 24 hours, 85% effective within 24 to 48 hours, and 58% within 49 to 72 hours post-coital activity. So as you see, as the time expands, then the effectiveness will be reduced. For the single dose, one tablet is to be taken by the female immediately. Post-administration. Now, effects that your patients can see: 10% bleeding, disturbances, nausea, fatigue, low abdominal pain, and headache. Some may also experience breakthrough or withdrawal bleeding, and that is usually seen within 2 to 3 days after taking the tablet. Also, a small percentage of patients may experience dizziness, breast tenderness, diarrhea, or vomiting. Now, ideally, Postinor 2 should not be used more than once per menstrual cycle. This is because repeated use reduces the effectiveness of the drug. Therefore, emergency contraceptive is less effective than long-term methods. So why Postinor 2? Because, just to be sure, Postinor. Postinor 2 was researched, developed, and manufactured by Gideon Rector Limited, and it was first launched in 1979. That's over 40 years of effective usage. Postinor 2 is the innovator or brand name of this drug quality assurance. And this is what the Postinor 2 and the single dose looks like. Now we'll be moving on to the long-term treatment or long-term contraceptives. That is our oral contraceptives of Lindinet, Novinet, and Mistral. Now, Lindinet is our combination of ethinyl estradiol and gestidine, Novinet, or combination of ethinyl estradiol and desogestrel, and Mistral, ethinyl estradiol and denagest combination. So let's talk about Lindinet. Lindinet is 99% effective. The gestidine takes a long time to be cleared from the system, and so you're getting sustained drug effect, fewer pregnancy rates due to a missed pill, and very low incidence of adverse effects. So in essence, Lindinet is well tolerated. Novinet. No, with Novinet, we're getting a positive effect in androgen-induced skin disorders such as mild acne, seborrhea, hirsutism, and alopecia. Novinet has a positive effect in case of dysmenorrhea, and also changes in body weight were non-significant. Mistral. Mistral is also 99% effective. You are providing your patients with good cycle control, reduced intensity of menstrual bleeding, decreased duration of menstruation, reduced frequency of dysmenorrhea, and also anti-androgenic effects, mild to moderate acne, hair, and skin greasiness. Here we have our Cleon D, which is a combination of metronidazole 100 mg and miconazole 100 mg. Cleon D is indicated for the vaginal treatment of urogenital trichomonas infection, bacterial vaginosis, and local therapy of candidiasis. One vaginal tablet is to be slightly moistened and inserted high in the vagina at bedtime for 10 days, and Cleon D is safe in pregnancy. However, if using the alternate treatment of 2 tablets at night for 5 days, this is recommended for patients who are not pregnant. We also have Mycosis, which is our brand of fluconazole, treating a variety of conditions such as vulvovaginal candidiasis, onychomycosis, and pityriasis versicolor. We have it in a 150 mg strength as well as a 200 mg strength. Then we also have an iron supplement, Sorbophorduals, containing 320 mg of ferrous sulfate, 60 mg ascorbic acid, and it employs the slow release technology. It's indicated for prophylactic treatment of iron deficiency and also for latent and manifest iron deficiency. Dosage for adults and children 12 years and older, 1 tablet 2 times daily. In pregnancy, during the first 6 months, a single tablet once daily, and in the last trimester, as well as during nursing, 1 tablet 2 times daily is what is recommended. Sorbophor is providing your patients with a lesser chance of constipation because of the slow release of the ingredients, less GI irritation due to the slow release of iron, and fast absorption because of the vitamin C. We also offer prenatals from our Prime Health line of products. And we also have an iron complex for women, also from the Prime Health brand. Recommended usage is 1 capsule per day or as directed by your healthcare practitioner. Thank you so very much for having us, and please enjoy the rest of the conference.
informing us about all of the options that they have readily available for us to enhance the women in our practices' lives. With no further ado, I will move on to introducing Dr. Red Alinsod. Dr. Red Alinsod completed medical training at Loma Linda University Medical Center in 1990. He admirably served a 12-year Air Force career with 4 active duty years at George and Nellis Air Force bases. He has a gynecological practice in Southern California and has since extended and now is in Texas and Nevada as well. Red has built a thriving cosmetic urogynecological following, including, I'm sure, Dr. Daly and myself as avid fans and followers. He is a director and founder of the South Coast Urological Gynecology and the Alinsod Institute for Aesthetic Vulvovaginal Surgery, which is an educational center, as well as Gynflix, which is an online e-learning platform that he has founded. His international teaching program is the first of its kind to combine both pelvic and reconstructive and aesthetic principles all together. He has trained many of the world's leading doctors and instructors in cosmetic gynecology and has presented his techniques worldwide over the last 27 years. He is a co-editor of Female Cosmetic Genital Surgery, Concepts, Classifications, and Technique, which is a seminal textbook for plastic surgeons and gynecologists in this rapidly growing field of cosmetic gynecology. He is the founder and chairman of the Congress of Aesthetic Vulvovaginal Surgery, the oldest and longest running congress dedicated to female genital surgery. It is now incorporated into the International Society of Cosmetic Gynecology, which we all know as like the granddaddy of the field. He is the proud inventor of the Barbie look and the hybrid look labiaplasty, medical curvilinear labiamajoroplasty, central and lateral clitoral hood reductions, as well as many other innovative surgeries. Dr. Alinsod is the inventor and patent owner of Thermiva and genital predictive permeation. He's the innovator of amniotic fluid use for the overactive bladder with AmDrop, and a co-developer in the O2 Vasc for improvement of genital blood flow. He's also the originator of exome use in genital conditions. Dr. Alinsod specializes in non-surgical female restoration, the treatment of stress incontinence, overactive bladder, atrophic vulvovaginitis, orgasmic dysfunction, vulvar dystrophy, and modern management of menopausal symptoms. He has been widely acclaimed and appreciated in many fields, so much so that in 2003, March of this year, he was awarded the Best Doctor from the National Women's Choice Award. And he actually received the best results in cosmetic gynecological surgery from the International Society of Cosmetic Gynecology for 2001 from 2020 to 2022. We are privileged to hear from such an innovator, leader, and stalwart in the cosmetic gynecology, urogynecology, and reconstructive gynecology field. And we are pleased to listen to Dr. Red Alinsod speak to us today on regenerative medicine in gynecology. Thank you so much, Dr. Alinsod.
Thank you for the very kind and generous introduction. I'm almost embarrassed. So I really appreciate it. You have been such a great stalwart for your country, training in this field. And I love the youth and vigor on stage there, Dr. Daly, training with some of the leaders in this field, including Dr. Matlock and Pelosi, and being an avid member of my Gynflix. I am so happy that Acog has allowed me to present here, my third time to present for Acog. And I believe that the specialty is moving in the right direction to bring these new technologies to all our members around the world. And so I'm very proud to be here, and thank you for allowing me to show my videos.
Thank you so very much to Dr. Red Alinsod for that informative presentation, showing us all the different modalities in energy, as well as the options with biologics as well, and how it can help us to improve the quality of life of our patients that we interact with. In addition, educating and showing us about the platform of Gynflix, which we can all utilize to learn even more about the kind of reconstructive surgeries that we can provide for our patients. We do have a few questions for Dr. Allen Sod. We have one from an anonymous attendee that asks, what is a vestibulectomy? Is it the same as vaginal dystrophy? Dr. Allen Sod?
A vestibulectomy is similar to a perineoplasty, removing that area, but vulvar vestibulitis is an inflammatory process right at the opening of the introitus that the area turns sometimes beet red. You touch it with a Q-tip and it's very tender and they jump. They can't have sex. You biopsy it and it only shows inflammatory cells. Sometimes it has lichen sclerosis, sometimes it doesn't. So it's really not specific, but it's a very tender area right at the opening of the vagina, and the vestibulectomy is a standard therapy in the past.
That definitely sheds a lot of light on that matter. We have another question. It's regarding the amniotic fluid. What is the preparation done for the amniotic fluid pre-use? How long is it viable for after delivery? And is it something that is commercially available?
Yes, amniotic fluid comes in 1 cc vials, room temperature. It can be stored for up to a year. There is only one manufacturer I know about in the US. The FDA closed down many of the companies that were providing amniotic fluid because they were from ground up amniotic fluid. This one is made out of pure amniotic fluid that's been filtered and cleaned, and it's been from IVF patients who have been screened. And so they gamma irradiate the amniotic fluid and collect it. So the company's name is Integrity, INTEGRITY, and the product is now called Integrity AF. I have no relationship with the company. I use their product because I think it's a wonderful thing. So Integrity AF is what I use. It comes in 1 and 2 cc vials. The approximate cost is, I can't remember exactly, but something like $200 per cc. When I started using amniotic fluid over 15 years ago, it was $2,000 per cc. So the price has dramatically dropped down, and I'm using it more because it's cheaper. I don't have to centrifuge anything, and it's not age dependent. A 60-year-old with perhaps poor PRP will respond very well to amniotic fluid for overactive bladder, lichen sclerosis. And oh, by the way, the same amniotic fluid is used as an inhalant on a nebulizer. Many professional athletes, professional basketball teams will spend millions of dollars for their athletes inhaling amniotic fluid through a nebulizer because it's so helpful for the lungs and regenerate and heal athletic tissues really rapidly. It's also used for wound healing, and it's used for ophthalmology. They use it for dry eyes as one of the best therapies for dry eyes. So there's a lot of use for amniotic fluid. So it's available now to a company, I believe they're in Florida, close to you guys, and it's called Integrity.
Quick question for you. Is there any role for the Thermiva in vaginismus patients? What's your experience with that?
Yes, I don't think you should use it in patients with active vaginismus. If they're in pain, it can exacerbate and cause the muscle spasm of the levator muscles or the pelvic floor. So my screen is if they have a history of levator muscle spasms or even interstitial cystitis. If they have an active interstitial cystitis, I will not do any of the radiofrequency. I will wait till they're symptom free. Now, once they're symptom free, you can certainly use radiofrequency, or in my case, Thermiva, for things like overactive bladder. It's a wonderful treatment for overactive bladder, and it can reduce IC symptoms and flares, but you cannot use it when they're having a flare. It will worsen the flare.
Thank you so much, Dr. Allen Sod. And one final question. What is the treatment modality for Thermiva for recurrent vaginitis? Is it the same 3 treatment with the every 6-month maintenance?
That is my preference. You just do once a month for 3 months. That will bring the pH for these patients. Typically, these pHs are in the menopausal range, 6 to 6.5. And after 3 months, it's a dramatic decrease down to 4 to 4.5. Their UTIs go away, their vaginitis go away. And that's with or without supplementary vaginal estrogens or carboxytherapy. So I think a Termiva treatment that's maintained every 6 months is the most ideal, but not everyone can afford every 6 months. So I have many patients who come in once a year for maintenance therapy. For those who can afford carboxytherapy, you can use one of those packets every month, and it will maintain the effects of Termiva, and you can do your Termiva touch-ups just once a month. Once a year to once every year and a half or so. So it depends on what kind of supportive therapies you're using along with the Termiva. And by the way, I'd really like to thank my friend there, Daryl Daly, for being one of the top Termiva providers there in the Caribbean. Thank you for your support and for learning about this therapy. So I'm really happy that these therapies are entering that region, because these are so helpful for your patients there.
Thank you so much, Dr. Allenson, and we're glad to have that available in Jamaica as well. So we're going to now move on to our next sponsor presentation, which is going to be from Alta Pharma.
Hi, Renee. Can you just unmute for us as well? Oh, there you go. Perfect.
Thank you. That's the button. Good afternoon, everyone. Can you see my screen clearly, and can you hear me clearly?
Yes, we can.
Okay, thank you. I would like to firstly say a big thank you for including MSD in this very important conference. And at this moment, I'll take the opportunity to talk about prevention of HPV-related diseases through the means of HPV vaccination, specifically Gardasil 9 vaccine. So, due to the importance of cervical cancer and other HPV-related diseases as global health problems, the World Health Organization recommends inclusion of HPV vaccines in national immunization programs. Since cervical cancer comprises of 84% of all HPV-related cancers, the World Health Organization recommends that it should be the priority for HPV vaccination. In Jamaica and the Caribbean and Argentina, we do have the inclusion of the Gardasil quadrivalent, Gardasil 4, in the government program, but you can readily find the Gardasil 9 in the trade or private market. Now, as we can see, as we just mentioned, the burden of disease, predominantly we have cervical cancer being the highest disease from HPV. But although cervical cancer is the most common HPV-related cancer infection with HPV HPV can also lead to a proportion of other cancers. Anal cancers, women and men, vulvar cancer, vaginal cancer. So when you vaccinate your patient with HPV, not only are you preventing cervical cancer, but these other cancers as well as the genital warts. So the proportion of HPV-related diseases, as you can see here, 100% of the cervical cancer cases can be attributed to HPV, 88% anal cancer attributed to HPV, 78% attributed to vaginal cancer, or 78% of vaginal cancer attributed to HPV, and 25% of vulvar cancer attributed to HPV. So 80% of people may be infected with HPV in their lifetime. The thing is, HPV does not discriminate by age or gender or lifestyle. And I just want to make a point about the gender that is important when we're recommending that we not only recommend the Gardasil 9 to our females or girls, but we recommend to both boys and girls. And as a matter of fact, most of our regions have gone gender neutral, including Jamaica since 2023, now including boys in the Gardasil 4 government program. So Gardasil 9 shows 97% efficacy against HPV 21, 33, 45, 52, 58, those other high-risk HPV related to cervical cancer. If we look at this slide here, I'm sorry, this is not very clear, but the first bar shows 100% coverage against vulvar and vaginal cancer, 98% coverage against cervical cancer, 75% against anal, 99% against genital warts for females, and 89% coverage against genital warts for males. And this is looking at the quadrivalent types, the 6, 11, 16, and 18. So Gardasil 9 is an adjuvanted non-infectious recombinant 9-valent vaccine. It is prepared from the highly purified virus-like particles of the major capsid L1 protein from the same 4 HPV types 6, 11, 16, 18 in your typical HPV vaccine, and from 5 additional HPV types. So your other high-risk types, including the 45 that we have here in our region, for 31, 33, 45, 52, and 58. Now dosing, it's easy to remember. It's 3 doses. You'd start today, then 2 months from today, then 6 months from today. So 0, 2, and 6. As we have had Gardasil quadrivalent in the market, one of the questions may be, what if someone has already been fully vaccinated with Gardasil and now want to upgrade and receive Gardasil 9? That is totally fine. Once the person's last dose of the plain Gardasil was 12 months ago, they can go ahead and start the Gardasil 9 regimen. There's an alternative dose, 2-dose schedule for children 9 to 14 years. So 15 and onwards, so there's no cap. So 15 and onwards, it's 3 doses, but 9 years to 14 years, it's 2 doses. So they can take those today, then 5 months or 13 months from today. If for whatever reason the second dose was given before 5 months, then they would have to take a 3rd dose because they wouldn't have enough time to mount a proper immune response. So for children, 2 doses. Please remember, of course, always check the prescribing information before prescribing. The most common side effects experienced is injection site pain, redness. There has been incidences of fever, nausea, and fainting. So sometimes it's recommended that the recipient of the vaccine may sit for 10 to 15 minutes before moving around. The call to action for Gardasil 9, it's about recommending. As individuals, we need to recommend to our family members. As physicians, we recommend to our patients because of all the cancers that plague our society, cervical cancer and the other HPV related diseases is the only cancer that we're aware of that's preventable through vaccination. So if we can prevent one less cancer type, cervical cancer, by simply recommending, then that's our duty. Thank you so much.
Thank you so much to Alto Pharma for that presentation, especially on Gardasil 9, because we all know how important and pivotal that has been in our cervical cancer prevention technique. And also for adding that additional information about if patients were previously given the vaccine, because that is a very common question that I'm sure we all get in our practice. Our next presenter is Pablo Cabintero. Dr. Cabintero got a diploma in the University of Buenos Aires. He's a specialist gynecologist, obstetrician, and also in clinical sexology. He is a fellow and the chair of the Argentine sector of American College of Obstetrician and Gynecologists. He is also a university professor at the Universidad Maimonides. He is the president of the Association of Argentina para el Estudio del Climaterio, which is the study of climacterics, and is a Latin American expert in climacterics and menopause. He is a member of the Professional Certification Board in Academia Nacional de Medicina in Argentina, and he is a member of the board of directors of the Sociedad Argentina de Sexualidad Humana, which is the Society of Sexual Behaviors and Sexuality. He is also a member of the Patient Blood Management Working Group in the World Health Organization, and we are honored and privileged to have him here to speak with us today. In particular, I want to say thank you to Dr. Cabintero, because as the chair currently of the Argentinian section, he and Dr. Daryl Daly have us currently in the history books. We are currently making history with this inaugural conference with the joint powers of both the West Indies and the Argentinian chapters. So the Reggae Girls made history yesterday, and we are making history today. Acog has always been very supportive and inclusive of us in the West Indies chapter, and I think this is a wonderful initiative for us to bring together all the powerful minds. So with no further ado, we are very excited to hear from you on this matter of iron deficiency anemia and the link to the postpartum hemorrhage.
Good morning, everyone. My name is Pablo Carpintero, and I'm an OBGYN from Buenos Aires, Argentina, and chair of Acog Argentine section. Personally, it's a great pleasure and honor to participate in the first joint meeting between Acog West Indies section and Acog Argentine section. So I would like to express my most sincere gratitude to Dr. Daryl Daly and Dr. Jordan Hardy for inviting me to participate in this prestigious event. So today we are going to talk about iron deficiency, and I would like to ask ourselves if there is a link between iron deficiency anemia and postpartum hemorrhage. So this is my disclosure slide, and these are the learning objectives or agenda that we're going throughout the presentation. So first of all, we have to mention that anemia is a global health problem affecting 30%, that's 1/3 of the world population, most often associated with iron deficiency, the most widespread nutrient deficiency in the world. It affects individuals throughout the life cycle in both developing and developed countries, with 3 to 4 times higher prevalence in the developing world. Anemia reduces survival rates, deteriorates quality of life, and diminishes physical and mental development of the populations affected, lowering its potential productivity, leading to significant economic losses. And what about women? The prevalence of anemia in women of reproductive age is nearly 33% worldwide. And if we focus on a region that is Latin American and the Caribbean, we can observe that in countries like Haiti, Panama, Bolivia, or Dominican Republic, the prevalent rates are above the worldwide media. What about Jamaica? In the last publication of World Health Organization, the prevalence rate of iron deficiency anemia in Jamaica, it's around 24%. That it's considered a moderate public health problem. Now, If we categorize this prevalence by group, we may say that the worldwide prevalence of anemia approaches nearly 42% of pregnant women. However, the category with the greatest absolute number of individuals affected by anemia is non-pregnant women, approximately 470 million of women worldwide. We can infer that women are an epidemiological vulnerable group, and this is because the 0.5 or 1 milligram iron day primarily due to menstrual blood loss. And this gender gap between men and women for the anemia burden is widening through the last decades. The causes of iron deficiency and iron deficiency anemia are complex and multifactorial. For one hand, we have decreased iron intake with diets that may be insufficient in quantity and quality, like vegetarian, vegan, or unbalanced diets. Then we have an excessive blood loss, like heavy menstrual bleeding, derivatives either vaginal or C-section, GI bleeding, and surgery. Then we have decreased iron absorption and involves inflammatory bowel diseases like celiac diseases, and an increased iron demand like the physiological states of pregnancy and lactation, infancy, and adolescence. As you may see, many of these conditions are present in our OBGYN daily practice and as women's healthcare providers. And many of these causes also overlapped. It's not unusual to find a teenage girl with an insufficient diet, with an interpregnancy short interval, and a prolonged lactation period. By far, the first cause of iron deficiency in women is heavy menstrual bleeding. Now, what about pregnancy? There's a high risk of iron deficiency anemia in pregnancy, and the estimated daily iron requirement increases approximately tenfold from the first to the third trimester of pregnancy, mainly from the great expansion of maternal red blood cell mass and for the fetal requirements. But if we take into consideration that approximately 40% of women were iron deficiency before pregnancy, this condition exposes women to a serious and high risk situation affecting their physiological response to hypovolemia in case of an hemorrhagic event during delivery or postpartum. Iron dietary intake is insufficient to meet higher iron requirements during pregnancy, as we can see in this graphic. So it's crucial to supplement or directly treat iron deficiency anemia depending on the values obtained during the preconception screening or the first prenatal visit. For all the conditions mentioned before, the World Health Organization had stated their global targets for 2025, and one of them is the reduction of 50% of anemia in women of reproductive age. So here we have an inexplicable paradox of a high prevalence disease that despite an effective treatment, it still represents a major challenge to public health efforts. So the questions will be, are we identifying iron deficiency in the most vulnerable groups of women? Are we diagnosing iron deficiency earlier, and are we treating it with the most appropriate formulations? What are the consequences of iron deficiency in mother, fetus, placenta, newborn child? In mother, mortality and morbidity are mostly related to the presence and severity of anemia, influencing exercise and mental performance, immune function, and neurological functions. It is well known that in fetus, it is related to prematurity, rupture of fetal membrane, growth restriction, and higher mortality rate during the first year of life. And in the newborn child, well, this is a very alarming situation, is the irreversibly impaired development of the fetal nervous system with an impair of the future psychomotor development. But today we are going to focus on the impact on the maternal situation. Iron deficiency anemia increases antenatal and perinatal mortality, and depending on the severity of the anemia. And if we see this map, the global prevalence of anemia in pregnant women can be mirrored like a specular image with the global prevalence of maternal mortality. So we have to ask ourselves if there's a link between these two medical conditions. We know that there are several risk factors for postpartum hemorrhage. We can categorize women in low risk, medium risk, and high risk. Low risk, we have single women, fewer than 4 previous deliveries, unscarred uterus, and absence of history of postpartum hemorrhage. We have medium risk when we have previous CCCS section or uterine surgery, more than 4 previous delivery, multiple gestation, polyhydramnios, blood fiber, chorioamnionitis, etc. And high risk in cases of placenta accreta disorders, ante or intrapartum bleeding, history, personal history of PPH, or known coagulation defect. But we have to take into consideration and be aware that most cases, around 40 to 60%, have no risk factors except one, and it is preventable, and that is iron deficiency anemia. World Health Organization developed a collaborative and multicentric study, either in developed and non-developed countries, that stated and conclude that pre-existing iron deficiency anemia does place women at greatest risk of hemorrhage during childbirth. The conclusion or the summary of this study, whether the risk of maternal mortality in women with severe anemia during pregnancy and postpartum, shows that maternal death with severe anemia was more than double, between double or triple the risk than in women with no anemia before conception. That is why prevention and treatment of anemia during pregnancy and postpartum should remain a global public health and research project. What is the prevalence of preoperative anemia in scheduled surgeries by specialty? In OBGYN surgeries, approximately 40% of women have operative transfusions than those with no anemia, leading to an increased mortality risk. Here we can see in this graphic that mortality and composite morbidity doubles the risk in women with anemia, and of course the rate increases depending on the severity of anemia, or as hemoglobin lowers, we have the higher risk. And this is why 18 or more methodological approved studies show that preoperative anemia has a significantly relation to perioperative bleeding due to impaired coagulation. And perioperative bleeding is a strong predictor for red blood cell transfusion requirement. On the other hand, red blood cell transfusion is responsible or a strong predictor of an adverse clinical outcome. That is, it doubles the risk of infection, it triples the risk of preoperative anemia, of transfusion requirement. We have 22% more prolonged hospital stay, and we have also the triple of requirement of intensive care unit. So in order to break this deleterious triad and stop this vicious cycle, all our emphasis should be targeted to diagnosing and treating preoperative anemia in the most appropriate way. So 8 million US patients suffer from iron deficiency anemia, and yet it remains an underdiagnosed and undertreated condition. So we should ask if we should rely on the clinical symptoms, like we already know, mood alterations, fatigue, generalized weakness, headaches, cognitive impairment, pale or swallow skin, dyspnea. But we all know that all these symptoms are common to other clinical conditions and they are not pathognomonic to anemia. They have in common a decreased physical performance, that they can worsen outcome of concomitant disorders, and they increase morbidity and mortality. But if we cannot make a diagnosis taking into consideration these clinical symptoms, we have to rely in lab tests. Basically, hemoglobin. And WHO stated that in pregnancy, an hemoglobin less than 11 grams per deciliter makes diagnosis of anemia, and in non-pregnant women, less than 12. But what is iron deficiency? That is to say, when the iron levels, body iron levels, are reduced, but still we can have a normal hemoglobin with low iron stores. If we only rely on the hemoglobin test, we are missing around 60% of women that are iron deficiency. So how can we diagnose iron deficiency? Ferritin, serum ferritin, is the gold standard and the most sensible lab test to detect iron deficiency. But we have to think that serum ferritin, it's acute phase reactant, so we have to incorporate the transferrin saturation and a protein C reactive in order to discard a concomitant inflammation that may falsely elevate serum ferritin. With a serum ferritin less than 30 nanograms per milliliters and a TSAT less than 20%, we can firmly diagnose iron deficiency anemia. That is to say that iron deficiency anemia is not what we can see like in this iceberg, and we have to discover it adding this ferritin and TSAT and protein C reactive to the normal hemoglobin that we ask in our antenatal visits. So in order to overcome this serious public health situation, the World Health Organization publishes in December 2020 a policy brief saying or stating the urgent need to implement patient blood management. And what is patient blood management? It's a patient-centered, multidisciplinary, systemic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood while promoting patient safety and empowerment. And patient blood management, it's supported by 3 pillars. Pillar 1 is anemia and iron deficiency anemia. Pillar 2 is minimizing blood loss and bleeding. And Pillar 3 is restricting transfusion. So how can we optimize the red cell mass? We can minimize blood loss and bleeding using hemostatic surgical techniques and drugs, and transfusion by harness and optimizing physiological reserve of anemia and restricting transfusions. So how can we optimize red cell mass? Basically, by screening for and detecting anemia, identifying and managing the underlying disorders of the causes that I've already mentioned. But we have to treat suboptimal iron stores, and that is iron deficiency. Refer for further evaluation to an hematologist if it's necessary, and consider anemia as a contraindication for an elective surgery. That is important to timely organize the surgery with hematological optimization, and of course, manage and treat iron deficiency anemia postpartum, either being vaginal or C-section. What are the treatment options for iron deficiency anemia? We have oral iron, which is first-line treatment, IV iron, and red blood cell transfusion, which is only in cases in severe anemia in postpartum hemorrhage. Oral iron is limited to small amount of iron required and when time is not critical to replenish iron stores. While IV iron is when we need moderate to large amounts of iron required or we need a rapid repletion. So how can we indicate or prescribe oral iron? The dose is 3 kilograms for 4 weeks, and we expect to increase hemoglobin by 1 gram per deciliter during 2 to 4 weeks. We have to think that oral iron, we have ferrous sulfate and IPC complexes. IPC complexes have lower incidence of nausea, vomiting, and GI discomfort, and have similar efficacy to ferrous sulfate, but superior tolerability and better compliance. But we have to also mention that there are factors of reducing limiting treatment, like GI adverse events, limited absorption, or inappropriate compliance, or chronic inflammatory comorbidities. So when do we have to shift to intravenous iron? Especially useful in patients with oral iron intolerance, inadequate iron absorption, with a severe anemia that's an hemoglobin less than 9, presence of risk factor, poor compliance, or third trimester of pregnancy. So we have to say that the only treatment with significant efficacy to replenish iron stores and provide the quantity of iron required for erythropoiesis in case of rapid administration is intravenous iron. We have 2 main formulations, iron sucrose and iron carboxymaltose. They have different pharmacodynamics and pharmacokinetics. Iron carboxymaltose, which is the newest, allows us to infuse a large amount of iron, milligrams, in a very rapid infusion of 15 minutes. What are the results or the comparative results between IV iron and oral iron? As we can see here, more patients assigned to IV iron responded with an hemoglobin increase of 2 to 3 grams per deciliter or more. And here we can see in these 2 graphics of serum ferritin and TSAT, we can see that at 7 days after infusing an IV iron, we have a rapid and sustained repletion of iron deposits in women with anemia treated with IV iron. This is crucial because it gives women better response in case of an unprecedented hemorrhagic event during childbirth or postpartum. So we may say that the choice of an appropriate iron formulation is of great importance. And we have to consider the preferred IV formulation choice when a rapid repletion of moderate or large amounts of irons are required. So what are the final messages? Iron deficiency is the most common cause of anemia, particularly in women. Iron deficiency negatively impacts quality of life and increases morbidity and mortality. Iron deficiency and iron deficiency anemia should be viewed as a serious and treatable medical condition rather than simply an abnormal lab value. Take-home messages: optimize iron deficiency diagnosis and think about ferritin and include it in your lab test, routine lab test, besides the normal hemogram. We have to make a strict follow-up in order to take treatment efficacy and lack of adherence and rapidly shift to another formulation. and we have to choose or switch to the most adequate treatment option based on the severity of the disease, the presence of comorbidities, or the critical time for hemoglobin increased desire. If we take into consideration all these take-home messages, maybe we can contribute to World Health Organization global targets for 2025, that is the reduction of 50% of anemia in women of reproductive age. So thank you very much for your attention. I hope you have enjoyed this presentation, and it will be a pleasure to meet you again in next future academic event. Thank you very much.
Thank you so much to Dr. Carpentiero for such an informative presentation about a condition that affects so many of our women. Thank you for highlighting to us the importance of the use of ferritin and transferrin, as that is probably very often overlooked, and that we will now be able to manage these persons appropriately, not underdiagnosed, and also how to implement the blood management system concept appropriately. With all of this information, we will certainly be able to aim towards decreasing the morbidity and mortality associated with this condition, as well as to hopefully meet our WHO target. And personally, I want to thank you for reviving my Spanish lingo, because I think your TV was the most Spanish words I've said since high school, to be honest. That being said, I believe we have a question from the panel.
Thank you so much. I have a question. Locally in Jamaica, we have a prevalence of about 80% of our women and pregnancy, right? In the public setting, it's common where we administer iron sucrose, usually in the form of Venifer, the brand, and now we have Flovin coming up. I would like to know what is the ideal dose and the frequency to administer the iron sucrose to our patients who are like third trimester, severe anemia, so that we can avoid the need for blood transfusion intrapartum and postpartum.
Great. Thank you very much for your feedback. And it's a great question. We have maximum infused doses between, as I showed in the graphic, between iron sucrose, which is the most available formulation also in our country, that is an underdeveloped country. And in most public settings, we have iron sucrose available. The maximum dose for iron sucrose, it's 600 milligrams per week in 3 infusions. That is to say, 200 per day, for example, 3 times a week. May say Monday, Wednesday, and Friday. The difference between carboxymal dose is that we can infuse 1,000 milligrams in only 1 infusion. So they are very effective at the same dose. The difference is that we need more visits to infuse, for example, 1,000 milligrams of iron. We have to take in consideration that iron deficiency in stores in women are around 1,000 milligrams. That is to say that we have a serum ferritin less than 30%. All the iron stores are fully depleted. So we need to replete 1,000 as a base, 1,000 milligrams of iron. That with iron sucrose, it will be around 2 weeks. That is to say 5 infusions of iron sucrose. That would be 5 visits to the institution to the infusion. They are the same effectivity, but let's see, we have more visits to reach the same dose. I don't know if it's clear.
Yes, that was clear. Thank you so much, Pablo. One last question. Have you ever utilized erythropoietin in your practice, and what was the response to improve iron deficiency in pregnancy?
Well, actually, erythropoietin is indicated when there's a low erythropoietin dose in the lab test. Actually, it's not common indication in OBGYN practice. It's mostly for nephrologists in kidney chronic disease or in other diseases that that are present with erythropoietin, with low values of erythropoietin. Which is not the case in pregnant women if they don't have these comorbidities. What it is most important for me to leave this message is that even though oral iron is the first line treatment and the indication by World Health Organization, sometimes we don't have the time to replenish absolutely all the iron stores. Let's say that if we require 1,000 milligrams and the maximum absorption milligrams of iron daily, it's from 5 to 7 milligrams. That is true if we need to replenish only 1,000 milligrams for the iron stores, we need 200 days. And that's a long time during a pregnancy. And we are exposing our women to a higher risk in case of an unprecedented postpartum hemorrhage. So if we know that we are not having the therapeutic effect that we are desiring or that we are targeting, that is this increase of 1 gram per deciliter in 4 weeks, very immediately we have to switch to IV iron because we are exposing our women to a higher risk. And we all know that we are underdeveloped countries. There are a lot of people under very low socioeconomic status. We are diets that are insufficient, either in quality or in quantity. And all these situations will potentiate in a very negative way. So we have to be very conscious of the risk because we have to remember that postpartum hemorrhage is still the first cause of maternal death worldwide. So I think that will be our contribution to assure all these women better quality of life during their pregnancy and diminishing the risk in case of an unprecedented hemorrhage during childbirth.
Agreed wholeheartedly, Dr. Cabintero. We have one last question, and this is coming from Dr. Rishi Shan, asking about what are your thoughts, Doc, on the effect of iron deficiency anemia on the neuromuscular junction of the myometrium and the resulting uterine atony, and as a result, postpartum hemorrhage that may occur?
Great, it's very important. You know that all muscular tissues needs oxygen, and hemoglobin is the carrier of oxygen. They need oxygen to make this contractility. So this is one of the mechanisms why severe anemia is strictly linked to postpartum hemorrhage. One of them is because severe anemia impairs coagulation factors. That will be one mechanism. The other is that it affects uterine musculoskeletal contractility. They don't have let's say, the strength to have this contraction that is the natural or physiological mechanism to diminish normal hemorrhage during postpartum. So yeah, it's great. It's a great observation, and it's demonstrated that this is one mechanism why we have an anatomy that will lead to a postpartum hemorrhage.
Thank you so very much, Dr. Cabintero, for
Thank
such
you.
an informative presentation on such a very important diagnosis, especially with the repercussions with our women and their health. We will now move on to a presentation from one of our sponsors, Recharge Distributions Limited.
Hello, good afternoon. I'll be sharing my screen, and you can just confirm with me if everybody is seeing.
Yep, it's up.
It's up? Okay.
But I need you to go to the... There you go. Perfect.
Okay, excellent. All right, so hello, good afternoon, everyone. I am Aliyah Davis, a medical sales representative from RDL Distributors. Now, before I begin, I'd like to express gratitude for having us take part in today's proceedings. So at RDL, we like to focus on three main headings: prevention, treatments, and diagnostics. I'm going to start off with treatment, and as Dr. Watson went through with us in her vaginal discharge presentation, she spoke to us about treatments for bacterial vaginosis, trichomoniasis, vaginal atrophy, and so I'll be focusing on the three vaginal suppositories that we carry here at RDL. So we have Organo V6, which has cotrimazole in it, and then we have Damphos and 3-Night, which comprises of clindamycin and cotrimazole. Now, the difference between our Damphos and our 3-Night is that the 3-Night has 200 milligrams of cotrimazole, while our Damphos has 100 milligrams of cotrimazole. The Damphos is used over a 7-night period, and here in Jamaica, we know how our clientele is. A lot of persons, will say, "Doc, can't bother with the 7-day, can't bother with the 10-day," and so a 3-night would be a good option. As I said, it's used over a 3-night period, and hence the increase in the cotrimazole portion. These can be used for your bacterial vaginosis, yeast infection, vaginal atrophy. Now, Dr. Carpintero just went through a iron presentation with us, and so I'll be focusing on our iron preparations. And as he said, it is a moderate problem here in Jamaica, which means that a lot can be done to try to assist our patients in reducing iron deficiency or iron deficiency anemia in Jamaica. So I'll be focusing on our hemo, which we call at RDL our complete blood builder. And I say that because, to our knowledge, it is the only product on the market that has such compositions, and these compositions include the folic acid, the ferrous fumarate or cupric sulfate, which is copper, and or manganese. These help with iron deficiency, copper deficiency, and also fetal development. It is easy to swallow, it is chewable, and can cause little to no constipation. A key thing I want us to remember also is that when we give patients our iron supplements, we want to also remind them that iron is not the only thing that may cause constipation when they're taking the iron tablets. So we want to advise them to drink a lot of water, take their fiber while they're on these iron supplements as well. Moving on to our Overmod Forte, which is a chewable tablet. So this has our iron 3 hydroxide polymaltose complex and also folic acid in it, which will help with iron deficiency and also will prevent iron and folic acid deficiency. It is, as I said, a chewable tablet, will cause little to no constipation and has fairly good taste. In the liquid format, we do have Overmod drops, and it only has iron 3 hydroxide polymaltose complex. As I said, it causes little to no constipation, and from my experience is probably a very good tasting liquid for an iron supplement, used for iron deficiency and also prevents iron deficiency. We also do carry metoclopramide tablets. Our brand is called Overclow, and we know that this can be used for antiemetic purposes. Currently, we carry one antibiotic at the moment, which is our Inclav, which is amoxicillin and clavulanic acid. We have both the tablet and the suspensions at the moment. Just on a wide scale, we do a lot of injections across the board. I want to highlight our Easivit B, which is our vitamin B complex, and also our diclocid, which is our diclofenac sodium. From conversations with my doctors and also from research, we found that when you give the vitamin B complex with the diclofenac sodium, we find it to be more effective for your patients. We also do carry a oncology line, which is called Get Well. And don't worry, if you don't see any of the products listed here on our slide, it is available upon a special request. And the good thing about it here in Jamaica, it is that it's NHF subsidized. Now, prevention. We do have a list of supplements here. So we have our Code Soft, which is our evening primrose oil. We do have our Evictol, which is our vitamin E, and also our Zecal D3, which is our calcium plus D3, which we know is very important in our daily supplementation. We also do have an item called Nourish Gold, which comprises of vitamins and mineral supplements. So it contains of a wide range of vitamins like your methylcobalamin, your pyridoxine, selenium, B, D, E, and the list could go on. We also do carry an emergency contraceptive called Preventol. We also do carry some condoms, which are called moons and in case. So another way that we can utilize our condoms is we can utilize it on our catheters and on our probes. So moving on to our diagnostics, which are cost-effective, proven accurate, quick, convenient, and very user-friendly. Now, a thing that Dr. Watson mentioned to us is that we want to avoid misdiagnosing our patients so that we can give them proper treatment. And so here at RDL, we offer a wide range of rapid test kits. Let me start off with our STI kits. We have chlamydia, gonorrhea, herpes, syphilis, and HIV. And yes, you may be asking about the trichomoniasis, but don't worry, we're working on it. We also have some oral self-test kits available, which we have done with MOH to be promoting, or oral kick HIV, which is a swab of the mouth. And we now currently do a check now by Abbott HIV, that is a prick of the finger. We also carry a sickle cell scan, rapid test kit, rubella, rapid test kit, ovulation test kit, and a blood grouping rapid test kits. Now I could go on and on, but I'm just going to highlight a few. So we do hepatitis test kits, dengue, cardiac markers, drug of abuse test kits, and most importantly, our COVID-19. And no, COVID-19 is not finished, very much still rampant. We also do quite a few diagnostic analyzers. We do our code-free, which is our GMR machine, lipid care analyzer, HbA1c machine, ECG monitor, a hematology analyzer, a chemistry machine, and most importantly, after Dr. Carpenter's presentation, we want to highlight our hemoglobin machine, which is highly used by our National Public Laboratory. As I said, we want to focus on trying not to allow our patients to leave without knowing an answer. And so having these rapid analyzers, having these rapid test kits will give us an answer right there and then so that we're able to properly treat our clients, and then we can do further testing and further checkups with our patients. All this will help to improve your patient care and have your patients coming back to you. Now, all in all, we also do PPEs and medical supplies like your gloves, both latex and nitrile, fetal Dopplers, disposable gowns, pulse oximeters, blood pressure machines, syringes, as you can see listed here on our slide. Now, we won't be able to say everything today or go in depth, but if you do have any further questions, you can contact us at the numbers listed here. You can visit our website or you can follow us on IG. I thank you.
Thank you so much to Recharge Distributors for giving us some more options with treating our patients with vaginitis. Because as we know, this is a very common thing, as Dr. Watson mentioned, most of our practice is going to be vaginal infections, and giving them options such as a 3-day course instead of the weekly and 5-daily is also very much well required and appreciated. So our next presenter is Dr. Scott Sullivan. Dr. Scott Sullivan did his medical training and residency at the University of Louisville School of Medicine. He obtained a master's in clinical research as well as doing a maternal fetal medicine specialist through 2003 to 2006 at the University of South Carolina. He rose the ranks from a clinical instructor to assistant professor to now to professor at the University of South Carolina, and is currently the professor of medical education at the University of Virginia. He's also the maternal fetal medicine system director at Innova Healthcare. Dr. Sullivan has been active in many organizations, including the South Carolina Obstetrical Association, South Carolina Medical Association, the American Medical Association, Central Association of Obstetrics and Gynecology, but through and through, he's one of our own. He has been active in the American College of Obstetricians and Gynecologists since 2001, from being on the scientific program committee to doing patient safety committee, numerous committees and subcommittees, eventually becoming a scientific chair, becoming active in the District 4 as treasurer, secretary, and he currently holds the position as our vice chair of the District 4 of the American College of Obstetricians and Gynecologists, and is currently our chair-elect for the next term. He has received many presentations and research awards, including the American College of Obstetrician and Gynecology's top research star in 2012-2013. And we all know that being commended by your peers is one of the highest accolades you can get. And he received the District Chair's Section Award from his fellow chairs in 2016. We are honored and privileged to hear from Dr. Sullivan today as we hear on his presentation. Dr. Sullivan?
Well, thank you for this invitation to speak at this very exciting meeting. I think if this type of joint venture really capitalizes on a shared interest in our district and aids in networking and collaborating and a joint education. So I'm honored to be joining you at your meeting virtually. I'm the Director of Maternal Fetal Medicine at the Inova Health System in Northern Virginia, and also a Professor of Medical Education at the University of Virginia. I'm also the Chair-elect of District 4, so I hope this will be the first of many times that I get to join your meetings. And we're going to be talking about maternal mortality and particularly its association with maternal hypertension. Advance the slides here. I have no conflicts to disclose. So maternal mortality, we're going to give an overview update on the data regionally and internationally. Of course, we'll talk about what we might do about it, and of course, how hypertension plays a role and what the treatments might be. So historically, giving birth has represented a risk as long as there's recorded history. The Egyptian god of pregnancy was their most deadly animal, the hippo. Hippocrates wrote a treatise on it. And in Rome, the word Caesari, which means to cut, where we get the phrase Caesarean section, was a law about how pregnant women who died were treated, how their bodies were buried and not prepared, and for some odd reason, the babies were removed post-mortem and buried separately. And that's where we get the phrase Caesarean, not from Julius Caesar as it is sometimes thought. And of course, all the way up to last month, some very high profile like cases of maternal deaths that have been in the news, including Dr. Irving and the Olympian who died last month, which are just sear in the consciousness that this problem is everywhere and is a ever-present problem right up to right now. So that the definition of maternal mortality, death during pregnancy or within a year of postpartum, and has been also broken down further into pregnancy-associated mortality and pregnancy-related mortality. We've had a problem with data for years, confusing definitions, historically underreported. There have been multiple efforts to improve this, including the updating of death certificates to include a pregnancy checkbox, which definitely improved our data capturing. The previous work had indicated that using codes or databases seriously underreport maternal mortality, somewhere between 20 and 90%, which is really staggering. Internationally, the world maternal mortality ratio is somewhere around 200 per 100,000 live births. That's over 800 women a day. And it does seem concentrated in a few countries, and most are avoidable. somewhere between 60 and 78% are thought to be preventable. Worldwide, there has been nearly a 40% decrease in maternal mortality, which is encouraging, although in some countries, including in the US, that is not true. Here's a snapshot from the World Health Organization showing some of the hotspots. While that might look reassuring for the US and Europe, certainly in the US, our rates continue to rise, which is very concerning. There's multiple causes, of course. Maternal death is an outcome, not a diagnosis. Hemorrhage, infection, DVT, VTE, and of course hypertension, which is one of the focuses of this talk. It's estimated that hypertension causes between 10 to 15% of maternal mortality worldwide. Of course, there's underlying causes too, social determinants of health, political problems. Some of the countries with the highest rates of maternal mortality, like Syria, Afghanistan, Libya, also have civil wars and disruptions in traditional social services and healthcare. Around the world, not having a skilled attendant at birth. Of course, we think of midwives, OBGYNs, but in some countries, this may just be a person with experience, a village elder, a lay midwife, if you will, without formal training, but just having somebody who has some experience, can triage, can call for help, can often make a big difference. Women who have a birth alone or just with family members have a significant increase in maternal death. And of course, no single magic bullet worldwide, but there is has been a global effort to decrease deaths through diplomacy, aid, contraception, birth spacing, training, the availability of Cytotech, and of course, education and research. I mentioned in the US, we've, over the past 120 years, it looks pretty good. We've gone from a ratio of nearly 900 to much lower to about 25. However, over the past 25 years, we've seen a steady increase in maternal death, whereas other countries have seen a decrease. Similar countries like the UK, Germany, France, Canada, the US remains quite an outlier in this. And again, multifactorial, might be due to size, to disorganization, lack of insurance coverage, poverty, racism, a number of systemic factors. I gathered data for this talk. The incidence in Jamaica varies quite a bit year to year and over the last 2 decades. Certainly, we've seen a similar increase in Jamaica as we've seen in the US, a rise over the past 25 years. Argentina looks a little bit better, going down from 70 to nearly 32, but has been a recent spike. Globally, over the past 2 to 3 years, there has been an apparent spike, often due to COVID or the disruptions due to COVID. It'll be curious what this looks like in the next 5 years as vaccinations and better treatments for COVID take hold. In the US, it's also not homogeneous. If you live in, say, Oregon or Vermont, have very low rates, below 10, but if you're in Mississippi or Louisiana, you may have rates similar to other hotspots in the globe. And even in Virginia, where I practice, rates around DC are below the national average, but in the South and West, which is more rural with less care, rates are 2 to 3 times higher. Also, unfortunately, that depends upon your ethnicity, your availability to care. If you're African American, your risk of dying in childbirth is somewhere between 2 and 3-fold, which is, of course, has been persistent and shocking and really unacceptable. I sort of foreshadowed this a little bit, that all across the U.S., rates for African Americans are higher, even across socioeconomic status, as those high-profile cases would illustrate. And we're talking about mortality. It's also estimated that near misses or injuries are somewhere 10 to 15-fold above deaths. And we've seen a steady rise in reported near misses, injuries from pregnancy as well. This just shows a breakdown of timing. About a third of deaths occur in pregnancy, almost 20% on the day of birth, 20% the first week postpartum, and another third up to a year postpartum. Acog has talked about the fourth trimester, the weeks and months after birth, and this clearly illustrates a need for increased surveillance and clinical care in the weeks and months after pregnancy. So why is mortality increasing, at least in the US and some other countries? Is it better reporting? Probably not. We've probably gotten through that phase. Is our population different? Yes. We have an older, more obese, more medically complex a pregnant population. I always have to be careful with that because it sounds like we're blaming the patients, which we don't want to do. We also have increases in poverty, a lack of access to care, lack of distribution of care, racism. Clearly, in the US, we have a 450-year history of racism and lots of work to go in terms of training systems and providers in bias training and that type of thing, and rooting out systemic racism. And really, question is, are we doing enough in the OB and healthcare worlds to address this problem? And I think that remains somewhat of an open question. I'll briefly touch pregnancy-associated deaths, which include homicides, suicides, motor vehicle accidents, and overdoses. It's estimated to be at least 1/3 or half of all deaths. And this is from Utah, showing that suicides and overdoses were actually on par with our traditional medical associations of pregnancy deaths. We really haven't given this a lot of attention. There's more of a building momentum to address overdoses and violence in our healthcare system, because this is another driver of mortality. I also mentioned age. We have an older population, that age is an independent risk factor for maternal death, which might also be due to risk of becoming hypertensive or diabetic or risks like obesity. Causes by timing, if you look at hypertension, the highest risks of death from hypertension is during pregnancy and the first week after birth. And you see other types of causes, day of birth, hemorrhage, and AFE are our leading causes. So it depends on your time frame. So it is interesting that with attention and with bundles that we have made some progress in some areas. There is a decreased incidence of death from hemorrhage and infection, but increases in cardiomyopathy, VTE, DPT, and hypertension and stroke. So that's what makes this talk particularly timely. If you look at hypertension and a CVA, it's pretty consistent across the board, around 15 or 20%, whether you're talking about a live birth, an IUFD, or the unknown causes. So I've given you the bad news. So what do we actually do about this? Well, a number of things. I think there's no magic bullet, as we mentioned, but a lot of things we can do, especially when it comes to hypertension. Of course, we need better data in every location. We need a comprehensive review of deaths. We need protocols and treatment bundles. We need earlier intervention with aspirin, with antihypertensives. And of course, we need good healthcare coverage. I mentioned MMRC in the US, at least, that there's been an explosion in data review so that each locale can have a better sense of what they're dealing with. I helped start the one in South Carolina and shared it. And so our report showed that our biggest problem in South Carolina was hemorrhage and infection. And in fact, with hypertension, we were doing a reasonable job. So we focused our training and education on those two drivers. Other states and other locations, that might not be true. And the CDC in the US has been a good partner for this and publishing a lot of guidelines for localities and hospitals to improve the care. The AIM project, the Alliance for Mortality project, many states have adopted this and shown, at least in some states, you can really make an impact in maternal mortality if you take a systemic approach. This is the California data. So how about hypertensive diseases in pregnancy, which includes chronic hypertension, gestational hypertension, and preeclampsia? We have seen increases, at least in the US, of all of these diagnoses over the last 10 years. And that's one of the reasons why mortality from it is increasing. Your risk of death, if you're diagnosed with any of these, is significantly higher if you have chronic hypertension or gestational hypertension, or if you have any of these. And we also know being diagnosed with any of these sets you up for a lifetime risk of cardiac risk, of stroke, and early mortality. So what are some things that are evidence-based that help reduce a risk of death or injury? Of course, aspirin prophylaxis. We now know that taking 1 or 2, it's controversial how much, but from around 12 weeks to 37 weeks has been shown to decrease preeclampsia by around 15 to 20%, as well as low birth weight. But we also know that this is not universally adopted, and patients are not always on board with doing this, but that is an important intervention which we should be discussing with our patients. Home blood pressure monitoring, it's never been easier. You can get a cuff very inexpensively. A lot of insurances will cover it, and patients can do it with a push of a button. It can either be linked to a smartphone or other type of device. So monitoring at home allows us to keep a closer watch on our patients than we could have previously. Of course, keeping patients a minimum below this severe range, 160 over 95. We also know that long-term keeping them below 140 over 90 also has benefits long-term, but in terms of the risk of death, stroke, CVA, IUFD, giving acute treatment when they're in severe range is very, very important. I have a slide about acute treatment in a moment, but data would indicate that treating within 60 minutes, ideally even within 15 to 30 minutes, does reduce morbidity and mortality. Of course, don't forget about magnesium for seizure prophylaxis when indicated. And thankfully, none of us at our practices or hospitals have to reinvent the wheel. There's a number of good maternal bundles for hypertension treatment. I mentioned California. Acog has them. AIM has them. They're free, downloadable, easy to access. So there's no need for every hospital to have their own. You can take what's published, what's evidence-based, and modify it for your own use. And of course, don't forget postpartum, as a third of deaths do occur in the first week or months after pregnancy. So seeing patients back sooner, 1 to 2 weeks, rather than the traditional 6 weeks, and following them up longer term is also important to reducing death. Of course, equitable care. We all know that that there's too much inequality, too much racism worldwide in terms of the high performance and quality delivery of healthcare, and it's incumbent on all of us as leaders to work towards more equity in healthcare. So, as mentioned, here is a well-known nomogram from the CMQCC, which shows how to triage acute hypertension, whether it's in the emergency room, whether it's in triage, L&D, or even if someone's calling you from home, of how quickly to respond, how to monitor, and how to respond. First-line agents, at least in the U.S., it's not the only agents by any means, but labetalol, hydralazine, and nifedipine have a good evidence base, good safety profile, and again, good evidence essentially that you can just distribute to your team. Here at Inova, we've had this really be nurse-led because oftentimes they're in the front lines, and that they can initiate a treatment as the physician's on their way, being notified and coming to ultimately manage care, but to not create a situation where there is a delay in treatment as information is being relayed across teams. I mentioned racism. This isn't going to be solved in a year, as it's been hundreds of years in the making, but it's very, very important that we recognize that this plays a role in maternal mortality and in rapid treatment. The U.S. has a number of initiatives, as I mentioned, that you can go and download and browse and really get all the resources you need if you're interested in bringing something home locally. One of the frequent things you hear from African American patients is that their complaints, their phone calls, their reports to healthcare providers were either ignored, minimized, explained away. So it's important that we all be aware that if we have an African American patient who has hypertension or has a complaint, to redouble our efforts to be responsive and to recognize that they are at risk, and that we need to be acting as if everything that is reported should be considered for action. So again, at the individual level, what are things we can do? I think, again, use of aspirin prenatally, involving cardiology prenatally for patients who are at risk, echocardiograms, looking for signs of cardiomyopathy, signs of trouble before they happen, good communication between teams, advocating for more research, more funding, adequate pregnancy spacing, postpartum programs, QI projects, research, and of course, one patient at a time. I think there's no magic bullet in terms of how we're going to tackle the mortality crisis. And I mentioned hypertension, as important as it is only 10 to 15% of the puzzle. So we can't stop there. We have to continue to look at hemorrhage and suicides and overdoses at the local, regional, national, international level. That's ultimately how we're going to respond. And we absolutely have to. If we saw how people responded to COVID with funding, with energy, and I hope that we can see a similar international effort on maternal mortality. Well, thank you very much. This is a picture of a young lady who nearly died in my care and who needed multiple surgeries, ICU stay, a team of many, many, many physicians and nurses who pulled her through. And every year she brings her young one by for what she calls her new birthday. And it always is a celebration. And one happy ending here. But as FDR said many years ago, when faced with a crisis, above all, we should do something, try something. So I blew through a broad range of topics, but I think as all of us, we should try something and try to bend this curve. Happy to take any questions after this is played. And again, I hope you have a fantastic meeting. I'm honored and pleased to be invited and hope to see you soon, both virtually and in person. Thank you all very much.
Thank you so much, Dr. Sullivan, for such an extensive and comprehensive presentation. Maternal mortality is truly something that has been plaguing all of us, both in developed and developing countries. And so we definitely have learned a lot during your presentation, and we will aim to try something and definitely do something to help save the lives of our women. I believe we have a question for you. One moment, please.
Thank you. I wanted to ask a question. I've missed it, but in terms of women with hypertension in pregnancy, right, and using the lower threshold that is being proposed, what has your experience been with using the threshold of 135/80 for your pregnant woman, and the pregnancy outcome in terms of mommy and baby at the time of delivery?
Thank you for that question, and I hope you can hear me. It's an excellent one, and of course we're all adjusting to the new numbers, and I think what we've learned from the research is that it is beneficial in terms of improved outcomes, but it is a little bit harder for both us and the patients because it's a tighter therapeutic window. So we obviously don't want to overshoot because patients can have side effects, or we don't want to make them hypotensive, of course, and they're more likely to not take their medication if they're not feeling well, or those types of things. So it is a little bit of a challenge, but I think that data is fairly clear that the outcomes are better, and so it behooves us to, I think, be more aggressive on the day-to-day and the routine visits. But just being honest is that it is more work. I think it's one of the advantages of home blood pressure monitoring, because patients can message you in the EMR or bring their log in, and so it's a little easier to adjust than it was when we were checking it once a month or that type of thing. So I think that helps us in that endeavor, but it is more time intensive. It's a little bit more like taking care of a diabetic patient, honestly.
Thank you, Dr. Sullivan. I do agree. It is quite a challenge to achieve that new threshold, but we work on it.
Towards it, for sure. I believe there is one more question from Dr. Carpentier. Would you like to unmute and ask your question, Doc?
Yes, no, I only would like to congratulate Dr. Scott. Excellent presentation as usual, and the best closing message at the end with your son. I think that's the best message that you could deliver for the care of our patients. Thank you, Scott.
Thank you very much, sir. Thank you very, very much. We're all in this together. Every one of us who sees patients has a role to play, and especially us in Acog in terms of researching, of educating patients, and really at our individual hospitals in instituting safe systems. It really is in our collective hands, essentially, the solution to this, although it's very big, very complex.
but I really do believe that that we can turn this around.
Thank you so much, Dr. Sullivan. We have one more question for you. We have a question regarding the pharmaceuticals, use of pharmaceuticals in management of hypertension in pregnancy. Particularly, this person would like to know about your views when it comes to medications such as Aldomet or methyl-dopa and labetalol in the management. And which ones do you recommend?
Absolutely. I think one thing that I try to stress is that even though labetalol and nifedipine and hydralazine have gotten a lot of attention, California protocols and Acog is they're not the only ones, right? For some patients, they may have benefit from something else, like a Norvasc or even rarely a diuretic. And of course, Aldomet, the issue with Aldomet a little bit is twofold. One is it oftentimes has more side effects than say a labetalol or a nifedipine. And it's also, at least in the US, there has been shortages and at times where you couldn't really reliably get it. So it has somewhat fallen out of favor because of that. But it's still reasonable. If a patient came to me on something other than the big three, I call them, if they're well controlled and they're tolerating it, then I wouldn't change them, unless it was one of the few that say, like an ARB or an ACE inhibitor, something that's like actually dangerous. If it's something that's a little different and it's safe and effective, then I wouldn't change them. Now, labetalol works quite well across the widest spectrum. It's well tolerated. One of the reasons I like it is it has a broad therapeutic window. For some people, 100 or 200 milligrams will do it. And some patients, you might be 800 or 1,000. And so as people go through second and third trimester, you can really adjust it well for some people. And the risk for things like IUGR and other things very, very, very low. Not impossible, but low. So labetalol is one of my favorites. But Aldomet still in play if you can get it. And if somebody isn't tolerating the other ones, it's still fair game. Thank you for that question.
Thank you for your response, Dr. Sullivan, and thank you for participating in this conference today. Our next sponsor is going to be Square Distributors Limited, and I believe they're going to be mixing things up a little bit today. So could you proceed?
Ladies and gentlemen, I am Tamara Melville, and I'm the country manager for Square Pharmaceuticals, and we are proud to be one of the sponsors for this Acog inaugural joint meeting. So, our tagline at Square is quality squarely targeted, and it represents safe and efficacious products that we bring to market. And Square Pharmaceuticals is distributed out of R.A. Williams. So I am encouraging our listeners to listen keenly to the presentation, because I have two lovely baskets that we are eager to give to the two winners at the end of the presentation. So I'll start off with just a brief introduction to Square Pharmaceuticals and showcase two of our products, our Zymax and Ceftron. All right, so Square Pharmaceuticals is manufactured in Bangladesh, which has a population size of about 168 million. They proudly produce 98% of their pharmaceutical needs, and for a population of 168 million, that is pretty an impressive feat right there. We only high quality players can have a presence in Bangladesh, which creates an ecosystem to put in place the best technology practices in the industry. And Bangladesh was actually the first country to introduce generic versions of COVID-19 medications. All right, so Square Pharmaceuticals is actually the largest pharmaceutical company in Bangladesh, and it's among Bangladesh's leading conglomerates, holding this strong leadership position since 1985. And we're on our way to becoming a high-performance global player, and we currently export to over 42 countries. So this slide shows, you see we are currently exporting to 4 continents, and it shows a list of some of the countries that are on our export list. So all of our manufacturing units have SRA and GMP approvals, from bodies such as in the US, the FDA, and in England, the UK MHRA. So really this speaks to the quality, the high quality products and the stringent regulatory authorities that have approved our plans. So the global mission at Square, the logo, our company, it represents, Square symbolizes today a quality, a state of mind, perfection and equality. And we produce and provide quality and innovative healthcare relief by maintaining stringently ethical standards to our stakeholders and society. All right, so our newest product to the line, which is our antihistamine with excellence, is our Fexo suspension. So I know that we have a diverse audience today, and therefore for our nurses, our doctors outside of our ONGs, and also for our doctors who do have children and friends, we have our Fexo suspension, and it is the active ingredient is fexofenadine hydrochloride. Some of the advantages to our Fexo suspension is that it is raspberry flavored, non-drowsy, and 12-hour relief. So I'm going to show the video after on our Zymax and our Ceftron. So our Zymax is our azithromycin, which is available as a 250 milligram capsule and a 500 milligram tablet, and also 15 ml and 30 ml suspension. It is a category B drug, so it's safe for treating your pregnant mothers with chlamydia. And we also have our Ceftron, which is our ceftriaxone injection, available as 250, 500 mg, and also 1 gram, which is safe to treat your patients with gonococcal infection. So I will play the video, and after I will come back to give the questions. All right, so ready for the questions? I'm going to ask you to raise your hand. And what do we do, Sam? If it is that they enter the contact?
Yeah, so just answer in the chat. I'll announce if you win. This is sponsored by the Betting Gaming and Lotteries. And after you have won, I'll ask you to just send me, the host, a direct message to say this is your contact number and name so I can share it with Tamara, who will reach out to you and get your winnings to you. All right? So question uno, because we are bilingual today.
Okay, so Square Pharmaceuticals, we also distribute consumer goods. So there are Square hand washes in there, as well as we have our Nebanol ointment or neomycin ointment, as well as other goodies. So the first question is, where is Square Pharmaceuticals manufactured?
I know. All right, so the first person, do we all agree this is the first answer? All right, Aliyah Davis. Woo! Congratulations.
Congratulations, Aliyah.
Wait, Aliyah, you can't win. You're on the panelist. Oh, shh.
Sorry, Aliyah.
Therefore, Tanifa Bahari, you are the winner of the first giveaway from Square. Your answer is correct, Bangladesh.
Correct, Bangladesh. So we will get in contact with you and personally deliver it to you, Tanifa
Behari. Dr. Behari.
Okay, congratulations, yes. Dr. Behari. All right, so ready for the second question?
Yep, let's go.
It's a two-part question. Which list or name the strength.
Oh, sorry, that didn't come in. Something with the microphone. Ask again. Let me hear.
All right.
No, let's change the microphone. Can we borrow this mic right here? Sorry, guys. And go ahead.
All right. Two-part question. And
yeah, man, go ahead. I'm here. Two-part question.
Two-part question. So which pharmaceutical options are available from Square to treat chlamydia, and what are the strengths available?
All right.
So the name of the product and the strengths available. Tip, there are four options options available, presentations available.
All right, I have some options here. Is Zymax correct?
Correct, Zymax.
Is 500 milligram tablet correct?
Correct.
250 ml capsule.
Correct.
15 ml and 30 ml suspension.
Perfect. Congratulations,
this
Dr. Jackson.
This person uses ChatGPT. Dr. Damian Jackson, congratulations.
Doc. So we will have it personally delivered. I want to provide us with your contact information. And thanks from Square Pharmaceuticals for going to share about our products and our company with you. Have a good evening.
All right, thank you very much. All right, so we're heading back over. Thank you, Square. And back to Dr. Bridgewater.
Square Pharmaceuticals for certainly targeting this audience squarely, giving with giveaways. That's one way to get doctors' attention, as we can see. Now, we know it's been a long day, and as much as it has been informative and engaging, we know you must be tiring. But don't worry, we saved one of the best aspects for last. This is going to be one of the most intriguing parts of this presentation because it is not something commonly done at conferences of this nature. And this is going to be our Stump the Professor this year. This is a platform in which we have resident bodies present different cases and to have didactic information, but also information and discussions to bring about the main points regarding these diagnoses and the management for these patients. It is proving to be a very riveting way of learning, and so we hope that you will benefit from it today. Today, we're going to have two teams. We're going to have the West Indies chapter team as well as the Argentina team, and they are going to be spearheaded by our current vice chairs, respectively. We are going to have Dr. Jordan Hardy, who is our current vice chair of the West Indies chapter, who will be leading our West Indies group. Now, regarding Dr. Hardy, this handsome fella to my side here. He is a homegrown obstetrician and gynecologist, having done both his undergrad and postgrad at the University Hospital of the West Indies, Mona campus. He completed his MBBS in 2008 and his Doctor of Medicine in ONG in 2014. During his training, he has rotated through many hospitals, seen many diagnoses, and is certainly apt to lead our team today. He has done many research, including one on the endometrial thickness of premenopausal women with abnormal uterine bleeding, and particularly a 5-year mortality review of causes of maternal mortality within our country. So, of course, he was particularly keenly interested in Dr. Sullivan's presentation prior to the last sponsorship one. He's an avid football fan and family man. He is very charismatic and an advocate for women's health care. He is going to be leading a group of residents that he will then further introduce. On Team Argentina side, they will be led by Dr. Gustavo Letero. Dr. Letero did medical school at the University of Buenos Aires. He did his residency at the Hospital Zona General de Agudos Abita. He is current where he was the chief resident between 2001 and 2002. He has specialist recognition as a specialist in obstetrics and gynecology in Buenos Aires, Argentina, and many other places. He is currently also a specialist in clinical sexology and a professor at the University of Maimonides. So Dr. Letero will be leading Team Argentina. Unfortunately, Messi has left to go to the States, so you're on your own, but I'm sure you are more than capable of leading the team. And Dr. Hardy will be leading Team West Indies. So you guys can further introduce as we look forward to this awesome experience.
Quick interruption. Can everybody in the chat just let me know? Can you hear me? If you can hear me, just put 2s in the chat. Okay, seeing the 2s. Thank you very much. Ready for this exciting discussion.
So today has been a very long day. Thank you for everybody who has been here and is still with us. So as a part of our discussions with the joint inaugural West Indies and Argentinian Acog conference, we wanted to have something that involved the residents and also increased resident engagement. So we decided, as opposed to the typical stump the professor where you would direct questions at the professor, but the residents will be actually asking questions of each other and we will be guiding them. And we are hoping that this will continue to increase resident engagement across the district and the region, and both teams after the games will be able to reach out to anybody who was here. So presenting for the West Indies team, Dr. Rachel Matthews is a 2018 graduate of the University of the West Indies with a bachelor's degree in medicine and surgery, and is currently a medical officer in the obstetrics and gynecology service at the Maypen Hospital in the Southern Regional Health Authority. She also has a WHO certificate in adolescent sexual and reproductive health. Her most recent academic achievement was the presentation of her research work, the case that she will be presenting today, at the prestigious Royal College of Obstetricians and Gynecologists World Conference in June 2023. So yes, Dr. Matthews is well-traveled. She has a particular interest in sexual and reproductive health promotion, education, and research, and aims to pursue a career as a sexual health medicine specialist and obstetrician and gynecologist. This has led her to start a passion project called All Things Women that offers sex educational workshops and empowers women and girls on information in sexual and reproductive health. Yeah. Yes.
Dr. Matthew, please go ahead and talk to us. There you go. Have the same hairstyle. Let's unmute first. There you go.
Awesome. Good afternoon, everyone. I am Dr. Rachel Matthew. It's a pleasure to be here, and thank you for the opportunity to present. I will be presenting on a very rare medical condition that affects monozygotic twins, and that is twin reversed arterial perfusion sequence, abbreviated TRAP sequence. The case report is entitled The Misdiagnosis of Twin Reversed Arterial Perfusion Sequence, and the authors include Doctors Angela Rankin-Mullins, Ryan Halsall, Alit Heman-Skeen, Darrell Daly, Vincent Williamson, and myself, Rachel Matthew. The case involves a 27-year-old prima gravida with no known illnesses who was referred to our service with an ultrasound showing 2 gestational sacs, one containing a live fetus at 11 weeks, and another with a 2.5 times 2.3 centimeter heterogeneous mass. To your right is the ultrasound at 11 weeks. The red arrow shows the heterogeneous mass, and there's no obvious cardiac activity. And the yellow arrow shows a normal twin A and a red dot that indicates cardiac activity.
Hi, Doc. We're not seeing to your right. So we're going to ask you to share the screen.
Oh, okay.
It's all right.
So just to be clear, you weren't seeing my screen all this time?
No, we thought you were introducing
Oh.
something. We didn't know it was a presentation.
All
So
right,
we
I'm
weren't seeing
trying
the
to
screen.
figure out share screen.
Yes. Yes.
All right. Sorry
Perfect.
about that.
No, it's totally fine. All
All right,
right,
let
so
me
let's
go
click
back.
where we see all tools there. Can you just click on that X beside it for me?
All tools.
To the left, that column, all tools, and then you have export a PDF. There's a little X right above that export a PDF, so we can see it full screen. Not seeing it. It's all right. Go ahead, we can see.
All right then. See the full screen?
Yes, twin reverse arterial perfusion, TRAP sequence.
Yes. So let me start over. So we'll be presenting on a very rare medical condition that affects monozygotic twins, and that is twin reversed arterial perfusion sequence, abbreviated TRAP sequence. And the case report is entitled The Misdiagnosis of Twin Reversed Arterial Perfusion Sequence. The authors include Doctors Angela Rankin-Mullins, Ryan Halsall, Alit Heman-Skeen, Darrell Daly, Vincent Williamson, and myself, Rachel Matthew. The case involves a 27-year-old prima gravida with no known chronic illnesses who was referred to our service with an ultrasound showing 2 gestational sacs, one containing a live fetus at 11 weeks, and another with a 2.5 times 2.3 centimeter heterogeneous mass. To my right is the ultrasound at 11 weeks. The red arrow shows the heterogeneous mass in which twin B is in, and the yellow arrow shows a normal twin A, the red dot indicating cardiac activity of twin A. Subsequent ultrasounds at 20 weeks reported a cystic hygroma of a demised twin B. Another ultrasound at 29 weeks and 4 days showed that twin A had a prominent right atrium, and there was a 22 times 14 times 16 centimeter mass containing the demised twin B with severe polyhydramnios. At 30 weeks and 1 day, patient reported symptoms of anemia, which included shortness of breath, palpitations, headaches, and generalized weakness. At this gestational age, the latest ultrasound which I just presented was reviewed, and due to its alarming findings that showed polyhydramnios of more than 30 centimeters, and the fact that the mass was obviously increasing in size, as well as a live twin having a prominent right atrium, the patient was admitted to the maternity ward. On admission, she was normotensive, afebrile, however tachycardic at 110 beats per minute. Mucous membranes were pale and moist. There was a fetal heart within normal ranges. Significant physical exam findings showed that she was obese. There was a symphysis upon a height of 40 centimeters and marked fetal edema. A complete blood count showed that the hemoglobin was 7 grams per deciliter. During admission, she was given corticosteroids, blood transfusions, and thromboprophylaxis. Just to add, a diabetic screening was done and it was negative for gestational diabetes. On day 4 post-admission, she was sent to the maternal fetal clinic at a type A facility. Ultrasound done there showed that twin A had abnormal umbilical artery Doppler studies. And the plan from that clinic was for internal amnioreduction, repeated growth scan with Doppler studies, and admission to that facility in a week. On day 5 post-admission, unfortunately, there was difficulty auscultating the fetal heart, and as such, ultrasound was done and confirmed that twin A demised. As such, a decision for cesarean section was made once the hemoglobin was well optimized. So on day 7 post-admission, cesarean section was performed by consultants, and twin B was found to consist of an irregular mass with lower limbs only, and a diagnosis of trap sequence was made. I want us to turn our attention to figures. Figure 4 shows the twins. To the right, to the left, sorry, is the normal twin, which is a pump twin. And to the right is a figure 4. We see the acardic twin. There's no obvious head or torso or upper limbs. There is a bowel there extruding from the anterior abdominal wall, and the only thing that's recognizable is the lower limbs. So that blob of tissue is the heterogeneous mass that was seen during ultrasound. And to your right is figure 5, the placenta that the twins shared. There were no post-cesarean section complications. So on day 10, post-admission, patient was discharged from the ward with date for postnatal clinic follow-up. The discussion. So twin reverse arterial perfusion sequence, or TRAP sequence, is an extreme case of twin-to-twin transfusion. It occurs in 1% of monozygotic twins and in 1 in 35,000 live births. So in this type of condition, it comprises of a pump twin, which is structurally normal, and an abnormal, non-viable acardic twin, which is otherwise kept, quote unquote, alive in utero as it receives blood that is pumped from the umbilical artery of the pump twin through the intrafetal anastomosis seen on this diagram that I'm pointing at, the simplified diagram that I'm pointing at, and that deoxygenated blood, some of the deoxygenated blood goes to the abdominal aorta of the acardic twin. And as such, the lower limbs of the acardic twin are well more developed than the upper torso, the upper limbs and the head. TRAP sequence is considered when there is no cardiac activity or lack of normal cardiac structures in a twin. The diagnosis is made definitively when Doppler studies show reverse pulsatile flow to the acardic twin. And as such, early diagnosis is important for weekly ultrasound surveillance, especially for signs of cardiac failure of the pump twin. So again, we have some diagrams. Figure 2 shows cystic hygroma of twin B, and figure 3 show the fetal skulls of the twins. The red arrow, the fetal skull of the normal twin A, and the yellow arrow shows the homogeneous mass that surrounded the fetal skull of twin B. These are my references. Thank you very much for listening.
Thank you so much, Dr. Matthews, for that very interesting case. And at this point in time, I'm going to invite the residents from Argentina to ask you a few questions before we open the floor.
Okay, congratulations. It's a very, very interesting case.
Thank you.
So, good afternoon, everyone. As you mentioned, I'm Gustavo Literio of Acog Argentine section. It's a pleasure to participate in first showing meeting between the Argentine section and West in this section. Welcome to all Argentine and Jamaican residents that will participate presenting two clinical cases. So first, I would like to introduce Dr. Juliana Fernandez, Junior Fellow Vice Chair of Acog Argentine section, who will present the clinical case, and Dr. Gala Serafini, Chair of Junior Fellow, and Dr. Mariela Ladino, Chair of Young Physician, who will make some questions to the Jamaican resident about their clinical case. Okay, Juliana, are you ready?
Yep, we're seeing it. Okay, perfect. Liver disorder and pregnancy.
Well, hello everyone. My name is Juliana Fernandez. I'm fourth-year resident from Narciso Lopez Hospital and the Junior Fellows Vice Chair from Argentine section. And this afternoon, I'm presenting a case report on liver disease. Sorry, I can't page. Okay. Well, let's review the definition. As we know, intrahepatic cholestasis of pregnancy, also known as obstetric cholestasis, we see at the presentation as ACMP, is the most common pregnancy-specific liver disease. It is presented in the third trimester with pruritus of the palms and soles, abnormal liver functions, and raised serum bile acid levels. In this clinical case, the patient is a 34-year-old pregnant woman with 3 pregnancies and 2 miscarriages. She is Latin American, and she refers her sister and mother as an important family history, which were diagnoses of obstetric cholestasis. At 13 weeks and 3 days, she consults at American unit for presenting bleeding for the vagina. She was admitted to the hospital due to threatened miscarriage. She referred to us as recent diagnosis of obstetric cholestasis at 8 weeks in treatment with ursodeoxycholic acid 300 every 8 hours. So we ask, it's possible of being this diagnosis cholestasis at 8-week pregnancy? The answer is no. Because of that, we don't agree with the diagnosis and we suspend the treatment. We consult a medical clinic who indicate loratadine due to the itching, and we performed an hepatobiliary pancreatic ultrasound that was normal. During the hospitalization, a serial laboratory was requested to control liver functions, which observed clinical improvement and decrease in hepatic enzymes, so we decided medical discharge and follow up by high-risk obstetric clinics. During the controls, liver functions continue to be evaluated, maintaining normal values. But at 20 weeks, she recurs with itching and soles and palms, so she attends the emergency unit. The last lab results were bile acids 112.2, so we come to the conclusion with a diagnosis of obstetric cholestasis and indicate ursodeoxycholic acid and diphenhydramine for the itching. We repeat an hepatobiliary pancreatic, which is normal, and growth scan with Doppler studies normal too. After starting the treatment, we noticed an improvement in the patient clinic and a drop in liver enzymes, so we gave her medical discharge. She continued her checkup in a high-risk obstetric clinic and with a liver specialist who ruled out other cases of liver disease as Acog recommends. But at 33 weeks, she returned to the emergency unit due to worsening symptoms and increase in bile acids. Medication could not be increased because she was already received the maximum dose. We indicate dexamethasone for fetal load maturation, and on 4 days post-admission, the symptoms worsened even more, with an increase in bile acids. And we decide an elective early delivery because no response to the treatment. What does Acog recommend about it? It recommends the administration of antenatal corticosteroids for fetal lung maturity for patients delivering before 37 weeks of gestation is not previously administered, so it was okay. And they recommend delivery between 36 and 39 weeks of gestation for patients with ACP and total bile acid levels of less than 100. But delivery between 34 and 36 weeks of gestation can be considered in women with obstetric cholestasis, with excruciating and unremitting maternal pruritus not relieved with pharmacotherapy like our patient. Obstetrical outcomes were successful and postnatal clinic follow-up too. We ruled out a suspicion of autoimmune hepatitis because the antibodies were all negative and hepatograms returned normal after delivery. To sum up, we have a case of cholestasis with very early symptoms. Therefore, we finally conclude that although intrahepatic pregnancy cholestasis appear during the 3rd or 2nd trimester, it should also be without it can appear in the 1st trimester. So we must consider to individualize the decision for every patient. Thank you all for your attention.
Congratulations, Juliana. Thank you.
Okay. Thank you so much for such an interesting presentation. We're going to invite the Argentinian team to ask some questions of Dr. Matthews.
Okay.
Hello.
Mariela?
Yes, hello everybody. I'm so sorry for my voice today. I'm really sorry. I'm the physician chair from Argentine section, and I really want to congrats Jamaica and Argentina residents who present the cases. They were really interesting. And I want to ask, what are the prognostic factors of the trap sequencing? To Dr. Matthews.
Okay then. The prognostic factors I'm about to mention contribute to the poor prognosis. So these include severe polyhydramnios. So in our case, we saw where the patient had an AFI of more than 30 centimeters, where there are signs of cardiac failure of the pump twin, where the weight of the acardic twin to that of the pump twin is more than 0.7 or more than 70%. In our case, the pump twin weighed 1.4 kilograms and the acardic twin weighed 6 kilograms. So it was more than 4 times, the acardic twin was more than 4 times the weight of the pump twin. Another prognostic factor is wherein the acardic twin upper body is very much more developed. And lastly, where there's preterm delivery before 32 weeks. So these are the poor prognostic factors involved in trap sequence.
Thank you. And another one, sorry, what do you want to say?
I just wanted to add, so we see here that when the patient was admitted to the maternity ward, she already came in with poor prognosis because she had many of those poor prognostic factors already on admission.
Thank you. And what are the treatment options for the trap sequence?
Okay, so before I name the treatment options, there are no sources that point out whether one treatment option is more superior to the other in preventing complications during those procedures, such as premature rupture of membranes. Neither is there one treatment option that is seen to reduce the perinatal mortality of the pump twin more than the other. And so some of the treatment options that are available include radiofrequency ablation, fetoscopic laser surgery, ablation with alcohol or microwaves, or high frequency ultrasound. Now the goal is for all of these are similar, and that goal is to disrupt or destroy the intrafetal anastomosis that I spoke about. And in destroying the intrafetal anastomosis, the acardic twin is no longer a parasite to the pump twin. However, there are no sources that tell us when exactly in the gestational age that these medical interventions should be done, and there is not much clarity as to when to implement the medical interventions versus conservative management. So those are some drawbacks.
Thank you, Rachel. And the last one I want to ask is, what was the conclusion drawn from this case report? What do you think?
Well, the conclusion is that when there is an abnormality seen in a twin, that trap sequence diagnosis should be considered. Ultrasound with Doppler studies should be done, and MFM, maternal fetal medicine referral, should be made right away.
Okay.
Thank you. Thank you so much.
Rachel,
Thank you.
do you have any question for Argentine resident?
Thank you. So,
no, I don't.
On behalf of the West Indies team, Dr. Clark, who is a fourth-year resident in our DM program, will be asking some questions of the Argentinian team.
Hi, Argentinian fellows, junior fellows. Okay, so our first question for you guys. Could you tell us what Acog says about the gestational age to diagnosing intrahepatic cholestasis of pregnancy?
So, hi everyone. Congratulations for the West Indies team. I'm Gala Serafini from Argentine section, actual junior fellows chair. Acog says that the typical presentation of ECP occurs in the third trimester, but up to 80% of women presented after 30 weeks of pregnancy. But it's important to mention that some patients present symptoms as early as in the 7th week. This is more common in multiple pregnancies, advanced maternal age, and family clusters. And there is no evidence to suggest that women who present earlier have severe disease or worse maternal and fetal outcomes. The diagnosis is usually confirmed after demonstration of abnormal liver function test and especially higher serum bile acids.
Hi guys, Dr. Witter here from the West Indies section. So I have another question, the second of our three questions. So the second question that we have is, in terms of fetal health and assessment throughout the pregnancy, what are some of the ways that we follow up the patient to assess fetal health?
Yes, we indicate a regular cardiotography and a fetal growth scans. However, it should be noted that there are several case reports of normal cardiotocography in the hours and days preceding fetal death. So Acog said that there isn't a specific method to predict the risk of very adverse maternal and fetal outcomes or to reduce it.
Yeah. Thank you, Dr. Sarafini. Okay, and our final question.
Okay.
Based on your response for the first in terms of the diagnosis and some of the risk factors, what are the considerations in terms of the prognosis, postpartum prognosis for the patient? What do we usually, or what should we advise them of in terms of future pregnancies and also during the early postpartum period?
Okay. We can assess the patient to follow up lab test before pregnancy, and for the future pregnancy, we should ask them to be like aware for the symptoms to appear, you know, not to make them feel fear about, only to make the follow-ups and the checks during the pregnancy.
Okay. And what if it happens in terms of like a familial cluster? What do we do, and what additional testing should we embark on for this family that's affected?
I think the follow-up lab test may help us in every patient who develop the symptoms, but there is a lot of literature in which for family clusters specifically, there is a mutation of the transport protein ABCBCB4, but there is no specific like follow-ups for that patient. Only be aware about the symptoms and the follow-up as in every patient with itchy palms and soles.
Thank you so very much to the West Indies chapter team, as well as the Argentine section team as well, for presenting two amazing cases. Many of us have not even seen that in clinical practice, especially the TRAP syndrome. They're both fairly rare conditions, but they're so integral and so important because they can have such severe complications. So having that discussion, highlighting those cases and those conditions, greatly appreciated. And we can certainly see that we have great minds coming up in the chapter. Yes, Dr. Sarafina?
Yes, thank you. I really want to thank Dr. Francina, the immediate past chair, for her help, support, and guidance during the process, designing the clinical case report, and giving all her good energy during this process.
Amazing. I'm glad that you are a benefit of that as well. So we thank you guys for such an amazing ending to what has been a phenomenal course. We have heard from many presenters locally in Jamaica, presenters in the US, presenters from Argentina. I mean, we are worldwide today. It has been very informative and very, very applicable to our day-to-day lives. And I am sure that we are all going to take away lots of information to help our women, whether it be with maternal mortality, whether it be with regenerative vaginal surgeries and modalities. But we've learned a lot, and we will certainly not forget today. So today is the first, but I'm sure it will not be the last that we will have this kind of a conference, right? Definitely. So now I want us to just give Dr. Darrell Daly our attention as he gives us our vote of thanks and adjournment as we proceed.
Thank you, everybody. But before I give the official vote of thanks, I just think it's fair to invite Dr. Blanchard one last time just to give us some words of encouragement before we end our official inaugural meeting. Dr. Blanchard, could you share a few words with us before we wrap up, please?
I would love to. And to echo what Dr. Bridgewater said, phenomenal meeting. This was really wonderful. Congratulations to the junior fellows, the young physician presenters, really fantastic cases. Thank you to all of the presenters and all of your sponsors. This was a real pleasure to join you today, and congratulations to the Acog Argentina and West Indies section leaders for your vision and the ability to make this come together. And I think Oldgate Solutions is a wonderful partner to you all. I'm so impressed with your technologic smoothness. So wonderful to be here. I look forward to next year and hopefully connecting with you all in person. And with that, I will turn it back over to Dr. Daly, and thank you for having me.
Thank you so much, Dr. Blanchard. It truly was a pleasure and an honor to host you and for you to be present. Well, we reached that time. It's been a great and amazing day. As I mentioned earlier, the vision at dinner last year has become a reality today. So I'm grateful and thankful for all of you who stuck it up, but almost here, and we appreciate it. Without you guys, we would have no presentations. I'd like to thank our moderators, Dr. Bridgewater and Dr. Clark, for doing very well in hosting and ensuring that everything went smoothly. I'd like to give an honorary mention to Dr. Witter, who came in at last minute, and she's our junior fellow chair, for stepping in. Definitely, I'd like to thank Dr. Blanchard again, Dr. Scott Sullivan, Dr. Hardy, Dr. Gustavo, and Dr. Pablo for helping all of us coming together about 3 months ago, you know, bouncing ideas from one another so we can make it. I'd like to thank our presenters, Dr. Tiffany Watson, Dr. Medley, Dr. Gregory Lewis, Professor Ramswak, Dr. Allen Sod. Definitely big ups to Oldgate. They have been doing very well, Sam and his team. Without him, I mean, definitely everything went so smoothly today. So smoothly. Last but not least, I'd like to thank our sponsors, Spanish Court Hotel, for catering to us and facilitating us. Our title sponsor, Ferrin, for sure. They have been, I mean, we can always count on them. Medical Products, Bayer Consumer Health, Apex Radiology, Indus Life, East Health, Alta Pharma, Recharge, Distribution, Square Pharmaceuticals, Medimpex. Thank you so much. Also, I want to give a special thanks to Miss Hyacinth Smith. She has been the glue for the presentation. Without her, none of this would be possible. I just give the orders and she executes. I don't have to follow up. She has been doing this for years, and I hope she'll continue to help us as we move forward. And with that said, this is my final symposium as chair, and I have Dr. Hardy following me, and hopefully probably Dr. Bridgewater. But it's been an honor and a pleasure being the chair for the West Indies. We'll have one last meeting in October where I'll get a hug and tell everybody goodbye. Dr. Blanchard, Dr. Sullivan, Dr. Pablo, and it's truly been my pleasure. And just thank you all. Enjoy your Sunday. Meeting adjourned.